It's time, sir. You can start in time.
Yeah. So, welcome to our Cardiological Society of India and NIC third initiative, education initiative meeting. And I welcome you all the faculties, national and international, and also all the delegates. And I just want to tell you that there is a great response for the registration, and already more than 1000 registration has been done, and we have opened the link for today, and no registration is required anymore. The registration was of course all free, so we are delighted that there is a huge response, and delegates from South Korea, Japan, China, Taiwan, Malaysia, and then Singapore, Middle East countries, Europe, USA, from everywhere we have got delegates, and there is a very good response. So the inauguration will be done after half an hour. Dr. P.K. Deb, our mentor, will be inaugurating it. And I welcome you, all the faculties, the chairpersons, and the experts, and the speakers on the occasion. And it's really a very joyous occasion for us. We have done the past two meetings very successfully, and I hope that with your contribution, valuable contribution, this is also going to be a very, very valuable meeting. We have professors, we have with ex-Director General Dr. Sanjay Tyagi, Sub-Dean of AIIMS, Rakesh Shommukh Sundaram, our President, Dr. M.K. Das, President-elect, and the speaker for the next session, Dr. Mohanan. So everybody, so I tell that first speaker is none other than our President-elect, Dr. P.P. Mohanan, and he will be talking on DAPT dynamics in the management of SCS patients. And so I invite you, and this session will be chaired by Dr. P.K. Deb, Dr. M.K. Das, Dr. Anjanlal Dotto, Dr. S. Shommukh Sundaram, and Dr. Rakesh Jadhav, Professor Rakesh Jadhav. So I invite all of you to chair the session, and our speaker, nothing to introduce, he is our President-elect, and he's a very dynamic cardiologist, interventionist, and he does a lot of intervention, and he is involved with a lot of studies, and he's a very good cardiologist. I don't want to tell anything more about him because it will take 1 hour time. So I would refer the chair to Dr. M.K. Das and Dr. P.K. Deb, Dr. Dotto, Shommukh Sundaram, and Dr. Jadhav to go with the proceedings, So refer to you, sir.
Thank you, respected chair. Can I begin? Are you able to see my screen?
Yeah.
Sure, sir.
Yeah. We can see the full screen. Yeah.
Okay. Thank you. Thanks for the opportunity, Dhiman. And the advantage of a opening batsman is that all the distinguished chairs are eager to answer any question that comes out. Okay. So my job will be much minimalized by the aggressive chairpersons around. So when you talk about the dynamics of DAPT, let us begin at the beginning. We know aspirin has been with us more than 100 years. We celebrated its more than 100 years of its existence years ago.
Dr. Mohanan, I'm just interrupting for a minute. I'm sorry. Dr. Arup Das Bishwas is also going to chair the session.
Thank you.
His name was Dr. Arup Das Bishwas. Sorry, I beg to be apologized because the list which has come recently. Anyhow, so okay, Dr. Bishwas, Professor Das Bishwas, please join us in the forum.
Yeah,
Professor Das Bishwas.
Dr. Mohanan, please continue.
Okay.
More the merrier, Das Bishwas. We need more. We need more chairperson because this is a very dynamic issue, and that more the merrier. So when clopidogrel came sometime in the mid-90s, and it had a comparative study in Capri, and that showed clopidogrel being a little better than aspirin in the primary endpoints. And this was possibly the study which cemented the importance of the concept of DAPT, especially in acute coronary syndrome. Cure by Salim Yusuf and others cemented the data, giving us a appreciable reduction in MACE and otherwise even in mortality reduction. And that was the beginning of the concept of DAPT. Now, I will say that, of course, we were prior use of DAPT, but the concept and the excellent result began from CureDat. Of course, after that, we had innumerable experience and value of DAPT in STEMI, in Clarity TIMI, and the large Chinese trial Comet CCS. Of course, we should also know that we started in India, we started using clopidogrel and aspirin in SCS much before Comet SCS and much before Clarity. All of you who are treating patients will know that. We have also data which showed that the benefits of DAPT and, of course, clopidogrel in the CREO trial, even at the end of 1 year. We know how the antiplatelet drugs act. We have very many drugs available, parenteral, oral, and even otherwise. So, but then of later, see, sometime in the late 90s and 2000 and maybe the later part of 2000, we had concerns about the clopidogrel because of its now very many factors, and we have discussed it many a time. I will not go into that. There were worldwide data about the clopidogrel resistance, substantial data from India also about the increasing prevalence of clopidogrel resistance. And we should also realize the fact that in SCS, especially STEMI, the risk of rehospitalization is huge. And it's imperative that we have to use more potent drugs. The risk of not only the risk of rehospitalization, the risk of mortality persists in spite of whatever we do. So it is imperative that we have to have better drugs, and that's what the pundits have given us. The research has given us. They have given a quite lot of alternatives to clopidogrel, and the first to come was prasugrel. Of course, it has its limitation. Again, I don't want to bore you with an older data, which showed it is definitely better than clopidogrel, but at the expense of the higher bleeding. And it has some black box warning. There are subgroups of patients where you may not be using it, like more than 70 years, less than 60 kg, those with an older CVA. So there are groups of patients where you cannot use it. And of course, there were found to be of benefits in subsets of patients like STEMI, diabetic substance. It was also found that prasugrel very eminently reduces the incidence of stent thrombosis. Mind you, these were the times when we were using the first generation and second generation stents. So we needed more potent antithrombotics, antiplatelet. Then came Plateau, and it again gave us similar results to prasugrel in forms of primary endpoint reduction. But surprisingly, the bleeding rates were much, much lesser than the other compound, the prasugrel part. So it seemed that possibly the only antiplatelet drug at that time to reduce mortality was ticagrelor. Even this time, I suppose, so we had more and more data coming on ticagrelor, and mind you, the benefits of ticagrelor starting very early. So that's also very important. And consistently, the treatment effect was palpable in every subset of patients, whether it is in the medically treated one, whether it is the NSTEMI group, STEMI group, even to the extent of the post-thrombolyzed group. I will not exploit on that because we don't have any large data. We have a small data of post-thrombolyzed patients. But then what one could see was that ticagrelor was very much useful in a whole lot of patients. See, I was talking about the era of instant thrombosis earlier. That was the time when we have been worried about the ISR, basically, and also even stent thrombosis because of the earlier generation of the DES that we were using. Now today we have very safer stent platform. We have a better understanding, and that was the reason why we talk about why don't we reduce the duration of DAPT. The dynamics comes there, and the discussion on how long to continue DAPT has been vexing us for many years. We have guidelines and guidelines, but generally what we do is, at the end of the conventionally, most of the guidelines told us, you continue the DAPT for 1 year if it is not a HBR patient. Of course, the concept of HBR, high bleeding groups of patients, came only later. Now, we all know that. But generally, conventionally, every guideline told us, you continue the DAPT 1 year, then use any of these risk models, whether use a DAPT score or a precise DAPT score, or even someone may use a Paris score, and then decide if the ischemic risk is more, then you may continue the DAPT for a longer period. But if the bleeding risk is higher, you better stop it at that time. And that was the origin of the thought process of shorter and shorter DAPT duration. So we know that the dangers of prolonged DAPT duration, because it's beneficial only at the cost of increasing bleeding. That's why we have more and more data coming up. Why not a shorter DAPT? And if it is proving that we have a similar ischemic endpoint because of the better understanding, better technology, better design of the stents, better drugs available, why not shorten the duration of the DAPT to the minimum? And that's why you have a series of trials. I will not have time to discuss you with all these, but these are some of the meta-analysis which talked us about what about stent thrombosis when you use a shorter duration. It was a little confusing. There were data supporting shorter duration. There were data suggesting that stent thrombosis will be better, lesser with a longer duration. Every trial agreed on one thing. Shorter duration substantially reduces clinically significant bleeding. And mind you, this is important in elderly people, CKD people, women, and the whole lot of ACS patients that we are seeing. We know our excellent secondary prevention trials and drugs has considerably reduced the incidence of MACE. So we have to be now looking more at the safety endpoints. This is interesting. Whether you give a shorter DAPT or a longer DAPT, the cardiovascular mortality remains almost similar. And we are definitely looking at a cardiovascular mortality in ACS patients. So all of us has to do a balancing act versus ischemic risks versus the bleeding risks. And that is not easy. That's why you have the concept of individualizing every ACS patient by your wisdom, by your pearls of wisdom, to decide on what is the duration. Because HBR is a concern. We have a lot of groups of patients who has these comorbidities who are at the risk of high bleeding risk. So naturally, it's important for all of us to realize the fact that the DAPT, a prolonged one, could be potentially assisting deteriorating the status of HBR patients. And we have to also, earlier the concept was, of course, minor bleeding, we don't need to worry about. And mind you, most of the time, we don't see the real bleeding. Somebody else sees that. So it's also important that bleeding matters. It increases the mortality. Even transfusing blood increases the mortality, not the short-term mortality, even 1 year mortality or 2 year mortality. We have now evidences which shows that even blood transfusion during the ACS period can increase the mortality. People thought that, the HBR patients are a lesser group. Not necessarily. We are going to see a large majority. I don't know whether we will go and see 1/3 of the patients are or HBR group. We don't have a strong Indian data on that, but it is real. It's a fact that we are seeing, you and me are seeing everybody, SES patient, more than 70, a large group of patients. And these are the patients which present us, which gives us concern. That was the time when we thought about what about dropping aspirin and continuing on just monotherapy. Give DAPT for a shorter time, 1 month or three months, and then continue with monotherapy, and you have a lot of data accruing up. The first one, one of the first one was the global leaders. People thought that by giving a 30-day, 3 months of DAPT and then continuing with monotherapy, we will be better. But global leaders was a failure. It did not, I will not say failure, but it did not say any superiority for the monotherapy concept. Then came the smart choice trial. I can go on talking about Lomini trial, the STOP DAP trial, and each one of them showed the short DAP was just 1 month DAPT, and when it was compared to 12-month DAPT, bleeding was definitely lesser, and the ischemic endpoint was near similar. You can look at the data. So we have now increasing data which showing a shorter DAPT duration, and then monotherapy will be suffice. And that was such twilight, which every one of you have heard multiple times. And maybe in this session also we're going to hear it more often. So we have the data which showed us definitely when it comes to bleeding, no questions asked. We have a huge difference for the shorter DAPT group. Even the death MI or the other MACE group, look at the data. See, it's not very statistically different, but then the fact is we have a near similar results of ischemic endpoints. We have the sub-studies of TOLIDE, the TOLIDE CKD, which again 1/3 of our patients that we deal with has some compromise in the renal function. All of us are concerned about the use of a prolonged DAPT in that. This is one data which has given us, you might be asking, what about the ISAR-REACT? This possibly the newer ESC 2020 and STMI guideline was based on that, but I am a little confused on this data. As Marco Valgimigli was saying recently, you give a 1-year recommendation to prasugrel, you give a 1-year recommendation to ticagrelor in STMI. Then you say that prasugrel has a 2-year recommendation over ticagrelor. I don't understand clearly the statistics. I think the pundits possibly will be able to better. I'm not very sure whether that comparison and that guideline will hold true in that. When it comes to this, not so common group of atrial fibrillation and PCI patients, we have again more and more data coming on limiting the triple therapy to the least possible time. For your information, every one of you know that. In Augustus, aspirin was given very procedurally, and then aspirin was stopped. And look at the result. Phenomenal reduction in bleeding and near similar results of ischemic endpoint. But having said that, do I need to? I will not touch the APT. Of course, when I do this triple, I don't do this regularly, but occasionally you may be doing this multiple stent business, longer stent business, extensive disease, ISR. There are situations then you have to use it. So we have more and more data. I don't want to prolong the agony of talking too much. I know my time is almost up there. So we have also data talking about the extensive beyond 1 year limited, with the 60 milligram trichloride data. Every one of you are aware of the Pegasus trial. Just before concluding, I will touch on a point of using generics. I know we are in the times of our Modi's concept, everywhere you have the generic drugs availability. What about use of generics? So we have a lot of assumptions that bioequivalence comes into matter, comes into play, based on the assumption that a 20% difference in pharmacodynamic factors, even if it is there, it will not matter the efficacy. But I don't know the real fact. I'm not a pundit on these bioequivalence studies. But whatever we have seen in cases of clopidogrel, we have studies which showed that using generic clopidogrel, we have problem. We have decreased bioavailability, decreased platelet efficacy, platelet inhibition, aggressiveness, everything was considerably lesser. So these are something which one has to realize. And finally, summarizing, the dynamics of DAPT goes on experimenting, and that's good for the science. We have to experiment. The optimal duration of the antiplatelet therapy is still now debatable, and I'm sure the newer guidelines will touch on it. We had the guideline from 2016 now prevalent. We possibly will see it soon in a year or so. We must stratify ischemic and bleeding risk to balance the risk-benefit ratio. Bleeding matters. It is a predictor of mortality. And we have the new concept of the stent design and technology. We have lesser stent thrombosis, lesser ischemic endpoint. Which ideal drug is ideal for monotherapy? The data seems to be favoring ticagrelor and it's a matter of concern. You have to be cautious about using generics. Thank you very much for your kind attention and also for the opportunity.
Thank you, Dr. Mohannan, for nicely summarizing the DAPT dynamics. We learned many things from you. But I think there are certain issues remain to be discussed, and within the coming few minutes, we can discuss those things. Number one, whether do you think that guidelines will soon be changed from 1 year to lesser duration? And whether guidelines will be going towards more patient-specific approach rather than one-size-fits-all, that is stratifying between high risk and low risk and then deciding the mode of therapy. It is not only drug, the strategy of therapy itself, when to start, when to stop, etc. And there are 2 or 3 nuances in the dealing of the selection of the drug. For example, the ESA React that showed that prasugrel is better than ticagrelor in certain aspects, whereas recently published, very recently, within a month in this year, there have been 2 studies with ticagrelor showing its benefit over prasugrel and clopidogrel in regarding LV remodeling, regarding endothelial dysfunction, etc. So in those studies, ticagrelor showed some benefits. So I think the choice of drug will be also somewhat changed. So in these regards, you can start discussing, then others will join, and we can. And I'll be seeing the chat box also if there is any question from the audience.
You are absolutely right. This was on that particular point that you suggested, because the ISAR React was, now I can pick a lot of holes in ISAR React, but it was one of the first randomized controlled trial comparing prasugrel and that showed the reason, even though every time we used to say the mortality reduction, cardiovascular death reduction happens mainly with ticagrelor. So we need to have more data, comparative data. If you look at the 5 or 6 large propensity meta-analysis that has been done, it has shown that there may not be much to choose between that. So the most important point right now is we ourselves has to use our wisdom, our clinical experience, and individualize every person in choosing and picking antiplatelet drugs. That will be my suggestion, rather than saying you do that, you did this.
Thank you, Dr. Mohannan. Now, just to let you know that 1,008 patients are watching Dr. Mohannan and the expert chairs and panels.
People, Dr. Kahali.
Yeah.
1,008 people.
Yeah. 1,008 doctors, interventionists. I can't tell because, there are many cath lab technicians also.
Yes,
So
yes.
people is not bad, at least, Dr. Das Pisher.
Yeah.
It's a good term, I think.
Or you can
We
say
tell
fast.
namaste to all the people. Anyhow, Dr. Tyagi, have you got any comments to make?
Tyagi, you are muted. Tyagi, Sanjay, you are
Yeah.
muted.
The situation of atrial fibrillation with dual antiplatelet therapy and acute PCI is not uncommon, and all of us frequently encounter this problem. So whether one should use a drug which antiplatelet drug which can be easily withdrawn and the effect goes away as soon as the patient develops the bleeding, or a drug which has a better efficacy. What do you say, Dr. Mohanan?
Yeah, basically all the 4 trials. We have 4 trials using NOACs. And of course, we have the earlier warfarin trial. We are not possibly speaking about the warfarin trial, but people have radial PCI. I mean, all the trials, which every one of you are familiar. But then the last couple of trials with edoxaban and apixaban was, especially the Augustus one, was using 1 week of peri-procedural aspirin. Stop aspirin at the end of 1 week, then continue single antiplatelet drug and a NOAC for 1 year, and stop the antiplatelet drug at the end of 1 year. Just continue the NOAC. Most of these 4 trials has used clopidogrel substantially. The Augustus has about 12% of ticagrelor, and the edoxaban trial has about 18 or 19% of ticagrelor. We have to know more about the newer antiplatelet drug in this subset. Generally, familiarity is more with clopidogrel.
Yeah, but problem with the clopidogrel is that it takes time to withdrawal. If the bleeding develops, then it takes longer time to get withdrawal as compared to the ticagrelor.
I think we are possibly going to see now gradually the proportion of ticagrelor user in the PCI AF trial is increasing. From 12% it has gone to 20%. We may see another trial with a 50% ticagrelor. That will be wonderful to see how they fare.
Yes.
In fact, that is why the trial with
the president is speaking.
That is why the trial with edoxaban has been already in the market. Actually, this is precisely the use which can be done even at a very short notice and for a short duration, and they can be either switched on or switched off. And that is why the dynamicity is not only dependent on the type of the antiplatelet agents, but also the duration, as well as the modus of giving the medication, whether it is oral or intravenous or infusion pump. And in the COVID scenario, for your information, in the COVID scenario, the thrombus has been a very, very important factor, which was really doing a lot of problems in the cases of PCI. And this intravenous Congrelor was much more in use in the United States, as has been published recently.
That's very important.
Dr. Mohanan, I just want to point out one interesting aspect. While we were considering DAPT and single platelet, the earlier studies, they took off the P2Y12 inhibitors and continued with the aspirin for the rest of the period for 12 months or like that. After some of the side effects of aspirin came up in like ARISE trial and ASCENT trial, now the trend has been when you are taking off DAPT and continuing with the single antiplatelet, to go for P2Y inhibitor and take off the aspirin first, because ARISE and ASCENT trial had shown a higher incidence of bleeding and mortality with aspirin, unlike our previous belief. So that is one of the important aspects of our looking at the DAPT. And when we go to SAPT, we continue with P2Y12 inhibitors rather than aspirin. That is number one. The number two issue is that we have a number of new trials like TICO trial, that even a global leader. If you look at the glossy centrally adjusted trial, they found there is a benefit in ischemic events as well. And even after 23 months DAPT as against 1 month, we find that 1 month ticagrelor is even better than 23 months, at least in terms of. So time has now come. We have to individualize our patient, no doubt. But time has to come to think in terms of reducing the DAPT duration. And if we had to go for a single antiplatelet, it should be either ticagrelor or prasugrel, neither aspirin nor clopidogrel.
Yeah. I mean, unfortunately, that is happening to aspirin. We now know aspirin is almost out of the primary prevention sector. It's unfortunate to see aspirin disappearing in the secondary prevention sector also. But then that is the truth. I think we have better agents, lesser GI bleeds, lesser other bleeds, and bleeding safety becomes much more important now these days.
Dr. P.K. Dev, have you got any comments? Dr. Dev?
No, I don't have any comments right now. But I think that aspirin is probably losing its importance, and antiplatelet monotherapy will soon replace the dual antiplatelet therapy. Only a short 3 or 4 weeks of dual antiplatelet therapy will be there in coming future. And in fact, the place of dual antiplatelet therapy is being decreasing day by day. And aspirin has probably lost its path.
Dr. Shomukha Sundaram?
Mohan, you would agree with me that cost is an important consideration for all. What's your view on de-escalation of therapy from ticagrelor to clopidogrel based on some genetic polymorphism studies? What is your view on that?
Well, we have the initial interest has been very, very, very high. Now, the one randomized trial and 3 other non-randomized trial, which showed that now even at the end of 1 month, not to speak of 3 months, changing from ticagrelor to clopidogrel have the same efficacy. See, the problem is, again, at one hand, we are talking about resistance, and on the other hand, we are talking about, I 100% agree that the cost matters. Cost is very important. That's why, you have always talked about even the use of generics. The importance of using generics was considering the cost. But whatever it is, the switching business of late has taken a beating. I don't know for what reason. We are not seeing a larger amount of data coming on the importance of switching these days. Because monotherapy, possibly alone with one drug, basically with more data with ticagrelor, is possibly the way. I don't know, honestly. I have to really say that unless we have more robust data on the switching, we have 1 year data. But if we have more data coming up, or if we have again more substantial data on proving prasugrel, which is a much more cost-effective drug, I am game. One side doesn't fit all. That I 100% agree. I think that's the reason why everyone says, from Anjan Lal Datta to everyone says that we have to individualize our antiplatelet therapy.
Professor Rakesh Jadhav, have you got any comments, Dr. Jadhav? Because we have to start the inauguration ceremony, so we have another 1 minute time. So you have to be very precise. Thank you.
Dr. Dhiman, just one short comment. In the process of de-escalation, there is one OTIC trial. The OTIC trial where after 1 month, ticagrelor was replaced by clopidogrel. The benefit was shown only in the less incidence of hemorrhage, but there is no benefit in the less incidence of ischemic heart disease. So if there is a de-escalation, there is no benefit as yet. Only the other escalation from clopidogrel, you can go over to switch over to ticagrelor in the same manner. But then there is enough evidence with that only. But then cost is a very important factor, no doubt.
This week, Dr. Mohanan, there is a issue in JACC that with clopidogrel and ticagrelor, after MI, there is a change in the left ventricular remodeling by ticagrelor, and it is in favor of ticagrelor. Dr. Rakesh, are you there? Dr. Rakesh Jadhav?
I'm very well here. I'm very
okay. Any comments we want to listen from professors?
Only one comment I just want to ask from Dr. Mohanan. Sir, in this era where, in this situation where a lot of dengue fever is coming, a lot of COVID is coming, what is your advice to, because a lot of patients, practically every patient for intervention is in India is on dual antiplatelet. So what your advice? Should we continue these two, ticagrelor or prasugrel or clopidogrel, or for transient time we should convert ticagrelor, prasugrel to clopidogrel and aspirin? Well, this is a huge problem which we are facing. And on the above, if you have a moderate to severe COVID, the NOVAC has to be started. So what in dual antiplatelet, you should stop. You should whether stop ticagrelor, prasugrel, clopidogrel, or you should stop aspirin and then give NOAC, or you should continue all these three.
No, despite the fact that everybody know about the thrombotic effect of COVID, and everybody start talking about the disappearing MI. Nobody talks about how we should proceed on the DAPT or NOAC or anything. So I think the situation demands a very aggressive antithrombotic regime. And possibly that will include more potent antithrombotic drugs, that will include more potent antiplatelet drugs, and a NOAC. In many situations when you have already an artery, patients are presenting with multiple thrombosis at multiple vascular beds. So I think the idea will be to use more stronger antiplatelet drugs. I will be the last person to talk anything stronger about it because we don't have any data.
Okay, thank you very much, Dr. Mohanan. And we want to conclude the session because we are over time and it is 4 o'clock. So we have to go for the inauguration ceremony. And I will ask Mr. Raghu, to come out with his inauguration program. And I would also ask Professor P.K. Deb to kindly inaugurate our this conference, CSI-NIC conference, the third educational initiative, please. So Dr. P.K. Deb, please. Raghu?
Should I start or somebody will call me?
Yeah. No. I've already called you, sir.
Okay,
so you please, start your short lecture. Yeah.
Respected friends and colleagues, it is a proud privilege for me to get such a great opportunity to grace the NIC virtual conference as the inaugurator. So getting this opportunity, I declared the conference to have been inaugurated by me already. NIC is the interventional wing of the Cardiology Society of India. It represents all interventional cardiologists practicing interventional cardiology across the country. He started as PTC registry in 1986 and CSI started in 1948. And the Intervention Council started its functioning in 1998. So this is and NIC has two conferences, one midterm conference and one occurs during the annual conference of CSI. And this conference, this virtual conference represents the midterm conference of 2020. It was supposed to be held in 10 to 12 of April in Chennai, but due to COVID scenario, due to pandemic of COVID and lockdown procedure, we had to postpone the conference. A virtual midterm NIC conference is being held on 31st of October and 1st November using a virtual or web platform. It is primarily an educational initiative. 2 webinars have already been arranged in near past, and similar webinars will be arranged in near future also as a continuity to maintain the educational initiative of NIC. And this particular virtual conference is also an educational initiative of NIC. About 1,000 delegates have already been registered for this virtual conference, not only from India, but also from Bangladesh, China, Taiwan, South Korea, Indonesia, Malaysia, then Singapore, Middle East countries, then West European countries, East European countries, USA, a few African countries. So we can call it an international conference, and I should be proud to declare that it should be called a successful international conference being arranged by NIC in such a dreaded and COVID scenario. that every year NIC collects data from coronary and non-coronary intervention across all of the country. And these data are presented during the conference. The annual data shows the comparative burden of CAD in the country, trend of the disease compared to the past year, changing number of interventions, changing number of complications, and adoption of various newer techniques, procedures, and newer devices for various centers across India. But India is not an uniform monolithic structure. The population of India is 1.3 billion. 35 million people suffer from CVD. There are around 1,400 cath labs available in 140 Tier 1 and Tier 2 cities in India. From April 2009 NIC conference, this is the data. Number of cath labs in India has grown up to 100% in last 5 years, Times of India 2019. There is a growing demand for cath labs in Tier 3 and Tier 4 cities in India. But there is a growing demand. Why? Because the rural population is equally affected by CAD as the urban population. And one cath lab center needs about 5 crores to come up. So whether or not by preparing cath lab centers in Tier 3 or Tier 4 towns and cities in India will be economically viable needs to be answered. The next frontier is availability of interventional cardiologists in the country. 7 years ago, India had around 120 cardiologists passing out every year. Today, the number is increased to about 650 per year, and the number is increasing year by year. But the problem is that these DM and DNB students do not follow the same syllabus or same teaching standard all over the country. The teaching standard varies, the syllabus varies, the standard of healthcare system also varies. So it becomes the duty of NIC to monitor whether the uniform pattern of healthcare system or interventional cardiology is being delivered to the needy patients all over the country in a uniform manner or not. Then comes the question of price capping and Indian stents. Due to price capping and introduction of Indian stents, affordability of stents has increased for the poor Indian population, more so when government patronizes the situation. But strangely, this price capping has also its own limitations because there is no differential price capping. The price capping is same in all categories of stents. The price capping is same. It is not the right thing to do, I believe. And CSI must have to say to remove this non-differential price capping. And more than 40 low-priced indigenous Indian stents are now marketed by more than 10 Indian stent manufacturers. This appears ideal for India's socio-economic and political scenario. But prospective placebo-controlled studies should be done only by NIC because no other body will be interested to do these studies, comparing these indigenous Indian stents with the standard stents. And we should know, the last lecture was the dual antiplatelet therapy, whether it should be shortened or remain the same or the duration will be lengthened. With available Indian stents, the indigenous Indian stent, whether the dual antiplatelet therapy will be same or shortened or will be lengthened remains to be seen, and that thing should be settled by CSI itself. And available registry data signifies that despite high incidence of CAD, a very low proportion of cardiac patients are performed PCI in India. And there is a gulf of difference between NIC and other Indian international bodies who are arranging international conferences. What is the specialty of NIC? NIC is unique in that it exclusively collects the annual international registered data from all over the country, which no other international body in India does. And NIC is a supervisory, monitoring and advisory body, which is not so by any other Indian society who does international cardiology. So NIC is unique in its way, and NIC must not be compared with any other international cardiology society in India. It is unique. And NIC has its own limitation also. NIC limitation is that The non-coronary council looks like a poor cousin of coronary council. It might be receiving a stepmotherly attitude from the parent body. I think the standard of operation of non-coronary body of NIC should be uplifted. There should be distinct and expanding visibility of non-coronary interventional cardiology all over India. And special regulatory authority should be there, and NIC should be more particularly interested to include in its clutches the special registry for renal denervation therapy. NIC is not only an interventional body, or it is not only an initial education initiative. It is a dynamic movement. It is a national mission. NIC must not fail in its supervisory monitoring or advisory capacity to keep its standard or to uphold its standard all over the country. Everything will be done, everything should be done, and everything must be done to maintain the moral and ethical standard of NIC. Dr. Dhiman Kahale, Chairman of NIC Coronary Council, Dr. D.P. Sinha, Chairman of Non-Coronary Council of NIC, Dr. Devabrata Rai, Program Coordinator, has an excellent work to make this conference a great success, and they have done actually Herculean task. They did a great job during a short period of time in high-peaked COVID scenario. Dr. M.K. Das, President of CSI, Dr. Mohanan, President-elect of CSI, and Dr. M. Mandal, Interim General Secretary of CSI, have expanded their cooperation in every possible way. Ms. Adhanika Das, Office Assistant of CSI, West Bengal Branch, deserves special attention for her sincere and supportive work. NIC expresses its gratitude towards the sponsors for their unrestricted academic grant. NIC expresses its highest regards for international and national faculty and delegates. Long live CSI, Jai Hind. So I now declare the conference, the virtual conference to open, and now the conference should go on in its own way and in its unique way. Thank you.
Thank you, Dr. Dev, for kindly inaugurating our meeting, NIC-CSI meeting, and also for your informative and valuable speech. We should remember your advices to us, as you have a great experience, and we try to follow your advices and preachings. Thank you very, very much, and thanks everybody for being present in this ceremony. And now the delegate is 1107. So I would like to go to the next session, and that is precision medicine, a new way to practice PCI and multi-vessel talent. And this is a legend speak, and legend is no other than Patrick Service. So I would request the chairpersons, Dr. P.K. Dev, Dr. P.S. Banerjee, Dr. Upendra Kaul, Dr. Professor V.K. Bahal, Professor Sanjay Tyagi, and Professor Rakesh Jadhav, all of them to kindly chair the session and introduce Dr. Patrick Service. So legend speak. So Dr. Patrick Service, please.
I should go now to the...
Dr. Service doesn't require any introduction, and I think world over, all the interventional cardiologists knows him as Master of Masters. And he is the chief editor of Euro-Intervention Journal. He is with EAPCI, and he has been involved with very beginning of EuroPCR. We also have been going to EuroPCR regularly, and all the chapters of book of EAPCI, and in leading journals, intervention journals, you will always find an article of Patrick Service. And whenever we meet, we learn from Sir. And so Dr. Patrick Service, first of all, thankful gratitude to you for kindly giving your valuable time to this virtual meeting. And I invite you to deliver your lecture kindly.
Thank you very much, Dr. Kahale. I think it's for me a real privilege and honor to be a speaker at the Cardiological Society of India. I really mean it. So the title is Precision Medicine, a New Way to Practice PCI, and an introduction to a trial to exemplify that concept. As a background, I would say that randomized trials are the gold standard for testing the effectiveness of novel treatment. However, average treatment effect are typically reported in randomized trial. I will explain that. However, treatment effectiveness can vary across individual patients, and average treatment effect may be suboptimal for decision-making in individual patients. So the Syntax Score 2 published in The Lancet in 2013 derived from 2 angiographic and 6 clinical variables provided an individualized decision-making based on 4 years all-cause mortality after either CABG or PCI. And using the data of the 10 years follow-up of Syntax extended survival, the Syntax's trial, we thought to update the Syntax Score to the version 2020 for prediction of 10 years mortality and 5 years MACE, major adverse cardio and cerebrovascular event. And we validate that in the Freedom trial of Valentin Förster, the best and the pre-combat of SG Park in Korea. And we validate the Syntax Score 2020 for its ability to predict treatment benefit in mortality and MACE. You see here the average treatment effect as a summary result for the 10 years all-cause death in the Syntaxes. As you could see, the all-cause mortality after bypass surgery was 24.5, and with PCI, 28.4. That's an increase with PCI of the risk by 19%. You can see the 95% confidence interval borderline, and the p-value is also borderline 0.066. Now, based on the average treatment effect, should we send all our patients to surgery? And the answer is, of course, not. So today we are creating decision tool to improve the personalized care in cardiovascular disease. We are moving the heart of medicine towards science. The first panel here, the panel A, is the average treatment effect assessed in an heterogeneous population. You could see there are small men in green. They will benefit from the new treatment. There are small men in blue who will have an equivocal response, and there are small men in red. The new treatment will arm this patient. And the estimation of the average treatment is this mixed bag, these small multicolor individuals. So it is very important to identify the heterogeneous response to the treatment in advance to the treatment, to segregate the patient population based on a treatment response, to identify again the patient armed by the new treatment, the patient will benefit from the new treatment, and the patient would have an equivocal result. So the Syntax Score 2 2020, just published in The Lancet 3 weeks ago, was redeveloped to predict these 10 years mortality and 5 years MACE in the Syntaxes trial, and as I said, externally validated. We have 2 important modifiers, the anatomical Syntax score and the type of disease, 3-vessel disease of left main. The clinical parameters are the current smoking, very coming from the Syntax and the Freedom, but also the age, the creatine clearance, the ejection fraction, the chronic pulmonary disease, the peripheral vascular disease, and the diabetes. And at the bottom, you see the probabilistic formula that you have to use. If you want to send the patient to surgery, you have only to include the blue parameters. And if you intend to send the patient to PCI, then you have to use the red parameter. Not only we can predict the 10 years mortality, but using a different formula, we can predict the 5 years MACE. Now, this is the cost validation. Let's start by the panel here. This is PCI. This is what we call a calibration plot. That's the relationship between the observed 10 years mortality and the predict 10 years mortality. And you see the whole population of the trial, 1,800 patients, has been subdivided in quartile, quarter of the population. The relationship, the regression line is remarkable, a slope of almost 1, an intercept of 0. And if we do that for the patient having undergone bypass surgery, again, looking at the relationship, observe mortality versus predict mortality, you have also an excellent regression line. Now, what we have done, if we have looked at the difference in 10 years mortality, we call that now treatment benefit of bypass surgery versus mortality. And you see that we found also a quite nice regression line dividing the population in quartile. And one point is important is that this quartile has clearly PCI is better. In this quarter of the population, we have equipoise, and in the last 2 quarters, CABG is better. Now, can we translate that in Kaplan-Meier curve? Yes, we can. And in the first group, the PCI better here, you could see that the survival curve of PCI in red is higher than the survival of bypass surgery. So in that quartile of the population, PCI is better. And as a matter of fact, the better is by 1.4% in terms of all-cause mortality. In the second quarter, equipoise, you could see that the Kaplan-Meier curve are superimposed, completely overlapping. We have the same survival with bypass surgery and PCI. And the difference, the absolute risk is close to 0. In the last 2 groups, CABG is better by 6.1% and 11.4%. And you see that the Kaplan-Meier curve for survival of surgery is better than PCI also in that quartile. Now, I can do the same for the 5 years MACE. I will not do that. It's the same principle and the same concept. Now, this is the important slide because that's what we are using now. Case number 1, I have an individual 74 years old. Creatine clearance is 38.6. Ejection fraction is 40%. That's not very good, the ejection fraction and the clearance. He's a current smoker. He has a left main, but a very simple left main with an anatomical syntax score of 11. And as you could see in that patient, there is a 10% benefit in 10 years mortality in favor, in blue, in favor of PCI in red. And the same is true, a 13-14% benefit for PCI in that patient of case 1. In case 2, the individual is 59, somewhat younger, but he has diabetes, fortunately not insulino-dependent. Creatinine clearance is 68, good. Ejection frac 67, good. He has a 3-vessel disease, a very simple one with an anatomical syntax score of 10. And as you could see, At 10 years mortality, we have very low percentage, 11 and 10%, and the 5 years MACE is 9.3, 8.4. So we have what we call equipoise, and probably we will select a PCI for these patients. The last one, the case 3, the individual is 69. He has a diabetes. It is insulino-dependent. He has, fortunately, a reasonable creatinine clearance and ejection fraction. He is a 3-vessel disease, but look at the anatomical syntax score, very high, very complex disease. And you could see that at 10 years, surgery in blue is much better in terms of a prognosis than PCI by 20%. I know that the Indian patient will easily select PCI because it's less invasive, but you have to take into account about this difference in mortality of 20% at 10 years, and the same in MACE at 5 years, that's 20%. Now, this data has been published just a few days ago. 6th of November is not yet there, but the electronic version was available on 31 of October. So you are really today with brand new information. I did that paper with one of my Japanese fellow, and very soon we will have an Indian fellow in Galway. Now, with the company SMT, and I'm very grateful for this Indian company, Sahajanand Medical Technology, to have helped the core lab, my core lab at the University of National University of Ireland, Galway. This is an app that you can, you don't have to pay for it, it's free, and it is on a smartphone. And as you could see, you have access not only to the syntax score anatomic, to the logistic clinical syntax score for PCI with the 2 years mortality, the syntax score 2 for the 4 years mortality, and now the syntax score 2020 for the 5 years MACE and the 10 years mortality. And you will find in this app at the end the same plot that I just showed you. Now, what about the best practice? The best practice is an editorial of my friend William Waynes, president of the PCR, and a surgeon of Ottawa. Then he was making an editorial on the trilogy of the European Society of Cardiology and the European Association of Cardiothoracic Surgery guideline. And the best practice today is, before deciding a PCI more than bypass surgery in patient with 3-vessel disease, please calculate the syntax score 2 and the syntax score 2020. Then treat only the lesion justified by physiology and anatomy using resting and hyperemic indices of stenosis. That's the pressure why I will discuss that later on. Optimize your result with intracoronary imaging, intravascular ultrasound. The benefit is really there. There are many 2-3 randomized trials on that. And then have an expert in your team for the chronic total occlusion so that you are sure that you achieve complete revascularization. We have today thin and ultra thin. In India, you have ultra thin stent, please use it. And then in terms of optimal medical care, give all the goodies, statin, angiotensin inhibitors, and so on. That's the component of the best practice. And we have used that. I mean, we have now the 3 years follow-up. This is the clinical outcome of the state-of-the-art PCI in patients with 3-vessel disease. 2 years follow-up, the 3 years follow-up is in publication very soon. And as you could see, we did indeed calculate the syntax score 2 in all our patients. You could see that we used the FFR in 96.4%, We use IVUS per patient in 84.1%. We had the expert having a success rate of CTO in 87%. We use, of course, drug-eluting stent in all patients, and the statin at discharge very high. And you could see the impact if you compare the old Syntax 1 PCI in red versus the Syntax 2 PCI. We have decreased the MACE from 21.9% to 13.2%. And in an exploratory analysis versus bypass surgery of Syntax 1, using propensity based on the Syntax 2, you could see that we are doing at 2 years, and I can tell you at 3 years, as well as the surgeon, 15.1, 13.2. Now, if you look at the recommendation on functional testing of the European Society and the surgical guideline, when evidence of ischemia is not available, FFR of IFR are recommended to assess the hemodynamic relevance of the intermediate lesion. And FFR guided PCI should be considered in patients with multivessel disease. This is recommended. 1A or 2A should be considered, and it's based on the 1A on multiple randomized trial, DEFER, DEFINE FLYER, SWEETHEART, or FAME. Now, I have to tell you that pressure wire with adenosine is something which is cumbersome, expensive, and a little bit difficult. I mean, they are not so optimal guide wire. So this is a cartoon published just right now by one of my fellows in JACC Intervention. This is the classical FFR. But we have now non-hyperemic wire-derived pressure ratio. The only advantage is that you eliminate now the adenosine. Either you do that on the whole cycle, it's the PDPA, or you have diastolic and sub-cycle with Boston Scientific, the TFR, Philips, Abbott, and Opson. On the other extremity here, you have the FFR derived from multi-slide CT scan, that's the heart flow. What we propose to replace that difficult and expensive pressure wire, we propose angiography-derived FFR. And as you could see, there are already 3 or 4 methodology very well validated, the QFR of MEDIS, the FFR angio of CatWorks, and the VFFR. So that's the goal we have, is to replace these pressure wire by the FFR. This is a 3-vessel disease, clearly a severe lesion in the right, a severe lesion focal in the LAD, and something suspicious here in these big posterolateral branch. So what we do is that we analyze the contour with the technology, and then what we do is that we do a 3D reconstruction. That's very important to do this 3D reconstruction. And then we use the frame counting to assess the velocity and the volume flow. And by combining these 3D angiography with the volume flow, we can have the pressure gradient and the FFR in the vessel. And as you could see in the case that I have presented right now, in the RCA, you have a QFR of 0.67. So you should treat that lesion. In the LAD, you have a QFR of 0.38. You should treat that lesion. But in the circ, the QFR is 0.90. You should defer. That's good for the cost. That's good for the outcome of the trial, short time and a long time. So with the Indian company SMT, which is really has a good leadership, we decided to do a trial in Europe called multi-vessel talent. And as you could see, we are treating 3-vessel disease patient, the most complicated. There is still a major debate with the surgeons. So we took 3-vessel disease. We do the syntax score 1 and 2. If the syntax score favor the bypass surgery, no alternative, you have to go to surgery. But if the syntax score favor PCI or favor the equipoise or show equipoise between PCI and CABG, then we have the heart team decision, and then you decide that the patient can be treated by PCI. Then we have the written consent, and then the film is sent to us in the core lab in Galway, in Ireland, at the University of Ireland, and we do for you the QFR on the diagnostic angiography. We communicate this result to you, and then you randomize between the Supraflex Cruise, the new generation, and the Synergy. And if for some reason we cannot analyze the QFR, you can always do in that single lesion not analyzable the FFR of the IFR. And then after the procedure, we do IVUS on OCT. At follow-up, what is new is that we stop the aspirin after 30 days. We have done now many trials, the global leaders with 16,000 patients, Twilight, Stop That, TICO. We can stop the aspirin. Aspirin is responsible for the bleeding. We have today specific and potent P2Y12. We should use it. So we give monotherapy, as you could see, monotherapy for 11 months, and then eventually we go back to aspirin, but we don't give the dual antiplatelet therapy long-term. That's responsible for the bleeding. And as you could see, the primary endpoint is a patient-oriented endpoint at 1 year, non-inferiority, but the good things is that we have a superiority in the power secondary endpoint, and that's the vessel-oriented competing endpoint, which probably will let emerge the superiority of one stent versus the others. I remind you that in Lancet, in the per protocol analysis with the Supraflex, not the Supraflex Cruise, with the Supraflex in the Lancet, we show in the per protocol analysis an advantage of Voce of the Supraflex on Science, and we go now against Synergy. So let me show one patient in the trial who has indeed been randomized to the Supraflex Cruise. You see the syntax score anatomy, the age, the creatine clearance, the ejection fraction, no left main, the gender, COPD, PVD, diabetes, BMI, previous stroke, hemoglobin, and you can do many things. You can look at the PCI logistic and have what will be the mortality of that patient at 2 years, excellent, 1.6. You can use at the syntax 2 in case you want to hesitate between bypass surgery and PCI. 4 years mortality, 5.1 and 5.6. That's equipoise. And you can even look at the 5 years MACE of the 10 years mortality now, and you could see that between surgery and PCI, there is no difference. So there is equipoise in that case. So Faisal Sharif, the principal investigator in Ireland, decided to do a PCI with the Supraflex Cruise. You see here the lesion. No doubt that there is a severe lesion in the right coronary artery. The LAD, there are a few places which are not pleasant, but I would like to know the physiology of that lesion. And then in the circ, there is something quite severe at that site. So what is the result analyzed by the core lab? It's a telemedicine. You send me your film. I analyze very quickly within 1 or 2 hours and send back to you. In the meantime, you can discuss the case with the surgeon. The right, no doubt that we have to do it. The QFR is 0.78. The LED, I told you, QFR just 0.80. That's the cutoff criteria. 79, you would do it. 81, you will not do it. So it's a little bit difficult. The CIRC, there was no issue about this severe lesion there and here. So it's a QFR of 0.52. So recommendation, 3-vessel disease, put supraflex screws 4 mm 16 and then 3.5 28. The OCT of the RCH show a very good minimal stent area of 8.6 mm. That's perfect. Then the LED, what happens with the LED is you see the clinician, Dr. Faisal Sharif said, okay, maybe the QFR of 0.8 is dubious. So he did an IFR and an FFR with the same pressure Y. And he was convinced that something has to be done in the LED. So he treated the LED with a 3 mm 16 and a 2.5 18. And the IVUS at the end of the procedure was excellent. And here you see now the QFR post-PCI in this 3-vessel disease, excellent in the circumflex, 0.96, and excellent in the LED, 0.99. My time of talk is over, so I have to come to the conclusion after 21 minutes. And the answer is that the conclusion is that the syntax score 2-2020 is a personalized predictive model based on 7 prognostic factors and 2 pre-specified effect modifier, disease type, 3-vessel disease or left main, and the anatomical syntax score to predict the 10 years mortality and the 5 years MACE for patients treated with PCI of CABG. This model may improve the ability of the heart team to inform patients and their families regarding the risk and benefit of alternative treatment for complex CAD and support a more transparent shared decision-making process. I think this is very important. I mean, when I'm traveling in the Far East, Korea, Japan, China, but also India, most of the time I heard, yeah, but the patient prefer to do PCI. Of course, everybody will prefer something less non-invasive, but we have now more information and we have to share with the patient what is his long-term prognosis. And if the surgeon in your institution is a good surgeon, you have to a little bit try to respect the mathematics. I mean, we are doctors with a clinical flair, but this is important. And finally, the multi-vessel talent of the SMT company is now running at 50 European hospitals and involve 1,550 patients with 3-vessel disease and is applying the best practice principle endorsed by the European Society of Cardiology. And I hope that one day, I'm currently with Upendra Kaul running the Syntax 2, the Tuxedo 2, sorry. I hope that at some point there will be a multi-vessel talent in India. Thank you very much. What should I do now? Click to exit. Sharing. Oh, that's it. Yeah. Okay, good. I hope that you could follow the slide and that the transmission was good.
Thank you, Dr. Patrick, for bringing us the latest in this analysis of whether to do PCI or CABG. The most recent work that has been published today And we are really grateful to you for enlightening us on this topic. You have been always the pioneer in this area. So thank you very much for your wonderful lecture.
Thank
Dr.
you very much. It's a great pleasure.
So my point is that is a wonderful lecture, especially explaining the decision-making process in multivessel CAD. Now, in your opinion, how important it is the stent design to take a decision in a multivessel disease, that whether you are going for CABG or it is for the PCI in multivessel disease, giving the importance on the stent design or start thickness. So what is your opinion?
Yeah, I think one of your colleague, Bangalore, has made a meta-analysis of thin and ultra-thin stent. And I think that there is no doubt that going initially from, remember, 140 micron to 120 to 100 to 80 to 60, and the Indian technology is basically the only stent where you have struts of 60 micron all the way for all diameter and all length. And that's the reason why I have selected that technology to work on it, because it is the most performing. The Orsiro is also very good, but not every length and diameter has strut thickness of 60. So I think it's a very, very important point. That's also the reason why we dare to reduce the dual antiplatelet therapy. In global leaders with 16,000 patients, we proved that it works quite nicely, especially in difficult patients with multivessel disease, with complex PCI. That's a publication in European Heart Journal and GACC. So that really, I believe that the strut thickness is something very important these days, like physiology and like optimization.
And what is your opinion as regards the continuation of the prasugrel in place of, because you all know that high bleeding risk with prasugrel. So do you recommend the patients with the chance of bleeding risk, should we continue the ticagrelor for 11 months rather than prasugrel?
Yeah, I mean, in the global leaders, we had two hypotheses. One hypothesis was monotherapy with potent and selective P2Y12 will reduce the bleeding, and we proved the point. We made the mistake to test the second hypothesis, which was, is the P2Y12 the second year going to reduce the ischemic event? And that we did not achieve that goal. So that's the reason why we know that it's good for 1 year, but you do not need to give a second year. Now the question is still very difficult. What should we do in the long term? And that's something difficult. I think that that issue is not yet resolved. You know, 2 years ago, there was 3 papers in the New England raising doubt about, is aspirin really something important for the patient in the long term? I mean, for more than 20, 30 years, we have been giving aspirin systematically, but it is a weak, which is maybe an advantage, antiplatelet agent. So I think that at some point, something more adjusted to the patient will come. You still have in the pharmacological research a lot of new compound coming, which may have the advantage to protect your patient against ischemic event without letting him bleed. That's still the dilemma that we have. But for the time being, we are pretty sure that 1 month of aspirin, of 1 month of dual antiplatelet therapy, followed by 11 months of prasugrel, and then going back to aspirin is the best we can do with the knowledge that we have today.
Thank you.
Dr. Behel here, Patrick. Excellent lecture, as usual, a great learning experience. You are a thought leader, so I thought I'll put a somewhat hypothetical and provocative question to you. When Syntex came, Freedom came, Best came, we thought that this will give us an answer, whether bypass should be done or a PCI should be done in multivessel disease. Now we learn from you that there is another score which we have to follow, Syntex score, and you are very logically and convincingly told us about the scoring. Now, what prevents us that after your trial or any other trial, that if this score doesn't prove that the angioplasty is superior to bypass surgery, we will not shift the goalpost again as interventional cardiologists, because this is how we are criticized based on ischemia or courage for stable and a multivessel disease for these large trials, that we conduct these large mega trials, and when the results come, we shift the goalpost. It's a little hypothetical and provocative question. I thought you are the best person because you are the leader in this field and you make the guidelines. So I'm right or wrong? Like, just want your comment.
Yeah, I mean, I told you that Valentin Förster asked me for November 30, so I'm working very hard about the history of revascularization. And don't forget that the first bypass surgery was done by Goetz in 1960, and Andreas Krunzig came in 1977. And it has been a very, very long progressive improvement. Today, after Noble, after Freedom, after Excel, we know a certain number. We have made major progress in the field. What do I see for the next 10 years? I see 2 or 3 things. Number one, I think that the non-invasive imaging with the multi-slide CT scan is going to become more and more and more important. I would even say will replace cine angiography. We are doing a trial, very provocative, I must say. It is fast-track CABG. So now, without cine angiography for university with top surgeon have accepted to treat the patient surgically with 3-vessel disease and main stem without catheterization and cine angiography, just based on the multi-slide CT scan. That show you how far we can go in that field if the surgeon accepts to do that. And if the surgeon accepts to treat the top of the pyramid, the 3-vessel disease and the left main, we interventional cardiologists, if we have a multi-slide CT scan showing 1 or 2 functional disease, we should not catheterize the patient, but go immediately to the interventional suite, because that's the use of the fluoroscopy. Today in the cath lab, I mean, with cardioband, with left appendage, with aortic stenosis, with CTO, we need time. So we cannot afford to do diagnostic angiography. It has to be replaced. That's point number one. The point number two is that, in the last decade, with anti-inflammatory interleukin-1, the CANTOS trial, the colchicine trial, the PCSK9 trial, we have made major progress. The surgeon, and they are right, the surgeon always say that the bypass is cardioprotective for myocardial infarction. It's easy to understand. We treat the lesion, but all the minefield of vulnerable plaque between the main stem and the stent in the LED is very dangerous, and we are not protected. The surgical patient is protected. I would say that by introducing, and you would say it's costly, but everything, cost effectiveness is a very transient business. Look at the $4,000 for the Palmar shots, and now you have capped the bare metal stent $100, and even go lots with the PCSK9 and mainly with the microRNA of PCSK9, and I'm working on it. 2 injections per year, and you have LDL cholesterol at 50. That will change the future. It will probably reduce the number of bypass surgery and the number of PCI. But when you have done a PCI, like many years ago, I published in the JAMA the fact that we have to use statin in every post-PCI patient, irrespective of the LDL cholesterol. You will have the same story with the PCSK9. And then the fact that we have more spontaneous MI than the surgeon, that's also something which is going to disappear. So at the very end, early in my career, I did something stupid. I said to the surgeon, one day surgery for coronary artery will disappear. But I said, I don't know when. And the surgeon always quote me on the first part, but not on the second part.
So I think we have already at the end of the session. So any questions from other chairpersons or any participants? Otherwise, we'll conclude this session and giving a big hands to Dr. Patrick Sarai for his excellent deliberation of his talk. Thank you very much.
Thank you very much. It was a privilege and an honor. Yeah, believe me. Bye-bye.
Bye-bye.
Over to Dr. Dhiman Kahale.
Sir, kindly unmute.
Yeah. Can you listen? Yeah. So, thank you very, very much, Professor Patrick Service. On behalf of the CSI NIC and the committee, I give you a big thanks, and please give a big hands to Dr. Professor Patrick Service. It's a fantastic lecture. You have shown us the latest of latest data, and we learned a lot from you. We saw the publication in Lancet. It's a fantastic one, and hope that soon we'll be meeting you soon. And thank you very, very much, sir. Thank you, sir.
Thank you very much.
From CSI NIC. Thank you very much, sir.
Thank you.
So, yeah, Devabroto, you please hold the meeting. Yeah, Devabroto.
Yeah. I think Dr. Colombo has some technical issues, and so the technical persons, they're working on it from his side, and we think, Dr. Sir, do you have any comments so far that has been discussed so far, the topics and all? If you have any comments.
Hello. Yeah. Dr. Rai, you continue?
Yeah.
Because I have some internet problem here.
Oh, yeah. Dr. Colombo has some problem on his side, so there might be some delay. So let him sort out those issues, and so we can accommodate him later. So we have Dr. Others, Dr. Tyagi is there, and Dr. Rakesh Jadhav. So Dr. Rakesh Jadhav, any comment on what has been discussed so far?
Yes, David, my simple one comment, just I want to say that though these trials are being quoted a lot, that you can still do a multi-vessel PCI, but the biggest problem in India is this is being done by a lot of inexperienced persons, because they claim that study says you can very well go for a multi-vessel PCI, Syntest score is adequate, you can go it. But here it's a very difficult situation, because in the name of these trials, a lot of immature, lot of person who are not able to perform it very good, they do multi-vessel PCI. So in my view, in India, the results of multi-vessel PCI may be more worse than what we are actually reflecting in our larger trials.
Okay.
I think it's a common. I could not agree more. I think that the success of interventional cardiologists, like the success of the surgeon, is to concentrate and have a very good operator in place. And indeed, the simple PCI can be done by a lot of operator, but the more complex case has to be concentrated in large institution where physician, interventional cardiologist, and surgeon can discuss the case. I could not agree more with you, Deb.
Thank you. Thank you.
So if we have more time, Patrick, I can ask one more question.
Yeah, no, Professor Bahal, I want to interrupt because we have been waiting for Professor Colombo, but somehow he is not being able to connect because of some technical glitches. So I would request our good friend Dr. Ramesh Dagubati from New York, USA, to talk on DEB, on the next revolution, drug-eluting balloon, the next revolution. So Ramesh, please, and Professor Service, you please also stay with us, and thank you very, very much for your excellent speech. So the chair is to be done by the same professors who are there, and I also would request Patrick Service, Professor Service, to be with us for some time as it is possible. Thank you, sir. Thank you. So Ramesh, please, Ramesh Dagubati from New York.
Thank you, Dr. Kahali. Great pleasure being with you all. Thank you for this opportunity. Could I share my screen? I think you have to allow me to share my screen, please.
Please share, sir.
You heard Antonio? Yeah.
So, unfortunately, I can't fill Dr. Colombo's shoes, but let me just see what I can explain to you about drug-eluting balloons and the next revolution. I hope you could see me and hear me clearly. I have no disclosures. Essentially, the background of drug-eluting balloon comes from the risk of very late stent thrombosis that we have with drug-eluting stents. And still, whether it is sirolimus or everolimus eluting stents, which is the standard now that we have, there's a stent thrombosis can occur in about 2.3% or so. So, you know, when we talk about drug-coated balloons or drug-eluting balloons, it's the only strategy that is being evaluated quite well by good friends in Germany as a drug-coated balloon strategy alone in bifurcation lesions. There's at least from 100 patient trials or a series, there's no potential short and long-term disadvantages, and the reduction probability of restenosis was observed in a POBA era. The paclitaxel drug-eluting balloons were versus drug-eluting stents in primary PCI. This was studied in Pantera Lux Biotronic balloons and versus Osiro or Xience stents have been studied as well. The efficacy of drug-coated balloons is the primary endpoint, and you can see that establishing a fractional flow reserve at 9 months follow-up, and the margin of non-inferiority is less than 0.05. And in secondary endpoints, late lumen loss at 9 month follow-up and major adverse cardiac events, death, MI, and TLR. Whereas safety, the most important for us is the safety of stent thrombosis or major bleeding. I'll show you a slide. Probably there was initially some data on even slow reflow, which actually is not a problem anymore. Quickly, this is a 40-year-old person who came in with the index PCI with the Cypher-eluting stent in 2006. And I think many of you had seen this presentation, had multiple interventions in bifurcation lesions. And actually, so we had drug-coated balloons after final kissing balloon in left main. And as you see that whenever we have recurrent restenosis, you always think about same drug-eluting stents. I don't think we are using bare metal stents actually anymore. So bare metal stent restenosis is the one that is approved in European guidelines for use of drug-eluting balloons. but most of us use drug-eluting stents, and whether you have restenosis, whether we should use the same or a different type of drug elution with the stent platform, or use drug-eluting balloons or surgery. There's always these good opportunities that we talk about. Here is a drug elution after a cutting balloon, and then you can see great results in the beginning, immediately. But patients do come back even after drug-eluting balloons, sometimes with the restenosis. So this is not actually as simple as we think. LV function is normal, and obviously there's always an opportunity again to what should we do. So here, because of a failure of drug-eluting balloon, another Promus drug-eluting stents were used, and DK crush was performed with the great results. And so the component of ISR is the reason that we use drug-eluting balloons. But several things that you have to think about. What are the mechanisms of ISR? There is no single formula that will resolve the issues of ISR. Some of them might have to do with biological factors. Some of them have to do with mechanical factors. So whatever we do, such as stent deformation, stent fractures, we cannot blame the drug itself, or it actually has to be iatrogenic, meaning we did not do a proper preparation of the lesion. And the technical factors also are mostly iatrogenic, that is caused by us incomplete stent expansion. So we cannot blame any part of the stent or stent system or the drug system. So you can see that this patient has angio, and IVUS is very important in knowing that we have to see that stent thrombosis or TLR rates are much higher in people who did not have intravascular ultrasound. These could be avoided with that. So I'll quickly go over these because brachytherapy is also one option, but still brachytherapy can present after this patient who underwent brachytherapy had a very late stent thrombosis. So I don't think that the brachytherapy is an answer for everything. So this patient again had another drug-eluting balloon treatment, which after that actually patient remained asymptomatic. So I think I'll show you this. So let's look at the data of drug-coated balloons or drug-eluting balloons in ISR. There are 5 randomized controlled trials for bare metal stent in-stent restenosis, PACO-CAT, PEPCAD-2, RIBS 5, patients C and PLEVA, and 6 randomized controls of drug-eluting stent in-stent restenosis, whereas here you can see PEPCAD, Harbera, RIBS 4, ISAR Desire and PEPCAD China, and ISAR Desire 4. And so all of them actually are evaluating, and there's still not a great data to say that drug-eluting balloons is going to be the final answer. But there's some promising data that actually will support of drug-eluting balloons. In RIBS 4, if you look at it, drug-eluting balloons versus everolimus eluting stents, and this is actually 3-year clinical follow-up. Freedom from death, MITLR, which is this is compared to drug-eluting stent, slightly not so efficacious in terms of reduction of MI, TLR, and death with the drug-eluting balloon in the blue line here with the 75% freedom from MACE rates. What do the guidelines say from Europe? In a repeat PCI is recommended if technically feasible in restenotic lesions. Drug-eluting stents are recommended as class 1A. Drug-coated balloons are recommended for the treatment of in-stent restenosis within bare metal stents or drug-eluting stents as class 1A. And the imaging is class 2AC. So American guidelines are not so strong yet on drug-coated balloons because the trials are still ongoing. Here is Antonio Colombo's data about drug-coated balloons versus second-generation drug-eluting stents for the management of multiple lesions in metal-layered in-stent restenosis. So first PCI with the bare metal stent or drug-eluting stent implantation is done. Second PCI with the drug-eluting stent implantation for in-stent restenosis. So they analyzed 746 lesions between 2008 and 2013. And now comes back with, again, unstable angina and requires for in-stent restenosis a third PCI with a second generation drug-eluting stent implantation of or drug-coated balloons for ISR. These were 179 lesions, again, between 2008 and 13, and they were compared among these 179 lesions. So second generation drug-eluting stents were seen in 68 patients, 82 lesions, drug-coated balloons, 65 patients and 89 lesions. This is a very good observational data that we have. And overall MACE rates, and you can see that at 1 year, the MACE rates were 14% in second generation drug-eluting stents versus 12.3% in drug-coated balloons. And at 2 years, it's a 28% in second generation and versus 43.5% in drug-coated balloons. So the gap suddenly started widening after 1 year to 2 years. And the TLR rates, and similar to that, actually up to almost 1.5 years, there was not much of a difference between drug-coated balloons versus drug-eluting stents. But after that, there was a slow catch-up of TLR in the drug-eluting balloons at 2 years with 38.3% versus 27%. So the overall focal in-stent restenosis groups did very well, either with the drug-coated balloons or second-generation drug-eluting stents. And the non-focal are the ones that did not do well with the drug-coated balloons. So I think there is still, from this study alone, we can say that the drug-coated balloons really have a role in focal in-stent restenosis patients who will definitely benefit that. How about a lot of the revelations came out, and then paclitaxel-coated balloon angioplasty versus drug-eluting stents in acute MI. There have been great papers that have come out in the JACC cardiovascular interventions. And you can see in this, actually, the drug-coated balloons versus the drug-eluting stents was similar. So in acute MI, the primary endpoint here being fractional flow reserve at 9 months, there was no difference between the two at 9 months. But we still have to, in acute myocardial infarctions, probably there is a role for drug-coated balloons. We still need to wait for large randomized multi-center trials and with maybe follow-up of 3 to even 5 years. The secondary endpoints here, you can see late lumen loss is actually similar. There's no significant p-value of but small numbers, 42 patients in each arm. And major adverse cardiac events also are very low in these, and cardiac death, MI, 0 in both groups. And TLR was very low as well in these groups. So we could say that in a drug-coated balloon strategy in STEMI is efficient, safe, and feasible, despite a small risk of coronary dissections requiring bailout stenting. Results up to 9 months follow-up is great. And truly leaving nothing behind without compromising results can be achieved with the drug-coated balloons. And the further investigations such as patient and lesion characteristics who may benefit a drug-coated strategy, a balloon strategy is important. Clinical follow-up will evaluate the prognostic value of FFR as a physiological endpoint in these group of patients. So that is for acute myocardial infarctions. How about small vessels? In basket small, drug-eluting stents and versus drug-coated balloons were evaluated, and actually it showed that there are very minimal differences between the two in late lumen loss, as you can see, in the diameter stenosis as well. There is slightly lower diameter stenosis in drug-eluting stents, but actually in the minimal lumen diameter that could be achieved as slightly higher with the drug-eluting stent, but not really different. Is there a role for drug-eluting balloons in small vessel disease? I think there's definitely a role. And as you can see that in the DARE trial, the primary endpoint was similar, and the non-inferiority endpoint was met with the drug-eluting balloons in these two groups of patients at 6 months angiographic follow-up. So I think I would say drug-eluting balloons is something that is really exciting for us in several types of lesions, such as acute myocardial infarction, where the vessel size might actually become larger after initial POBA with a drug-coated balloon, and maybe in bifurcation lesions where the side branch could be treated, and focal restenosis in bare metal or drug-eluting stents can be treated with drug-coated balloons. As well as I think in small vessels, I have been able to show that this is a convincing data to at least investigate further. The proposed treatment algorithm, at least in our institution, has always been a treatment of ISR and with make sure there are no stent fractures, and then whether it is neointima, you can look at the drug-coated balloons, drug-eluting stents, or vascular brachytherapy. So if it is a bare metal in-stent restenosis, drug-coated balloons or drug-eluting stents could be said. Actually, as you said, European guidance are given 1A for drug-coated balloons. In drug-eluting stent in-stent restenosis, still drug-coated balloons are much safer to use in this group of patients than multiple layers. And if that fails, actually, you can try vascular brachytherapy. And if all fails, obviously, you can still consider bypass surgery in those groups of patients. So in conclusion, I want to say that still the incidence of in-stent restenosis for drug-eluting stents ranges from 3 to 20%, depending upon also patient factors such as diabetes being the most important risk factor. Imaging is important to understand the mechanism of stent failure. Drug-eluting stents and drug-coated balloons are associated with nearly 10 to 20% recurrence again at 1 year, with the late catch-up after 1 year to 2 years. Drug-coated balloons or drug-eluting stents are effective for both bare metal stent restenosis, even though drug-eluting stents is our current preferred strategy for DES, ISR. Drug-coated balloons is probably the next revolution, and we still have to wait for strong data. Now, sirolimus eluting balloons have come, which have established that there is less slow reflow, slow flow phenomena as compared to paclitaxel eluting balloons. And I think as we move forward, these are here to stay, and very rarely brachytherapy for recurrent drug-eluting stent failure. I'll stop here, and I'll be happy to take any questions. Thank you.
Thank you, Dr. Ramesh, for your excellent lecture. It was really a fantastic one. You have touched all the important points. What is the advantage of DES, and what are the disadvantages of doing in the side branch with a any stent? Presently available any stent, there is 20 to 25% chance of restenosis in the side branch ostium. That is the international figures. So thank you very much for your excellent disposition. But this is a period of legion speak, so we don't allow normally any questions to legion. But however, we can discuss for 5 minutes because we are waiting for Dr. Colombo, and therefore we lost some time because our next session is due. So if chairpersons allow me, I would like to start, then we'll be in time, because Ramesh will be with us and we can discuss through chat box also. And I thank you very much, Ramesh. Whenever we are in problem, even if I ask with 10 minutes of time, you are always generous to give your lecture, and that's a fantastic lecture. You are really a legend. So give a big hands to Dr. Ramesh Daggubati, who is a great friend of mine. Don't
thank you.
Mind Ramesh, because this is a legend session, and according you are a legend. So naturally, we cannot, I normally don't allow any questions over this, but there was a discussion. But because of time limitation, we would like to go to our next session, which is on session on CTO, because there are a few Japanese guests of ours, and this will be chaired by none other than Professor A.B. Mehta, Dr. Pratap Kumar, Dr. Arun Kollanusundaram, Vijay Trihan, Dr. H.K. Bali, Dr. Kanak Kumar Mitro. And the expert panel will constitute Dr. Nitish, Professor Nitish Nayak, Professor D.P. Sinha, Dr. Anil Dhal, Dr. S.B. Rai, Dr. Kuntal Bhattacharya, Dr. B.P. Pandey, Dr. Manoranjan Mondal, and Dr. Gautam Datta. So I would hand over the session to our honorable chairpersons to conduct the session. And I would request Professor Mehta, Pratap, my all good friends there, to start the session, please.
Dr. Mehta Sahib is there? Ashwin Mehta.
Pratap, you can start the session. You are a legend on this. So I think the first lecture is with you.
First one. I think
your talk is the first, Pratap. So I would invite you, but just before that, a very short briefing, because no introduction is sufficient for Dr. Pratap Kumar. I have seen operating the difficult of difficult cases, which has been left out by many a person, many legends. He does all these cases, So thank you, Dr. Pratap, and I don't want to waste time. And he will be talking on my CTO toolbox. So Dr. Pratap Kumar, please.
Okay, sir. Thank you. Thank you very much, Dr. Dhiman Kahali and all the chairpersons of CTO session. I will just go to I'll share my slide. A CTO toolkit, actually, it consists of a lot of things. One, it consists of the sheath, guide catheters, Y connectors, guide wires, etc. Microcatheters, support catheters, guide wires, dissection or re-entry equipment, snares, uncrossable and undilatable equipments, and finally, complication management. So the sheath, actually, if you go to the sheath, femoral sheath and radial sheath, you have a long sheath is actually required in the case of a straightened iliac tortuosity. It facilitates the guide catheter and the wire manipulation, and it is actually reduces the risk for the guide catheter kinking. Disadvantage is actually increases the risk of thrombus formation within the long sheath. Disadvantage is actually of the 6 French. It is actually having a weaker support, inability to use the trapping technique, inability to use simultaneously a balloon and a covered stent. Guide catheters in the retrograde approach, 6 French radial guide for the retrograde side and 8 French for the femoral thing. A 90 centimeter guide for the retrograde shortens the distance that a retrograde wire can be externalized. Shortening the guide catheters can be used in retrograde system. Disadvantages of shortening the guide catheter is actually poor torque transmission. Side holes are used only for the RCA-CTO and not for the unprotected left main. What are the pros? 6 French is actually all transradial, definitely less bleeding, but it cannot always trap the thing, and all EDR over the long wires and less support is not possible. In a 7 French system, you can use a Corsair and a trap and a crossbars and a trap, but no Stingray is possible. If you go to the 8 French, you can use a Corsair and a branch anchor and a trap, and a Stingray and a trap, and real-time IVS can be done with the help of an 8 French. 8 French is usually femoral, uncomfortable, and there is a high risk of bleeding. Guide catheters, actually extensions are guide liner, trap liner, guidezilla, guideon. We have only guide liner and guidezilla available. Rest is not available with us. When you go to the guide liner, there is an inner PTFE lining and a stainless steel coil. You have an outer layer of the Pebax polymer and a silicone coating for the lubricity. Trap liner with a guide extension plus the wire trapping is trap liner available in the US. It is not available with us. Guidezilla 2 is available. It is wonderful. It is better than the earlier version. Advantage is actually a stainless steel core embedded in the polymer, and you have definitely there is a hydrophilic coating. It is actually having an atraumatic trip. Guideline and navigation catheters are used with the help of a balloon there, and it is actually useful in extension to the target size. You have a guide liner. This is a technique when you use a balloon. Always use the balloon. Take the guide liner down. With the help of the guide liner, you can take them down. If you can use the guide liner the other way, guide liner retrograde intervention, you take a guide liner when you have a difficult entry of the retrograde wire back into the system. This is actually the similar system. I have taken the guide liner from the antegrade catheter, the retrograde wire pushed into the guide liner. Once it is pushed, you can trap it and finally finish the procedure. And a complication possible with the guide extension is deformation of the guide wire, stents and other equipment. You can have a coronary dissection is also possible with the guide liner. You have over-the-wire system as well as microcatheters used. Actually, it provides a better support. It allows the reshaping of the guide wire and allows easy guide wire exchange, and it protects the proximal part of the vessel from the guide wire induced injury. Microcatheters are preferred over the guide wire balloons because it is an accurate visualization of the tip location. It is more flexible and track better than over the wire balloon system, and is less tendency to kink. So we use always a microcatheter and preferred than the over the wire balloon system. You can actually, when you take the balloon also, if you see a guide wire with a microcatheter, the wire is actually kink on the lesion. But when you take a microcatheter, with the help of the microcatheter, the wire can be extended and you can cross the lesion. When you see the spectrum of microcatheters, if you take the over the wire balloon in one side, you can have a turnpike in the other side. You have fine cross, super cross, and microphore, as well as a turnpike. When you use a retrograde system, we may use a caravel or a turnpike, or even use a fine cross. Retro and andograde, you can use a corsair and a turnpike. This is actually a difference between, for an antegrade approach, we can use a pushable microcatheter, which is fine cross and MCAT. If you want, it's a rotatable microcatheter, which is the corsair and the turnpike spiral. When you use the microcatheter for the retrograde approach, you have a septal crossing. You can use a corsair or a turnpike. In a low profile microcatheter, you can use a fine cross, turnpike LP, caravel, or micro LP. When you use a Corsair Pro, is actually advantage of the Corsair Pro is actually distal shaft is actually hydrophilic, and this is actually advantage of the Corsair Pro. Corsair Pro actually improved distal flexibility is possible with the Corsair Pro, and radio opaque marker removed to increase the flexibility from the Corsair to the Corsair Pro. So when you take a Corsair Pro, you can use an antegrade technique as well as retrograde. This is actually the Corsair is taken from the retrograde system, and I use always, sometimes I use a antegrade system also to take a Corsair to cross the lesion, not only for the retrograde system. Caravel is actually a soft one designed to advance forward push, but is always important, it should never torque. Even if it is torque, only minimal torquing is allowed. Also could be rotated to cross the challenging collaterals, but Caravel is not designed to withstand aggressive rotation and enhancement. And a low profile tip is actually the advantage for this caravel. This is actually a caravel system. You can actually take the retrograde wire easily when it is having torqueable. Actually, in the torqueable vessel, it will easily cross the lesion and go up. It is actually a retrograde system. The Corsair did not cross, but caravel easily crossed. Fine cross. I prefer to use this microcatheter more because actually it is actually a 2.6 French and even 1.8. The fine cross is actually, catheter is actually, as well as the Corsair, caravel, and turnpike are used to deliver even a microcoil also. Actually, it is actually successful in crossing the lesion. Unsuccessful lesion can be crossed with one. Successful in advancing past the fibrocalcific obstacle, which cannot be done by caravel. Turnpike and turnpike LP is not available in our country, but it can be rotated in either direction. Turnpike spiral is actually to advance clockwise to advance and counterclockwise to withdrawal. Basically, it is opposite to the Taunus, which is used by many of us. Basically, it is clockwise to withdraw and counterclockwise to advance. So the torqueable microcatheters are turnpike, Corsair, and turnpike, and non-torqueable are caravel and fine cross. So this is actually Taunus. Taunus is basically when you use Taunus, when you have a calcified lesion, it is not crossed. We can take this Taunus. Moreover, in a case of a CTO with a calcium, where the wire is not crossed, Taunus can be taken, and then you can cross the wire by which you can go ahead with and do the procedure. This is actually a two case of Taunus, where the Taunus did not even cross even that CTO segment, where I finished finally with a rotomation. Mamba catheter, which is again not available, which is actually a microcatheter used in the US and the Europe, not used by ours. 5 taper songs. So the twin pass, dual lumen catheters are very important. We have only 2 dual lumen catheters in our country, Crusade as well as Sasuke, but the other twin pass and twin pass torque is not available with us. Advantage of the dual lumen catheters are multiple. Basically, Crusade is a dual lumen catheter mainly available in our country. You can use for parallel wire technique. The wire in the CTO with a bifurcation at the proximal segment can be used by this dual lumen catheter. Wire CTO with a bifurcation at the distal tip, on the proximal tip as well as the distal tip, at parallel wiring, and wiring the side branch again can be done by a dual lumen catheter. It facilitates a reverse guide wire technique where it is a very sharp angle, a side branch then again can be taken. So when you have a wire in the subintimal lumen, a use of a dual lumen catheter in the parallel wire technique, the first wire in the subintima, the second wire can be taken easily with the help of a dual lumen catheter. For example, this is the case. When you have the wire is actually gone into the septal artery, not into the true lumen. So what I did is actually, this is actually a dual lumen catheter. Basically, you can see the wire coming down. This is actually the wire coming down and crossing the CTO segment and going down. Basically, this is actually a dual lumen catheter. With the help of a dual lumen, I cross the CTO. A Wenger catheter, not seen nowadays, but it can be deflected up to 90 degrees, especially when you have a side branch which is very, very highly angulated, we can use. Supercross basically is a straight tip and at various distal tip angulation. Retrograde approach by a saphenous vein graft, it can be used. Multicross and center cross are, multicross is actually having the lumen is in the central part, so the lesion, if it is in the CTO segment, can be crossed away from the subintima. In center cross, you have multiple lumens where you can use multiple wires to cross the CTO segment. Again, it is not available in our country. So when you go to the guide wire, we have some techniques. CTO wires have a polymer jacket wire and open coil wires. So the tapered wires are the most important. You have a open coil wire, actually no polymer jacket. You have a ultra low tip stiffness is actually Suho 3 wire. Low tip stiffness is Zion and Samurai wire. High tip stiffness is Miracle 3 and all. Tapered wires are the low tip stiffness is a crosset which is not used nowadays. Run through wires. High tip stiffness is a hydrophilic wire, where again we may use a Confianza 9 and 12, which I use preferably Gaia first, second, and third, and a high tip stiffness wire with a hydrophobic coating is Confianza 9 and 12. So the stiffer wire from the XTR into the Confianza 12, but we use XTR and XTA as the first wire to cross the CTO. When it is not crossed, we go to Gaia first, Gaia second, and Gaia third, and we use Miracle 6 and the UB3 wires are preferably to be used when you wanted to cross a really severe fibrotic and calcified lesion, and Miracle 12 and Congress Pro 12 are the wires to be crossed in a severe calcified lesion. So the CTO manipulation, I'm not going into the details. You have a small tip to be made, only 10 to 50 degree with actually 1 to 2 millimeter away from the tip. Wire bias strategies are very important. Microchannel means you have to use filter XT. When you have no microchannel, only penetration, you can use a Confianza Pro 9, 12, Gaia second, third. When you have a tortuous wire, where we should not use a Confianza Pro 9 or 12, where you have to use a polymer wire, soft polymer wires, where I use XTR or a filter FC and then cross the lesion and then take it. In a tortuous with a long occluded wire, you can knuckle wire system where XT and Pilot 200 wires are the preferred wires. And you can even use a Gaia second or Gaia first for the knuckling system. So the antigrade filter FC is the XT is the ideal one, filter XTR is the ideal one. If it is cross vessel of the occluded segment is known, you can take a Gaia second or a Confianza Pro. If it is unknown, you can take a Pilot. A retrograde crossing, I prefer to use the Zion wires as well as a Suho 3 wire. Now externalization with the RG3 wires. So the wire escalation, if you just see a soft tip polymer wire like XT and Whisper, if you got a moderate stiff wires like polymer jacketed wire and a heavily tapped wires like that. Knuckle wire, you can use XTR, which I explained already, or Pilot 200. Crossing the channels, we use a Zion or XTR. In an epicardial collateral, always, Suho 3 is the preferred wires. Wires for externalization, you can use any wire, but the preferred wire is an RG3, where this wire itself can be used for the stenting from the other system. So the microchannel crossing, I told you, Zion and XTR, cap penetration, Pilot 200 and Gaia, knuckle dissection for XT and Pilot 200, dissection re-entry, Stingray wire, retrograde crossing, Zion FC, as well as the Suho 3 and externalization with RG3. And this is actually an antigrade intervention trial. and failed, dissected segment, antegrade wire in the subintima, retrograde wire not able to cross. So what we did is actually the antegrade wire in subintima, retrograde wire in intima is the toughest of the retrograde system to use, where I used all the wires, cyan black tried, Gaia second tried, nothing crossed, Miracle 6 tried, not crossed. Finally, I crossed with the Congress Pro 12. So this is actually the antegrade dissection re-entry system, dissection with the knuckle wire, re-entry, and this dissection, I'm not going into the details of that. Snares can be used to capture the retrograde guide wire to antegrade guide wire catheters. Uncrossable and undilated lesion, you can use a balloon, microcatheters, laser, atherectomy, and cutting, where we crossed the wires with antegrade, no microcatheter, including the Corsair and Caravel did not cross. We did not able to cross anything. What we did is actually a burring, rotor burring done with a 1.25 bar, and finally crossed and finished the case like this, 2 stents. Another CTO segment with circumflex, which was actually earlier done an angiogram. With the help of that angiogram, I crossed the wire. Tonus did not cross, 1.25 bar, finally with a stent in the circumflex and finished the case. So finally, the complication management equipment. You have covered stent, coils, and pericardiocentesis tray. You should understand the perforation management is actually universal algorithm for perforation. Inflate the balloon to occlude the vessel, number 1. Number 2, you have to use IV fluid and pressas. And the third is actually pericardiocentesis if there is hypotension, as well as with massive pericardial effusion. You can notify the surgeon, I don't do that. Persistent extravasation, you can monitor the patient, definitely if monitor the patient and treat the cause. A large vessel perforation, you can use a covered stent or a prolonged balloon inflation. If a small vessel perforation, you can use embolization with a fat, coil, thrombin. I usually use fat and blood clot, covered stent over the perforator branch. If a small vessel, very difficult, type-specific treatment. Overview of the complication of the perforation management. Balloon inflation should be done for 8 to 10 atmosphere, but that should be done for minimum 10 to 15 minutes. Embolization can be done with fat, coil, thrombin, and thrombus. And these are the different types of covered stents available in the country. Thank you very much, because I exceeded 1 or 2 minutes more. Thank you very much. Dr. Dimanta.
Thank you, Dr. Pratap, for your excellent speech. It was a superb one, and it is a fantastic one. Thank you very much. So there is no time for discussion, Pratap, but don't leave us. You are chairing the session as well. So I would ask another young, brother of mine. He is also a wonderful, wonderful operator. Can you listen to me? Some disturbance in the audio, it seems. He is Dr. Arun Kollanasundaram. He is also an excellent CTO operator, and I see him in many of the foreign conferences where he is operating, and that's really very nice to see. So Arun, please start your talk on how to choose and engage the correct collateral in retrograde approach. So Dr. Arun Kollanasundaram, please. And we also we are very happy to get Dr. Carlo Di Mario with us. So welcome, Dr. Carlo Di Mario in City of Joy, and thank you very much for joining with us. Soon we'll be listening to you. Next lecture is yours. So thank you very, very much for giving your valuable time.
Thank you. Hey guys, thank you so much for having me in this fantastic conference. Really appreciate it, Dr. Kahali. Thanks for giving me the platform. It's truly an honor and a privilege to present here. So guys, you need to let me share screen, the host. All right, great, thank you. There we go. All right, basic. All right, I hope you can see my screen now. I'm not at the beach. All right, there we go. So, are you guys seeing it?
Yes, sir. Go to the full presentation, Arun.
Yep, there we go. All right. So this is kind of it's always a tough act to follow, Dr. Pratap Kumar, but I'm going to do my best. So we got it. So it's all about collaterals today. So in the next 15 minutes, I'm going to kind of give you an overview on some do's and don'ts, etc. So that's me. We're going to look at some of the basics look at some of the views, know your hardware, and again, then comes to the meat of the matter, which is crossing collateral. I'll show you some case examples of how we do it. So fundamentally, retrograde, you got to gain access distal to the CTO, so for which you can use septal collaterals, epicardial collaterals, or bypass grafts. Then you got to cross the CTO, antegrade and retrograde, essentially kind of connect the planes, whether it's a true to true crossing or it's some kind of a dissection reentry format. Once you do this, you still got to finish your PCI. I hope most of the times you do this over an externalized wire. So these are like, I mean, this is kind of like the big picture thing. So going back to the basics, if you want to do a CTO, pretty much use guides on both sides. Really, you want to have dual access. You don't want to pan. Know your angles. This is kind of important. I think a lot of people, I mean, you want to, when you're planning your PCI, make sure you do this right. Get the setup shots right. I think it's Pratap gave a fantastic overview on hardware, so thankfully I don't have to spend too much time on that. But you got to really know the wires that we use for crossing collaterals. So it's important that different wires have different properties. You need to know this. In the interest of time, I'm not going to go over the individual properties except for one, and I'll talk about that briefly. Also, you got to know your microcatheters. What can Corsair do? What can Corsair Pro do? What can your Turnpike do? What can your there are a plethora right now. You got Fine Cross, GT coming up, etc. I think it's important that we know the strengths and weaknesses of each of these. So I'm gonna, again, this is not going to be an elaborate talk on any of this stuff, so we'll kind of keep going. I do want you to pay attention even as you're crossing the collateral in terms of how you use your torqueable catheters versus not. And it's important that you, people that are early on, and I think there are a lot of operators in our country that are still early on in retrogrades, so it's important to know how you handle these two, all right? So the next thing, guys, I'm hearing a lot of background noise. So I would request that the non-speakers mute if possible. So optimal angiography, again, we touched upon this. Low mag, open the shutters. You really want to see everything when you're setting this up. Inject the retrograde side first. You want to really try to pacify the collaterals fully, and then inject the antegrade. Long runs so that you really see everything. Don't pan. I've already stressed this. This is particularly important in post-bypass patients. Sometimes you will need triple angiography. And once this is done, you have a good plan. And now, again, this is fairly basic, but for those that are starting early on, you need to know for an RCA CTO, what are the right angles? If you want to look at the whole course of it, you really want some kind of an LAO view. For you to look at the bifurcation, which is your, APL bifurcation, you want to take some kind of a LAO cranial projection. For looking at the septal collaterals themselves, oftentimes an RAO cranial is useful. And for the distal part of this, an RAO caudal or a straight RAO is very useful. For your LAD CTO, again, there are a couple of views that we use. These are the LAO or an RAO caudal for looking at the proximal cap and sometimes for the length, LAO cranial for the bifurcation, RAO cranial for the lesion length many times, and for the collaterals themselves. For the septal collaterals, a straight RAO or a RAO cranial. For circ, why am I admitting? Okay, somebody admit. Optimal projections for the circ CTO. For you to look at the proximal cap, again, a caudal view is very useful. Distal cap, some kind of an LAO cranial view. Again, most times you're going to use some caudal or a RAO caudal view. And again, these are not set in stone. Look at it, understand it, and then move this around. All right, but these are just general guiding principles. Okay, guys, I'm being asked to admit a lot of people. I'm not sure about how and why I'm doing it, but I'm just admitting everyone that wants to. Entering the collateral. It's not a big deal. Think of it really as like entering a side branch, a small side branch. So typically you want to enter with a microcatheter and a workhorse wire. Do not use your CTO wire, and I see this often. Don't get lazy. A workhorse wire and a microcatheter to enter the collateral. Sometimes you will need a dual lumen catheter. I'll show you an example of that. Sometimes you'll have to use more advanced techniques like a reverse wire technique, or you might want to use a polymer jacketed wire to enter this itself. But really, this just comes down to getting into a side branch. Okay, and then off the collateral, we've talked about this: epicardial, septal, SVG, and a lima. All right, so these are the various collaterals. And you also want to know what are the usual collaterals that are present in various CTOs. So again, I'm just going to give you the bird's eye view here. Many times in an RCA CTO, it's usually a LAD septal to a PDA. We know we have a lot of beginner audience. I would say this is your safe zone. Like, take a left LAD septal into a PDA. And then there are other collaterals. Again, in the interest of time, I'm not going to go over each of these. In a LAD CTO, the vast majority are probably going to have some kind of a PDA septal to LAD. I'm going to skip this. And then a circ CTO, which really you don't want to do unless you have done a lot of CTOs. The most common one is some kind of a diagonal to an obtuse marginal. All right, I'm going to skip all this. So let's just look at septal collaterals now, which I think is the most important one. Understand that all collaterals are not created equal. It gets more and more. If you have a straight channel, there's just some kind of a scoring system. Doesn't mean you do or don't do it. If you don't see any connections, it's 0. If you see some kind of a thread-like continuous connection, it's CC1. And if you really see it nice, it's like a branch by itself, it's a CC2. Want to ideally start with the CC2. And then you also want to see how does it take off from the donor vessel. If there is a really nice, if it's short, you got an obtuse angle, it's a 1, an acute angle or going through a stent is 2, an acute angle or implanted stent with a lot of tortuosity is 3. And sometimes what this doesn't even factor in is that sometimes you even have stenosis with the takeoff of the branch itself. Again, tortuosity, the more tortuous it is, the higher the score. And obviously, the more difficult does it get. And then comes the final thing where the angle at which it enters the recipient vessel also makes a big difference, right? So, and it also depends on how far is this from the distal cap, because, do you have enough of a running room? So you want to factor in all that stuff. And all these, obviously, there are simple ones. And then obviously, the more score you rack up, the harder it is. And then in general, LAD to PDA is easier than PDA to LAD, all right? So that's then now when you look at the epicardials, which again is for for once you've graduated and you're comfortable with retrograde, start working on epicardials. Once again, size, how it exits, how tortuous it is, how is the entry. All of this matters. And again, in the interest of time, I'm not going to go into the scoring systems themselves, but understand that what makes something really challenging versus what is straightforward. Vein graft, again, if it's an open graft, great. If it's closed, it's hard. At what angle does it anastomose, and where is it located? So all of these will influence how hard it is going to be. Lima, frankly, yes, there's a scoring system, but really you should try and avoid it, especially if it's the only remaining one, which many times it is. So you got to be really an expert before you touch a Lima, a collateral through a Lima itself. So I think it's important for you to do angiography and evaluate all this systematically for you to be doing this safe and successfully. Now, so for our audience, really, I think let's focus on septals, right? And septals, usually they can be, the stenosis is not particularly a big problem unless it's super, calcified, and at the ostium you could have stenosis. Length is usually shorter compared to your epicardial or atrial collaterals. Most of these cases really should be septals if you have an option, and these are dilatable. The other collaterals are not. So let me keep going. All right. So again, these are just some examples of what's easy. Again, as you see, somebody has panned here and you really don't want to pan. So that's CCO, this is CC1 and grade 2, which is really what you should be focusing on when you get started, all right? Tortuosity, again, you guys know what's tortuous and what's not, so I'm not gonna waste a lot of time here. Now, this is what I would like to spend some time on. If you wanna surf, use a polymer check-out wire, and you could use a cyan black. To surf or not to surf is a huge question. Septals, it's probably okay to surf. Don't get dogmatic. Sometimes you start with surfing, doesn't work, do a tip injection, and then identify the course. It's not a bad idea to inject. Remember, it's just going to make it a little bit sticky. You got to wash it off with saline and then start wiring it. And then for, when you have a less visible segment, like, not able to see it, Oftentimes I go to a Cyan Black. A Fielder FC used to be the wire before some of the newer generation. Samurai RC is from Boston. Still, that works pretty good too. And occasionally, rarely, you will use a polymer jacketed wire. If it's super tortuous, use a Cyan or a Suo 03. And I want to spend some time talking about the Suo 03. I think I got a couple of minutes left. So this is a wire like none other. It's got the softest tip. It's really atraumatic. And the key is this wire is not like what we're used to. Typically, you talk it too much, etc. This wire almost has a life of its own. You got to let it find its path. The softest wire in the market. Be careful. The key point is that it is super flexible. One-to-one torque is phenomenal. And as I think Pratap said, it's almost the default wires for epicardial. How do you use it? Torque no more than heart rate. I mean, I'm not a big torquer person, but for this, I do use the torquer. Use your microcatheters judiciously. So I'll kind of show this to you in a little bit. And how far you are from the tip will determine how the wire handles. And sometimes I got to withdraw the microcatheter, inject. Okay. Left hand to control advancement. Come back. Do not over torque this wire. That's asking for trouble. Never more than 120 degrees. And move your Caravel or your microcatheter to within 3 centimeters when you want to really advance it. You want to let the wire kind of find its path, and sometimes you got to get it closer. I'll kind of show you a few examples of this. So, in a nutshell, Suo 03 is pretty much applicable across the board, whether it's septals or epicardials. Works really well. And here are the other ones. CC0, I do tend to use Cyan Blacks a fair bit. It's still septal. My workhorse wire is a Cyan. Again, I'm going to, in the interest of time, skip some of these. Remember, you will often have to use a particular angle or a view to get into the septal, and to delineate the course, you're going to use another view. And then once you exit and are back and you're working on something else, you got to change angles. So that's important for you to know. Again, this is a beginner kind of stuff. Anatomy of the septal channel. So use your LAO to delineate the course of the vessel itself of the CTO, and then an RAO for understanding how the septal itself is and for crossing it. And once this is done, and again, nothing to write home about. Once this is done, let's move on. Once you've crossed, switch to an LAO view, understand this whole process. And here is from a PDA, like we already said, from the right to the left is always harder. Suo 03 with a Caravel. And again, I'm not going to show you the whole crossing of the collateral, but the key is you might want to use different things once you've crossed and you're here. Again, change angles so that you understand the CTO segment itself. So septal crossing, really, what do you want to know? LAD to PDA is typically easier, it's straighter. Choose the most proximal collateral. You might want to, surf or do a tip injection. Either really works. Go gently. If you're using a non-torqueable catheter such as Caravel, don't really torque it too much. Just gently advance it. You could use any of the microcatheters that are available, but make sure you use a long one. So the wires, we've already talked about it. And then location of the vessel course are more important than the size of the collateral itself. And sometimes you do have to do it injection guided, PDA to LAD. The getting in might be a bit of a challenge. And again, you might have to torque a little bit more because you want to get things through. So many times here, I tend to use the Corsair Pros or XS once we get that, or a Turnpike LP once we get that. We have talked about the wires. Sometimes you do need a newer lumen catheter to even get into the micro. Yeah,
your time is over. So if you kindly conclude your lecture, because we have also Dr. Masahisa Yamane. We lost the line of Dr. Colombo, but Dr. Yamane is also waiting, and so we have foreign lecture. So this is actually if you kindly conclude it, okay? Don't mind, please. Yeah, don't mind. Yeah, don't mind.
No. This is all good. I think we just are at 15 minutes. This is the end of the beginner section, anyways. And I thought this should be probably appropriate for for most of the audience here, since most of them are just getting started. So I'm just going to stop at this. Most patients do have collaterals. Vein grafts are safer than septals, greater than epicardial. You really need to think long and hard before using an IMA graft. Be good at what you're doing. Newer wires, you should be able to get this. General take-home points, do not pull. It's always a bad idea. Learn the steps. Crossing collateral, I do want to emphasize when you're part of the retrograde cases, never dilate an epicardial, and be prepared to deal with complications. You already have the toolbox talk. Thank you very, very much.
I think if there is, since there is no time, we can go ahead with the next talk by Carlo Di Mario. Carlo?
Hi, Pranab. How are you?
Oh, fine, Carlo. We can go ahead with the lecture. We are going to talk about the anti-grade escalation wiring, right?
I will do with pleasure, but next year I want to come to Kerala again and see you.
Sure. Okay, Carlo, please.
Let's try to share screen since I understand that we don't have much time. However, it says host disable attendee screen sharing. So
yeah, and
should solve this.
Yeah, please go ahead.
Please go ahead.
Hey guys, on the tech support, can you just admit people? Because while we are talking, I keep getting these pop-up messages. So if someone can help Dr. Mario so that he doesn't have to do it.
Okay, Carlo, please.
Perfect. So let's go full screen.
Good.
Excellent. So you get a glimpse of Ponte Vecchio in Florence. Looks a little bit like India, I think, isn't it? Very crowded, many people. And I would like to join this meeting also in my capacity of recently elected president of the EuroCTO Club, inviting you all, of course, to join all our activities in the future. So this is something going beyond the activity of the club. That's a group of CTO interventionalists put together by Dr. Brilakis. And you see that some of the main principles, this sort of key rules that guide the treatment of CTO lesions start by saying that you should always do dual angiography when is needed, and of the 4 crossing strategies, the one that is first is the one which is my topic assigned, anterograde wire escalation. Afterwards is mentioned dissection reentry and the retrograde issues. I hope that all of you, even if you are the best retrograde operators, and I really enjoyed the talk of Arun before with all these nuances to obtain optimal crossing of collaterals, agree that a primary retrograde approach is not what you should go to unless you are forced to do that, like when you have a true aorto-ostial occlusion, when already has been tested the lesion, and this is truly impossible to penetrate, but you should always ask yourself, was a wire strong enough use in a previous attempt? Was it properly supported? Did you try to use this, say, unconventional base stretch and go techniques to try to go through? When there is a stumpless lesion, when you don't know where to go, of course, that's a good potential reason to go retrograde. But again, ask yourself whether intravascular ultrasound in a side branch could have seen the location of the proximal cap. So an retrograde attempt was made possible by this. I'll try to show an example. And even when you don't have an idea, and if they're having penetrated, remember, a knuckled wire always has a chance to move forward without taking excessive risks of perforation. We take advantage of our large database. This was presented 1 month ago in one of the few live real congress in presence in Berlin of our CTO club, 140 people present, more than 250 connected, and presented the result of our database with around 4,000 new cases entered by full members and associate members respectively per year, and compare with past experience. So you see that there is a trend towards improvement of our success rate that went from the 80s in 2008-2009 when the club was founded to almost 90% in the most recent period. And this is due to an improvement throughout all the types of approaches that you can use, including antegrade wire escalation. This is not a technique that remains still in recent days. New wires like the Gaia family, new approaches like have been shown by Dr. Kumar, the dual lumen catheters. But of course, we are also indebted for this success to an increase in use of retrograde approach through, again, the very performing microcatheter and wire shown before by Arun Kalyanasundram, and by the development of antegrade dissection, re-entry, and the Stingray technique. How much are these techniques, however, used? Antegrade remains having the lion's share. Also in the hands of the expert full members of the club, around 60% of procedure remain antegrade. Of course, it all depends on your case mix. I guess the younger associate members are confronted with lesions that rarely had been previously attempted. More frequently, they go to an anterograde approach, and they have similar success rate as we do. Americans have, as you know, this hybrid approach that in theory almost immediately goes to retrograde, jumping there if there is longer than 20 millimeter long occlusion. Is it really true? It's not. There are numbers in terms of retrograde. When you look at a registry like Progress, is around 16%. Vast majority of cases remain done conventional anterograde wire escalation with a limited number of anterograde dissection re-entry. Complications are low in our registry. As you can see, almost all are below 1%. Death in particular in red is very low, both full member and associate, except wire perforation that is sometimes an impalpable complication with nothing really clinically happening. But remember, anterograde is the technique with the lowest number of complications that tend to increase, almost doubling for retrograde, for the obvious reasons that you instrument two vessels and that you go through extremely fragile and tortuous vessels. But let's concentrate from now on, after having said why I think anterograde remains the bread and butter of most CTO interventionists, how we should do it modernly. Well, first of all, you notice in our database a change from conventional, old-fashioned, all-femoral approach to the use of at least one radial, as you can see, in more than 50% of cases. This was, in fact, the case also in this lesion that I will show as a template to go through the various steps that I will illustrate. So I think you will agree that there is a total occlusion of the LAD beyond this large diagonal branch. You can barely see the distal vessel through homolateral collaterals, and the definition of CTO has recently been slightly modified. These are the new CTO ARC definition just published. Occlusion must be total, no flow. The distal flow should always only come from collaterals, bridging ipsi or contralateral. You also want not to see contrast staining indicating thrombus at the area of the occluded segment. And if this is the definition that I think you all agree, this particular lesion fulfills, this is the image that you get when you switch the light on and you inject contralaterally, and then you start seeing via not so appealing septal collaterals the distal LAD, leaving a segment of around 4 centimeters of occlusion. So did we go through these super complex septal collaterals with few hopes of success and higher risk of complication? No, we didn't. We went to an intravascular ultrasound approach, and what we did was to show where the occlusion was. Now we are going a little bit back and forth to show you better. There is a large plate of calcium that complicated our life. I'll go a little bit quickly, sorry, in the interest of time. I don't think we use enough as interventionalists in Europe IVUS during CTO recanalization. I think should be a must, including a final look to optimize success. But you see here, I don't know why it doesn't really move, but I'll do it myself, that my first wire, also it looked going in the right direction, in fact, was clearly subintimal. I went all over, I restarted, I had my ultrasound in place while I was puncturing with a super stiff Confianza wire, and at this point, I convinced myself that I could advance my Caravelle through the tip of this occlusion and that I was in the right direction. And then what I did was not to continue, even if theoretically this is a relatively straight segment with the Confianza, but to step down, to use a softer, safer wire, which I think should always be the case. I initially started with a Gaia, probably a mistake. Gaia is a great wire, but it's very difficult to put any secondary bends on top of what it already has. On the contrary, you can do it with Miracle, you can do it with Confianza, what you probably call Conquest down in India. And when you put the tip of your microcatheter in the occlusion, step down again to a Gaia. In this case, I went with a second, and I followed the normal rule to just move and deflect, helping yourself to reach the distal vessel, also by the tactile feeling of having an impenetrable area when you go against the wall. So the wires we use to start are always soft wires. Of course, it will depend in part on what Dr. Kumar said, presence of microchannel, presence of a stump, and so forth. But you see, an attempt, I think, is always worthwhile. You have only to stop quickly if you go in the wrong direction. And you see, also, they are very important. The final use of a Confianza or a stiffer wire, anyway, is not so high because of this stepping down technique. So Confianza are much more often used than being the very final wire that achieve crossing, that again, most of the times is back to a Gaia. So that's the final steps. You advance a little bit more your microcatheter, you look into different views, you are perfectly coaxial with the distal vessel in two views, and then you advance your wire. And in this case, I achieved a crossing that is not fully clear in this view, but I think becomes much more evident when you see the wire that is already inside the diagonal. The microcatheter followed, and I did a distal injection. At this point, I have to go back into the main lesion, and here it comes, the use of dual lumen catheters that are, as Dr. Kumar said, open to many applications in CTO. I could have theoretically started with a dual lumen catheter. I didn't do because I wanted my ultrasound guidance, but otherwise I could have had a very good support having a wire in the diagonal, and then I could push my second wire through the occlusion if the stump position was clear. You can do it in the same way I did here, as a distal re-entry in a bifurcation close to the site of the distal end of the occlusion, but you can also use it as a parallel wire technique, and then you spare the time to go with the second wire through the occluded segment. You move these very, especially Sasuke, fine catheters near the the mid distal segment of the occlusion, or wherever you believe that your wire became subintimal, to reposition it in the right direction. So look how quickly they are becoming adopted in Europe. Now 14% of CTO procedure are done with the help in some phases of the procedure of dual lumen microcatheters. And this is a consensus document we are working on to recommend which type you should do. The rest was easy: balloon, stent, the occlusion stopped at the bifurcation, so I didn't involve that, leaving a small narrowing in the second diagonal branch with a short stented segment. And I have the rare privilege of showing also very good follow-up. This patient being mainly asymptomatic, you never have a chance to check them again. But in this particular case, because of some minor changes in the stress echo, probably related to the presence of this narrowing at the ostium of the second diagonal that we treated with a coated balloon, we confirmed the presence of a good result, and this is after a coated balloon. I often use the concept medical sirolimus eluting balloon for this type of lesion, and we are in Transform, so unfortunately we couldn't enroll this patient because there is already a stent in the main vessel, which is a contraindication for this particular trial. So this is the most recent document of the EuroCTO Club, the third revision of this document. I won't go through all the steps, but believe me, we occasionally adopt also techniques like mini-star or like anterograde dissection re-entry using the Stingray. Is around 5% of all our total numbers. We tend to use it a bit more as bailout as initial strategy. Might be sometimes a mistake, to be honest. My conclusion: there are few cases where the retrograde approach should come first. Be brave in puncturing with stiff wires when you know your direction, and intravascular ultrasound can help. Also in stumpless lesion, as in the case I've shown. After you are punctured, however, be always shy and humble. If you don't know the direction of the vessel, before embarking into big knuckles like our American colleagues like pushing and pushing, I still prefer to use the finesse of our Japanese friends and use wires like Gaia, which will take more time, but I think more safely will take you to the position you want. Consider Stingray, however, if retrograde is difficult and distal lumen visualization remains good. Of course, it remains good if you don't push your initial wire failing and dissecting too far. You should work quick enough, use little contrast and radiation. Be ready to switch, but not switch in 5 minutes. Switch when you have exhausted a certain modality and you have then to change gear and go to a successful mode. Retrograde technique has progressed, has improved outcome, is needed if you want 90%. You will not get 90% only with anterograde. But again, remember, don't go for crazy distal, super tortuous, super fragile collaterals. One death is not worth 10 successes. Safety remains first. Thank you.
It was a wonderful lecture, Carlo, as usual. I think Dr. Biman Kahali, we have time to discuss, or we will go to the next presentation.
Dr. Kahali, you got to unmute yourself.
I think we can have some discussion at the end. Carlo, is it okay for you?
Well, my only problem is that I will need to connect to OPCI, a meeting in New York.
So maybe we can have a brief discussion now, if that's all right.
Thank you.
One question to Carlo. Carlo, what is your number of percentage of retrograde now intervention in your lab? What is you told retrograde is less than. So what is your percentage of retrograde?
I think it's around 30%, like the average of the club, 25 to 30%.
30%. I think, Arun, any questions?
No, I mean, I think, I would have to agree with pretty much everything that he said. I think safety always trumps success rate. I mean, I think especially once you start doing a lot of CTOs, people don't want to say, well, I failed in this particular thing. It's perfectly okay to walk out, live to fight another day. I do think, my own techniques have kind of evolved over the last couple of years. I do think there is a role for knuckles, but I think perhaps, save it for when you really need it. I think it's always good to have finesse and be good, meticulous with wiring. There's always a role for re-entry in times. Completely concur with all of the conclusions. It was brilliant. Great talk. Thank you.
Okay. Thank you very much, Dr. Carlo. Thanks a lot. Thanks for the valued comments. Yeah. Pratap, I have to be excused because 3 Japanese great operators are waiting because it's 9:30 in Japan, I think, 9:40. So naturally, yeah, they will have their dinner. So I would appreciate if we could ask Dr. Yosufumi Kashima as to talk on the influence of CTO wire development on the success rate of a CTO PCI. Thank you, Dr. Kashima. He was enjoying a summer vacation and still he took my invitation. And sorry to bother you, Dr. Kashima, like that. Thank you very much. He's a great operator. He has come to our center. He has operated and I have got a lot of regards for him. He's one of the best operators in the world. Dr. Kashima, please. Yeah.
Thank you. Hello all. It's very honored to have the opportunity to share you my presentation. I'm talking about the relationship between the CTO wire development and the success rate of CTO PCI. I don't have any potential for conflict. CTO is one of the unsolved regions that's powerful enemy in our field. As you know, in CTO region, the essential problem is invisible CTO body. The invisible CTO body has some components which are true lumen, plug, and subintimal space, including plug including the intima and the subintimal space. So there are 4 pathways of the CTO guide wires, which are an antegrade true tracking, an antegrade subintimal tracking, retrograde true tracking, and a retrograde subintimal tracking. In the CTO body, we have the only 4 pathways to penetrate and to control the CTO wire. We already get a lot of strategy of CTO wiring in those pathways. Furthermore, the strategies are logically connected and in most cases, successful crossing of the guide wire can be achieved if the selection conditions, including the device selection and the timing of the moving to next step, adapted the forget CTO region. To success rate is over 90%. Therefore, it is necessary to understand the structure and performance of the devices to make full use of the devices. This is a CTO guide wire and a strategy history in our field. We got some drawing wire and a penetration wire for single wire strategy quarter century ago. However, the single wire strategy with those wires could not work if advancing into the subintimal space. Even the parallel wire technique occasionally could not work enough because those wires didn't have enough control performance. The IBUS guide strategy was a completely procedure even using 8 French guiding catheter. Because the IBUS of that was so fat. More than 10 years ago, we got the tapered wire, like the XTR. Extreme, which was product by Asahi Intec. This was an epoch-making to born the new concept CTO wires, including the Gaia family, Xion family, and the Slow series for our old strategies. After that, we could make full use of these strategies, including the retrograde approach with those new concept CTO wires. The success rate has improved to over 90% as wires with excellent performances have been developed and many strategies have worked well. Of course, as you know, the development and improvement of other devices also have had a big influences. In the second half, I will show you CTO wire in the detail. This is a CTO guide wire library. As you know, we must understand these wire characteristics before using them for our CTO procedures. This is no doubt that the treatment result will be different greatly depending on whether you can make full use of these wires. Almost operators are concerned with the tip load when the CTO procedures because we want to know the penetration force of using wire. However, it is necessary to be concerned about also the difference in the tip design because the cross-sectional area of the tip is greatly involved in the penetration force. There are three kinds of design, which is a microcone chip, ball chip, and a blunt chip. I will show an in vitro experiment of penetrating force using the same wire, only excluding the tip design. These are Gaia Next One wires with the same specifications except for only the tip design. Once again, the tip load of these wires are quite safe. Please look at the left side moving image. This is a microcone chip type Gaia Next wire. The microcone chip Gaia Next wire could penetrate the proximal cap of this model, like this.
Yes, sir.
Okay. Next, please look at the right side moving image. This is a ball chip type Gaia Next One. The ball tip type Gaia Next One could not work to penetrate the proximal cap of this model. So of course, tip load is important, but tip type is the most important point, like this, cannot work well. In this way, the development of various tip design has a great influence of the performance of the wire, including the penetration force. This slide shows you the whip motion, which is one of the jumping when you want to make some torque of the wire. Please look at the left side moving image. This wire has a complex structure which is Act 1. This wire makes linear torque response and you can't find any whip motion during making the torque of this wire. Next, please watch the another one, right side. This wire has only simple structures, like the conventional wire made by almost product companies. This wire makes the whip motion, so much whip motion, And you can find it as a jumping action of the blue flag, like this, jumping. In this way, the development of complex wire structures has a great influence of performance of the wire control. Next, I will show you another effect of these complex wire structures. As you know, Conquest Pro is one of the old type wire. But this wire has good penetration force until now. Please look at the left side moving image. We usually get the problem of this control, wire control, after penetration by Conquest family like this. Of course, Conquest Pro can penetrate it. However, we cannot control well after the penetration. Conquest family often advance into the subintimal space after penetration action, and sometimes make a coronary perforation. Next, please look at the right side image. On the other hand, Gaia family gave us a good wire control in spite of almost same penetration force compared with the Conquest family. Penetration rate. After that, we can control this guide wire in invisible CTO. Like this, we can control easily. Okay, so this slide shows you the key factors of CTO wiring in these phases. You already understand there are a lot of wire type for our CTO procedure. We have to change the wire operation method and the wire type in each phase to success our wiring. Proximal cap, penetration and tracking for proximal cap. Navigation during tracking for CTO body. Penetration and tracking for distal cap. This is a step and a step down, not only changing the different tip load. So I will share you my guide wire selection for my CTO procedure. I basically choose the best wire for each phase and each case in my CTO procedure from this chart. XTR for the control channel tracking. XTA for the control root tissue tracking. UB3, NEO3, and Gradius for the Amigas CTO drawing. Gaia Next family for the visible CTO navigation. Gaia Next 3 for the controlled penetration, and the Conquest family for the calcified penetration, but only short length, because Conquest cannot be controlled easily after the penetration. However, these wires cannot always work well in an integrated subintimal space. Even ADR and IVAS guide wiring have not been the completely strategies for an integrated subintimal tracking. Therefore, plasma wire system as a new device has been developed for ADR strategy. I can show you only the first generation plasma wire system today. Now, Kato Sensei and Nath Sensei mainly developed in the second generation, but I can show you only the first generation. Simply put, this wire creates a plasma that destroys the minimal amount of tissue required. In other words, this wire makes it possible to create a re-entry from the subintimal space to the true lumen without using the physical pushing force. Okay, please look at the moving image. You can easily understand to create a tiny channel by plasma without any physical pushing force. Like this. very easily create to the re-entry. But this is a sausage. The final edition of plasma wire are currently worked on, so it may be available to you in the maybe next few years. But I'm sorry, I can't say anymore because developing now. This is a summary of my presentation. The CTO wire development has greatly influenced 3 amazing achievements for only quarter century. The procedure success rate has been dramatically improved, and the difference in procedure success rate between each operators has been greatly reduced. Furthermore, the device development have cut the complexity of procedures time in half. The development of devices and strategies is closely linked to improving outcomes. Therefore, we have to always understanding old, thinking present, and creating new. I think that will be brilliant future result in our field. Thank you for your attention.
Thank you, Dr. Kashima, for your superb lecture. Already we are getting plenty of mails like Professor Das Biswas has congratulated you. He is a very senior operator. And because of lack of time, we are not being able to go for the discussion. If we get time, sir, at the end of the session, we'll go for this. And I'm really very, very grateful to you and from the CSI NIC group that, you have given your valuable time, even if you are in vacation. So give a very big hand to Dr. Kashima, and we'd like to meet you very soon, sir. So our next presenter is Dr. Professor Wataru Nagamatsu, and he will be talking on DART for CTO recanalization, antegrade and retrograde. So Dr. Nagamatsu, please.
Okay, thank you very much.
Good evening.
Good evening. Very nice to meet you again. Thank you very much for inviting me.
Okay,
I'm very, very glad to meet you again.
Thank you.
Okay, anyways, I deeply appreciate the invitation. Okay, and let's start my lecture. So, and can you see my
the last slide we can see. Okay.
Okay, thank you very much. And today my lecture is a focus on the DAT, and for the CTO recanalization, antegrade and retrograde. And I'll show that today's contents. And we have just only the 15 minutes. I summarize the 2 issues. One is the indication and the efficacy of the DART, and the second one is the tips. Tips of the antegrade DART and ADR, and the retrograde DART, the reverse cart. And I show the classification of the DART, and that is their dissection and the re-entry technique. And so actually, so this figure is published in 2012, an older one, but very nice classification showed and of this DART. And from the antegrade, and yes, and in this era, we have so many technique and of the DART, star and the contrast, guided star and the mini star and the last. And nowadays, mainly that we perform the Stingray and ADR. And on the other hand, the retrograde one is mainly that we perform the reverse cut technique. And previously, Professor Kashima presented about a plasma wire system. This one is a quite new one, and this technique and used for the both antegrade and the retrograde DART. And how about indication with DART? And this picture is a very famous one. This one is a Western style and the ADR and algorithm. And so I think that this algorithm focus on the anatomy. And please look at this figure. And if this lesion have the ambiguous portion curve and poor disturb targets and appropriate interventional collaterals, yes, and so this algorithm recommended retrograde special procedure. But on the other hand, and so there is no interventional collaterals, and some of the issues. And so this and algorithm recommended integrate, and especially this region length and more than the 20 millimeter. So this algorithm recommended that from the integrate. And so this algorithm is a very famous one, APCTO CRAB algorithm. So this one is a very familiar for us. And so actually this algorithm focus on looks like a technical one. And I'll show you the more detail. And if this CTO have the proportional cap ambiguity, if we can perform the IBUS guided entry, so this algorithm recommended the integrate PCI procedure. But on the other hand, very difficult to see, and even if we are using the IBUS and the intervention quarter present there, and this algorithm recommended the retrograde approach. And on the other hand, so this region have the poor quality disturbance or the bifurcation at this curve. There's no bifurcation, and this algorithm recommended integrate PCI procedure. And especially this CTO region that have the re-entry zone and for the integrate Dart. So this algorithm recommended dissection re-entry. And how about the efficacy of the Dart? And so I show the acute result. And so please look at this number. And so this case number is exceeds 1,000, very big study. And the number 7 is the progress CTO. Number 8 is the UK hybrid CTO registry. And the number 9 is the recharge. And 10 is the open CTO. So those studies show the very nice procedure success, maybe due to the data technique. And how about the procedure pericardial tamponade? And so maybe this occurrence is acceptable. But we have to think about the long-term efficacy and using the data technique. And how about this one? And so this study showed the long-term outcomes of using integrated dissection length and the retrograde approach in the CTO PCI. And especially I would like to hold up the big number. This study, and number 18 is a recharge, and number 12 is number 20 is a demand center ERCTO registry. That looks like a target-based revascularization, the percentage 5.5, and this European study is 13. Maybe they're acceptable. And this paper is a very interesting. So this paper compare with the wire-based and in the long-term result. And between the dot and the wire-based, there is no significant factors in the composite endpoint and the TVR and target lesion revascularization like that. Looks like this dot technique is a very efficacy, and even if the long-term result. But we have to think about this phenomenon. This is my case. So I think that this is a dot problem. As the one is a stent position. So this is RCCTO, and I performed the reverse cut technique, and this I checked the IBUS. So this IBUS study revealed the very big subintimal space. And this shape is a semi-luminous shape. So even if they put a stent, and even if I performed the post dilatation, but residually that we can see the subintimal space like that. And I showed that this interesting study. And so this study that checked the OCT, and this study performed the OCT follow-up 6 to 9 months. And the number is 75, and that 29 cases performed, and the interplaque is 46 cases. Please look at this figure. And how about the malapposed struts? And for that technique, and category is more higher, the percentage of the malapposed struts compared with the interplaque procedure like that. And from this OCT picture show the very huge malapposed part. And we have to think about how about the indication of the depth, and how about the management the depth. And we have the many problems, and even if using that technique. And another problem is branch occlusion. So this problem is a very famous one. And so we recommend the proximal connection is better for avoiding the branch occlusion. And move to the issue, the tip of the ADR. And so I recommend please check the CTA and before performing the ADR. And please look at this picture. And the more left side is very difficult to stick due to the plaque. But please look at this right side picture. This one is the actual case. And this CTA, a very easy way to check and know which position is better for the sticking, like that. And we have another benefit for the performing the CTA and before ADR. And please look at this picture, left side. So this one is ADR performed for the RC CTO. Looks like okay. Looks like this route is okay, but a little bit we can see the space and compare with the actual CTO distal part like that. And finally, this case created a big perforation like that. But and the right side is another case, and we performed the CTA, and before starting the CTO procedure, this picture showed. And this CTA revealed the concealed obtuse margin branch for the CTO region. So CTA give us a very nice information. And another tip is angulation. Angulation is a very important issue, as you know. And their very famous technique is a Stroh technique. And Stroh techniques, and we usually use a single lumen microcatheter, and they are routine use this Stroh technique for the performing the ADR. And 8 French guiding is recommended because we have to the insertion the CT region and stingray balloon and single lumen microcatheter simultaneously. And the bigger inner lumen and harder material is better for good aspiration. And for maybe the fine cross and Mizuki microcatheter is very suitable for this technique. And another, I will show another technique, base technique. Base technique is created cracking and using the balloon inflation and the proximal side of the CTO, and their insertion another guide wire and using the single lumen microcatheter like that. And another technique, the base and the power knuckle like that, fixed by balloon and to this microcatheter. So this benefit is the difficulty crossing a resistant proximal cap. And another technique is the side-base technique. The side-base technique is insertion of guide wire to the side branch and just the proximal part of the CTO entry, and their insertion additionally the balloon and the microcatheter. And this one is a benefit for the proximal cap ambiguity and the difficulty crossing a resistant proximal cap. Okay. And another one is a cutting balloon technique for the fenestration with the distal hematoma, and sometimes we perform. And another one is IBUS guided reentry, and for the rescue occurred side branches, and we use the first guide wire for the insertion of the IBUS. And move to the reverse cut technique. Okay, and so this picture is a very famous one. That overviews the three subtypes of the reverse cut. It looks like a little bit complicated. Left side is a conventional one, and the middle one is a directed one, and right side extended reverse cut. Anyway, the how to recognize these three subtypes. The key point is the guide wire position. Guide wire position means the antegrade guide wire position and the retrograde guide wire position. And for example, this directed reverse cut is this antegrade guide wire be in the intimer and the retrograde guide wire be in the intimer. And because because of the both guide wire be in the intimer plug, and we can do the intentional guide wire, intentional retrograde guide wire tracking. And the right side is extended one is and the antegrade guide wire be in the intimer plug. Yes, and definitely, and because of this belonging is and performed in front of the CTO region, and the retrograde guide wire already get advanced subintimal space, like that. And the conventional one and conventional reverse cut is included 4 patterns. 4 patterns mean the antegrade guide wire and the retrograde guide wire positions. And the reverse cut actually, occasionally it is difficult to make antegrade connection, and IBUS guide useful information. And I will show the key and key over there recognize the IBUS guidance for the reverse cut. One is recognize wire positions of the retrograde and the antegrade. Which position is better for making connection, and which option we need. And number 2 is the estimated Bessel size for the optimal balance size. And I show I will explain about using the actual cases. This one is RCCTO, and I perform the reverse cut, conventional reverse cut. In this time, very easy way to make a connection because, and I checked IBUS after that performing the reverse cut. And this one is Phillips and IBUS. Phillips IBUS mean this center and this center position is the antegrade guide wire position. Looks like this antegrade guide wire position is a be in the subintimal space. And we can see, and from the 1 o'clock, we can see retrograde guide wire position. This retrograde guide wire be in the subintimal space. And I will show the summary, and for this case, yes, and the antegrade guide wire be in the subintimal space, and the retrograde guide wire be in the subintimal space, and both guide wire be in the same space. In this time, very easy way to make a connection. I showed another case, a different position case. Actually, this case is very difficult to make a connection. And as you can see, this retrograde guide wire be in the subintimal space. But on the other hand, this antegrade guide wire be in the intimal plug. We can see the very big plug and between the antegrade and the retrograde guide wires. And I show the summary. Antegrade guide wire be in the intima, but on the other hand, the retrograde guide wire be in the subintimal space. And so in this time, both guide wire be in the difficult spaces. In this time, very difficult to make a connection. We need in this time we have to do some options, changing card position and optimal sizing balance, and changing guide wire position and stiff guide wire, and go back to the original card. But I know, and so sometimes it's very difficult to use the IBUS, but and I would like to show another technique. Double knuckle wire procedure is one option. And knuckle wire usually get advanced to the subintimal space. And looks like both guide wire looks like a knuckle shape. So this shape means both guide wire be in the subintimal space. In this time, very easy way to make a connection. From my data, and not so few performing this technique, and from my personal data, and about 10 to 15% I performed. And so usually, and I use a Sion Black guide wire and Gradius MG or the Gradius AEX. A polymer jacket guide wire I favorite for the performing that guide wire technique. Take home message, and that have efficacy of CTO PCI procedure success, and that will be needed more long-term outcome. Tips and tricks of the ADR are key of success. And when performing the reverse cut and guide wire position is very important. Thank you for attention.
Nagamatsu, it was a wonderful presentation.
Thank you very much.
I think Dhiman Kahali, if you have no time, then we can go to the next session. Otherwise,
okay.
Dr. Kahali.
Dr. Kumar, Dr. Pratap Kumar.
Yeah.
This is Dr. Roy. Dr. Yamane is waiting to deliver his next lecture on reattempt CTO tips and tricks. Can you please invite him?
Sir, Dr. Yamane actually is one of the most respected operator from Japan, as well as he's well known to all the Indian operators. He's actually given lectures and he's part of IGCTO throughout for the last 8 years, and he's a well-known person as well as he's one of the best teachers in CTO. I think, Dr. Yamane, please.
Yeah. So thank you, Dr. Yamane, for accepting our invitation. Thank you very, very much, sir. Dimania. Thank you, sir.
Very much for your oral invitation, and it's too much to describe my presentation as well. But beforehand, Dr. Nagamatsu, please close your screen because I cannot open my screen here. Yeah, thank you very much. So my topic is a reattempt of the CTO PCI, and it's always a pleasure and nice to have a talk about the CTO PCI. And probably sharing the experience with the Indian colleagues. And this is the COI of myself. Reattempt of the CTO PCI is sometimes very challenging and difficult, but suffice to say that before embarking on the procedure, scrutinize the prior PCI angel if they are available, and find the whole of the procedure very much important compared with some basic principles I touch upon briefly. Check the complexity and the risks associated with the procedure. At this moment, you are not necessarily more experienced than the first operator who failed the first procedure. Basic principle of what I mean by that is indication for the CTO PCI, definitely the improving of the symptoms, and dual coronary angiography is still the basis for our CTO PCI. And microcatheter is essential tool for supporting the guide wire strategy. And for CTO crossing strategies, as Dr. Nagamatsu already touched upon, antegrade crossing, antegrade dissection, and retrograde crossing and retrograde dissection reentries are the key for the contemporary CTO PCI. And changing of the equipment and the strategy will be the important aspect of the today's procedure. And optimized stent deployment after crossing the CTO is a key for long-term success. This is all of you already know.
Doctor, sorry to interrupt you. This is a technical backend. Doctor, sorry to interrupt you. This is from the technical side, from the backend.
Yeah.
Your audio is very low. I think it is an issue with your mic. Will you be able to remove the mic and talk?
Yeah. Can you talk? Can you hear me?
Yeah, it is very low, sir. It is very low. The audio output is very low.
I see.
So can you increase the volume?
Increase the audio?
Yes. Okay, sir. Please go ahead. Yeah.
Can you hear me now?
Yeah, this is better. Slightly better. Yeah. Thank you.
Okay. So this is a hybrid algorithm based on the 4 strategies, as you already know. So probably I can skip this one and this one. And with regard to the risk, progress CTO score will be the highlight for the likelihood of success. and risk associated with the procedure, such as the age of the patient, use of the retrograde approach, as well as to bending anatomical feature of the CTO as well. So if you face on the some difficulties, this is a first case with mid-RCA occlusion with calcification. And as you can see, the first operator tried to use a very stiff guide wire here and there, and Gaia second and third could not cross. And even the knuckle wire could not make any progress. So was the Confianza Pro 12 gram. So in this case, they tried to explore the retrograde approach, which in vain at the end. So the first procedure was abandoned. But if you focus on the first procedure, this is my procedure, the second attempt. Probably back to the basic is pretty much important, as I said. So we better use dual injection for the first place, because first that will recognize you as regard to the lesion length. This is not so long as we had expected by the single angio. And second case is we better to explore some kind of imaginary collaterals before the integrate approach. So in this case, we try to do the integrate wire supported by the 3.0 millimeter backup balloon here. It's a so-called power microcatheter position. Although the Confianza Pro 12 could not cross, but the Gaia X3, which is more powerful than the Dr. Kashima explained, that per square millimeter here, so the real occlusion was not so long here, but the heavy calcified here, the retrograde filling up to the very much middle segment of the CTO here as well. Gaia X3 successfully crossed the lesion, but no balloons and microcatheter could cross over here. So even we recognize a retrograde wire, antegrade wire, inside of the CTO vessel, but still we cannot cross microcatheter, small balloon, and support of the guide catheter extension. But in this case, what we found is that there is no availability of the rotablator, no the tonus microcatheter here. So what we're trying to do is subintimal modification by just advancing the dual lumen catheter, in this case Sasuke Asahi dual lumen catheter. Using the Confianza Pro 12 gram as a second guide wire, you can easily navigate the second wire over the subintimal space nearby the first crossing wire. As you can see that the CP12 already through the some CTO part. And over the second guide wire, believe or not, you can easily advance the 2.0 millimeter balloon over the second guide wire, because this is, I believe, to be inside of the subintimal space. After creating the space, probably you can navigate the microcatheter over the first guide wire by trapping, and then you can advance a 1.5 millimeter balloon and dilate it, and then you can bring any balloon and stent at the end. Even in spite of the heavy calcification, you can dilate and stent fully over the this recanalization without the rotablator. So the subintimal modification, or the external crush, as you may call it, after wire crossing the CTO, you can go around the CTO segment. Integrate subintimal crossing will be eased by use of the dual lumen catheter and small balloon inflation over the second subintimal space, and then a new small balloon inflation over the first crossing wire, and 1-to-1 ratio balloon inflation to stent is a pretty much important basics for the complex CTO. This is the second case for the LAD CTO. Actually, the CTO is not so much lengthy, but the problem is a Lima graft was attached to the diagonal branch, not the LAD. So here is the proximal LAD disease. So our purpose is to recanalize from the proximal LAD to the distal LAD as well. So probably in this case, they try to use a definite some measure such as a Lima graft used for the retrograde approach, because that is one of the little bit riskier procedure, because most of the time the Lima is one of the last remaining patency of the vessel and importance in the anatomical function as well. But in this case, they try to use the integrate and retrograde guide wire. Looks like overlapping in the CTO segment, but even use of the bigger balloon, this was not fully dilated at the end. They were not succeeded in making the connection of the CTO segment. 4 months later, I tried to myself for the just crossing for the CTO again, because in this case, LAD is a lifeline. And in this procedure, first we try to advance iris to see the target segment here. This is the occluded LAD, and this is a little bit side branch for the diagonal direction. So in this case, the LAD wire left main to the diagonal direction, and this is a Lima graft. This is a Corsair Pro microcatheter. In this case, you have noticed that the Lima graft diagonal to the LAD connect to the septal branch, whereas the integrate wire is to the diagonal branch. So theoretically and technically speaking, if the retrograde wire from the septal to the diagonal branch direction,
That's
that
it.
is deflection control using the Gaia wire,
That's it.
and then the antegrade wire that is from the diagonal direction to the septal direction, that is a clockwise direction, then you have increased chance of overlapping with the integrate and retrograde wire here. And that's what we did, because the balloon here is a 1.5 millimeter balloon. It's not bigger balloon. So sometimes even with a smaller balloon, but you can use the deflection control of the Gaia wire or the recent Asahi wires, and then you can navigate both integrate and retrograde wire inside of the CTO in an overlapping position. In this case, this is the CTO inside, but actually the Gaia wire exchange to the XDR, which is a very soft wire, slip into the proximal true lumen into the integrate guide, and over the externalized guide wire and placing the second guide wire over the dual lumen catheter, we can get the distal LAD and stent implantation, and finally we can achieve the very nice outcome here. So in this case, deflection control inside the CTO is one of the key factors, because bypass graft for the cabbage tends the vessel course, and bypass could distort the vessel course. However, the anatomical relationship with the proximal LAD with the diagonal branch, as well as the distal LAD with the septal branch, has not changed. And integrate and retrograde wire diffraction using the Gaia series of the wire should be the very much converging inside of the CTO for creating the overlapping. This is the last example of the proximal cap ambiguity, and this is a CTO of the proximal circumflex, and RCA is okay, and LAD is supplied by the Lima graft. Actually, this vein graft supplied the obtuse marginal of the circumflex, because repeated restenosis, they decided to open up the native vessel. This is the first attempt. As you can see, heavy calcified left main to the LAD, so decided to do the rotablator first and sizing up the burr here, and balloon inflation create some space for the integrate, and they construct the retrograde system over the vein graft, which is relatively easier. So the real occlusion per se is, as you can see, is very short, less than 15 millimeter, but the anatomical relation of the left main to the ostium of the circumflex is very close, in addition to the heavy calcification. And this is time that they had a very difficult time for advancing the integrate guide wire to pinpoint the location. So inflate the balloon here, and the retrograde wire tried to puncture the left main, which failed again. And if you go over the cranial projection, you can see the retrograde wire a little bit distant from the antegrade guide catheter. That tell you how difficult, and even with the retrograde knuckle wire with the Pilot 200, again that the cranial projection shows the distance from the antegrade guide catheter here. So at the end, they rotated the relationship, the guide wire, and this is a very much important. At the end, they try to visualize everything in place, because just failed attempt is okay, but without the complication is very important in the complex procedure as well. This is the second case of myself using the same setup with the retrograde Corsair Pro here, and we are very close to the retrograde Confianza Pro 12 gram over the 3.0 millimeter antegrade balloon. But again, the same thing over the cranial projection. Still, there is a distance here. So in this case, we have to create something new here, and even the knuckle wire could not help antegrade wire, Gaia X3, getting closer, but still there is a distance. So in this case, we see there's some space, but we did the modified Carino technique. That means 0.5 ml of the contrast injected over the this microcatheter, which navigated a very close position here, but still we have a distance. So I was desperate to try to the new technique, that is a stent deployment from the left main to the LAD first. Sounds like a little bit stupid, but since we create some space which modify the retrograde relationship with the guide wire here, and you can see that the antegrade wire possible because of some resistance of the stented segment of the left main. This is the Gaia X3 down to the some middle segment of the proximal segment. We could see the overlapping here with the retrograde gear. So this is the first time we create getting closer with the antegrade and retrograde wires here, and at the extension of this, we are happy to pull back the retrograde wire and advance it to the antegrade guide extension here. So after the externalization, we achieve the nice stenting over the DK crush. So the stent-assisted reentry is one of the technique, but this is a caution, because if you see the real heavy calcification and bilateral approach failed, and the crossing knuckle wire reverse cut attempt all failed, and modified Carino technique is a great help to understand anatomical relationship. Stent-assisted reverse cart has some benefit when it considers greater benefit more than the assists associated with the stent deployment here. So reattempt CTO PCI summary, the tips and tricks. Scrutinizing the prior PCI failed attempt is very much important. Check the complexity of the risk score is also very much important. But more important thing is organize materials to use to approach the new way of thinking. Reorganize your approach to unexplored method before, because you don't have to be more experienced than the first operator, but at least you have to be more creative than the first operators, and maximize your skill set for achieving the goal of success for benefiting the patient. Thank you very much for attention.
Wonderful presentation, Dr. Yamane, as usual.
Fantastic.
Yeah, thank you very much.
Fantastic, yeah. Dr. Pratap, we have all the legions. So, Pratap, you can take 7 to 8 minutes time for discussion, because we have got the legions. So we should not miss the opportunity to have a short discussion, you know.
Sure, sir, sure.
So, yeah. So, please have it, yeah.
Dr. Yamane, actually, the stent-assisted technique you told, that is actually one of the very do-or-die situation, the last sort. But you may fail also. If you fail, you will be in a real trouble situation. What are the solutions you keep in that mind when you do a stent-assisted reverse cut in that situation?
Yeah, that is a very good question, because we all failed more or less. But if you fail with a reverse current attempt, probably before giving up the case, think of some classic current technique. That means retrograde balloon inflation over the target segment and antegrade wire puncture. But sometimes bringing the retrograde balloon to the CTO is very much anatomically, technically, very much difficult.
You told you will be using a Carlino. Carlino you use frequently or very, very rarely? Carlino technique?
About 1% of the cases when you don't have the anatomical information regarding the CTO course, and sometimes I was outside of the vessel, but still that the 0.5 ml is no harm, no cardiogenic shock, no tamponade, is very much revealing. Yep.
Will you use in Carlino in a retrograde approach also or only in antegrade?
No, both antegrade and retrograde as well.
Oh, it's a wonderful thing. Nagamatsu, actually, you presented the dual technique, dual retrograde and antegrade. I think he's there or not?
Yeah, he's there.
He's there.
Naga, you actually, how many, what are the chances you do knuckling wire in your cases? You do knuckling regularly or very, very rarely? What are the...
Okay, thank you very much the question. Yes, and basically I prefer the how to say that, and not knuckle wire technique. And and so if they fail the normal procedure, I switch it move to the knuckle technique, because as you know, so knuckle wire technique created a big subintimate space, and sometimes there we can see the semiluminar big space from the IVA study. And once they created a big subintimate space like a semiluminar space, very difficult to the mal-apport, and even if the very big balloon post-dilatation. Basically, I would like to perform the normal guide wire technique. Thank you.
You prefer not to do knuckling as usual?
Yeah, not, yes, not knuckling.
Arun has a different opinion. Arun, what is your opinion about knuckling? Arun, please.
No, I actually would concur. You don't knuckle unless you have to. Your initial option, if you can wire it, in fact, the more I'm listening to these talks, right, you find there's a good synergy. So the issue is, and actually kind of going back to Yamane Sensei's talk too, right, when you have, let's say you have an expert that has failed with wiring before, I'm going to have a much lower threshold, because it is very arrogant if I think, oh, I'm going to wire that another CTO expert has not been able to wire. So what can you do that is different? I think the very key point that he made was, okay, you don't have to be more talented. Sometimes you just have to be more creative or willing to do something different and still do it safely. So while I completely agree that while you can wire, please wire, I think the hybrid 1.0 version that has been out there, the greater than 20 millimeters, it's really, don't take that as a dogma. The real key thing is, if either you or someone who is an expert has not been able to wire it, then have a low threshold for knuckling. I mean, I still think it's worthwhile trying to wire it briefly, but say if Nagamatsu is not wired it, I'm not going to wire it. Or if Yamane Sensei hasn't wired it, I'm not going to wire it. So it's like, what are you going to do that's different? I think that's really the fundamental principle. But if you can, please wire.
Yeah. Kashima, are you there? Kashima? I think Dr. Kashima left us.
I think it's late in Japan, sir. Thank you so much. We should have talked first. I feel bad to keep, we should have had them first.
Yeah. Basically, CTO intervention is actually just uphill experience required, skill required. As Dr. Yamane presented in the last moment, he told that you should be knowing about what materials you should use and what are the ways where you should have an alternative strategy. You may not be that much experienced. At the same time, you should know what to be used and where to be used. That is what actually the key point of excellent CTO intervention. I think any comments from Nagamatsu or Dr. Yamane is, you can have your own comments, please. Dr. Naga, any comments?
Yeah, Dr. Nagamatsu first.
Yeah, really. Thank you very much. Anyway, and I deeply appreciate the invitation again. And yes, and the CTO knowledge is there, and we need, and for the and how to say that, and we need we need emotion and over the creating a new technique. like Dr. Yamane. And you know that, and Carino technique is a very old one, but sometimes very beneficial still.
What is Naga is telling correct. Many people should understand that parallel wire technique still has a choice in many times. Actually, parallel wire is a wonderful technique, and people just forget about that parallel wire technique. Only wire escalation is the technique people still use, but parallel wire is a real good technique, like Carlino. Carlino, you can use rarely. Sir, Dr. Yamane, you can give the last comments before conclusion of our talk, please.
Well, thank you very much for the, first of all, I'd like to thank all of the invitation, always pleasure. And as you say that the most of the time, either the non-CTO or the CTO procedure, first operator sometimes looking too much on the lesion. So most of the time, the second operator or the even the technicians know the better some more objective findings of the key factors. So sometimes the if you under the stress and if you are about to fail the procedure, you ask your friends, just a second operator or third operator,
Hi, how are
what
you?
do we need? So that is kind of the advice we need.
There are some 20 people. ये बांग को क्यों रखा है स्क्रीन पे? स्क्रीन में तो बांग.
Okay, that is my message, and just going the safely as well as enjoyable is pretty much important to keep your excitement calm and objective and to higher achievement of success. Thank you.
Thank you, Professor.
Failure will give you a lot of messages how to succeed in the next step, right, sir?
Exactly.
Yeah.
I think
so.
Pratap, we also have Dr. Imad Shiban here.
Yes, sir. My mentor and my teacher.
Too? I know, you got to let him talk.
Yeah, we are waiting for his talk, Arun. So thank you, Professor Yamane,
Thank you very much.
Dr. Nagamatsu, Dr.
Kashimo.
Dr. Tashima, Dr. Kashima, Dr. Arun Kollan Sundaram. I don't know whether Dr. Carlo Di Mario is with us. So Dr. Carlo Di Mario also, he has left probably, and it's in Japan. I think it's 10:45. So thank you very, very much, all of you, sir, for your tremendous effort, and you have accommodated the invitation. And we always have a lot of respect to you, Dr. Yamane. You are in our minds, and also Dr. Nagamatsu and Dr. Kasima and Dr. Ferenc and Dr. Imad Shiban are waiting. So thank you very, very much, all of you, sir. So our next session is on bifurcation lesions, and we have legions as speakers like Dr. Imad Shiban, Dr. Ferenc, Miloslav Ferenc, who is a very good friend of ours, Dr. Saidur Rahman from Bangladesh, Dr. Ramesh Dagubati, my good friend. So first of all, I will call the chairpersons, another legend with us, Dr. Samuel Mathu, Dr. M.S. Hiramat, Dr. Praveen Chanda, Dr. Ajit Bhagavat, Dr. Shivananda Dotto for chairing the session. And our expert panelists include Dr. Shubhanand Roy, Ajit Muleswari, Sadanand Sethi, Dipankar Mukherjee, Kirti Punamia, Devdatta Bhattacharya, and Dr. Arindam Pandey. So I would hand over the mic to our chairpersons, and to start the occasion, because we are little restricted with time, so I would ask our first speaker, Dr. Imad Shiban, who is very, very known to all of us, on talking on how to decide on bifurcation strategy. So Dr. Shiban, please.
Thank you very much for the invitation. I'm really happy to be with you today. It is really, I'm disappointed that I cannot come that much to India in these times, but anyway, it is good to see you all.
Thank you.
So my presentation today is about strategy selection bifurcation lesion. I would like to start from clinical point of view, not from technical point of view. Because I think, first of all, we should follow a good clinical indication for everything we are doing for our patients. So starting with this, I think that the first thing is to define how we should evaluate coronary stenosis in general. I think severity, of course, by angio-intravascular or functional severity by FFR. Second point is the clinical relevance of the coronary stenosis. That means location. Where is that? It is in a big vessel, small vessel, or like this. And this will, of course, will be translated in prognostic relevance for the patient. That means we should look on long-term outcome and the MACE or any other event if we are leaving this stenosis. So clinically relevant vessel treatment could be translated or should be translated in relief of symptom and ischemia and improvement of prognosis of the patient. Now, what about side branch in bifurcation, which is the main issue in bifurcation is side branch? So do we have confirmed angio criteria to evaluate side branch clinical relevance? I think no, we do not have fixed criteria, but we have some data that can guide us in our daily practice. Well, this is the first study. It's an old study. It's from 2003, but was defining that when you have a vessel that's covering 10% or more, then this can be translated in severe ischemia and can compromise the prognosis. That means having clinical relevance for the patient. And revascularization of other vessels which are not relevant, I think it will not be translated in any benefit for the patient. It might be even harmful for the patient. So this is the first issue that should be underlined. And this is also recognized in the guidelines of the recent guidelines of European Society of Cardiology, and showing that prognosis should be, the prognosis depends also on vessels that covering more than 10% of myocardium mass. Now, we also have some data coming from CT scan by myocardial segmentation, studying the distribution of vessels and how much each vessel is covering. From these studies, both are coming from Japan, that showing that if you have a side branch longer than 73 millimeters, then it have a high chance to cover more than 10% of myocardium. Then it could be clinically relevant. And these are some parameters as well. So the length of side branch, location also is very important, like left main, because we all know that left main is not a conventional bifurcation. We are dealing with two main vessels. And if you look on location is very important, as well as dominance is very important, as well as number of side branches from the same vessel are very important in determining the relevance of side branch. And we have some proposal, again, taking consideration the size of the vessel, the number of side branches, is two or more than two, OBT, that means the distribution, and the highest, that means if it is very proximal or very distal. And this giving a score, which named a SNOO score, proposed by Korean society, and they are taking again consideration all parameters which I have been presented before. And just to give you a schematic example, this is coming from Dr. Koo, and showing how is the concept of long side branch mean covering huge amount of myocardium means that this side branch is relevant as compared to small one covering small amount of myocardium. And this can be translated on angio in daily practice. You can look on your diagonal, for example. It is a first diagonal, very big diagonal, very long diagonal, and it is covering, of course, more than 10%. And this diagonal is relevant for the patient. And if we have to treat that vessel, we should treat it. If we look on this example, then you see that this another diagonal, it is, but it is shorter, it's very short, small. The size is less than 2.5, and then this side branch will not be important for the patient. Just to show you what can happen when you are having some problem on important side branch, like in this case, we lost diagonal after stenting main vessel, which was not wired, and you see the ACG was like this. After we have restored flow in side branch, then everything was in place, and you see that this is a huge diagonal, and of course, as you can see also from ACG change, it's very important, very relevant for the patient. Now, not all bifurcation lesions are born equal. Should we have tailored approaches for these patients? Well, of course, but we do not have, again, criteria. I think that Medina classification is not an appropriate classification to guide for strategy selection, because it is very excellent and simple in defining plaque distribution, but we do not have any information about lesion characteristics, severity, size, and lesion length on side branch, the angle, calcification, tortuosity, thrombus, and so on. And if we look on the more recent classification proposed by Mamas, again, it gives you some idea about the diameter of the vessel, but still lacking on many other characteristics that we need to know before deciding whether it is important for the patient to treat or not. And just to show you some example again, you see here, this is both our Medina 111, but all you will agree with me that strategy in this patient will be completely different from strategy in this patient. And I think these patients cannot even be randomized to the same study. Same here, 111, again, you see complexity, very complex anatomy, very diffuse disease, as compared to 111 with focal disease on what is considered side branch, that means circumflex, and it is completely different from the previous one. Again, other things that should be taken into consideration if you have multiple bifurcation. For example, this big diagonal having important bifurcation at his proximal segment. So we have multiple bifurcations here. If you have very extremely narrowed angle here, that means it's very difficult to access side branch. Like here, we need to know something about it in order to decide our strategy, as well as if you have diffuse disease on side branch, this can also change your strategy. And even if you have predictable dissection following predilatation, also this can change your strategy in bifurcation. If we look on studies, of course, you see that one single stenting is equal as clinical outcome with 2 stents. But if you look on all these studies included in these meta-analyses, you will see that they are mixing together complex things with simple things. Then you cannot decide which is the patient who needs 2 stents rather than 1 stent. And I think that today the discussion should be focused on what is coming from this study. If you see that if you are changing from provisional stenting and going for provisional complex stenting, that the 2 stents, because like a bailout stenting, then the outcome will not be that much because will be associated with higher MACE. So I think that deciding the strategy before as default strategy, as intention to treat, is a good thing to do and will be translated in better outcome on long term. Now, we have some criteria, of course, now, particularly the only study who tried to separate simple bifurcation from complex bifurcation is Definition 1 study, defining some criteria. We can discuss about criteria. Maybe we have to change something. Maybe we have to go for scoring, which can be much more easy to use in clinical practice. But here you have some criteria which are called minor criteria and major criteria. Major criteria determined by the length of lesion on side branch more than 10 millimeter or less than 10 millimeter, and from severity of disease, that means around 50 or more than 50, severe or not. And so these two major criteria, length of lesion, severity of lesion, and the other minor criteria like multiple bifurcation, the angle, the length of the calcification, thrombus containing, and so on. And accordingly, in this study, simple bifurcation was defined according to these criteria, and complex bifurcation lesion was defined. And finally, if you look on what is coming from this study, we are treating simple bifurcation, then of course provisional stenting is doing much better and significantly better than 2 stents. But if we look on complex bifurcation, then 2 stents are doing significantly better than 1 stent. So this is very important message. And this was also confirmed in Definition 2 study, taking consideration only complex bifurcation. And in this study, you see that 2 stents are doing much better in terms of less MACE on follow-up than a single stent, than provisional stenting. So strategy of 1 or 2 stents should be based on clinical, first of all, clinical relevance of side branch, then lesion length and severity on side branch, then disease extension on side branch, the angle, the calcification can be also taken consideration. So if I will summarize what I have exposed before, then if we are going for stenting study, bifurcation stenting, we know that we have simple stenting that should be applied for simple bifurcation, and this is provisional stenting. And we have complex stenting for complex bifurcation, and then we have different strategies like T-stenting, modified T-tap, and so on, mini crush, DK crush, and the other family, big family is culotte stenting with mini culotte. So these are the 2 stent strategies mostly used in clinical practice. And I think it is not the selection of strategy, but I think that the operator experience and in practicing a particular optimized double stenting technique is probably more important than the specific technique selection itself. So to summarize, I think today bifurcation here should be approached like this flow chart. Bifurcation lesion, first point is, it is relevant side branch or not. And the other thing is distal left main. Distal left main, always side branch is relevant because it is a main vessel. Then when it is not clinically relevant, I think just keep it open. You don't have to worry about any other thing. And if it's yes relevant, then if it is simple accordingly to criteria that I have mentioned before, then simple stenting as intention to treat, and as elective simple stenting, that means provisional. If it is complex, accordingly again to the criteria we mentioned before, then you should go for elective complex stenting. Thank you very much for your attention.
Thank you very much, Dr. Imad Sivan, for your fantastic speech. Really, we are spellbound. Excellent speech, sir. and we'll discuss after the meeting. So if you kindly stay with us, Dr. Siban. And I would also invite our good friend, Professor Bijoy Bang, to chair the session, please. And I would ask our next speaker, our very good friend from US, New York, Ramesh Dagubati, to speak on IVUS OCT FFR, which to use when for assessing the side branch. Ramesh, please. Dr. Ramesh. Dr. Ramesh Dagubati. Yes, some problem. He was with us only. He delivered one lecture also. Dr. Ramesh.
So Dr. Ramesh is there in the group, but I don't know why he's not speaking.
Okay, so I think he has some problem in getting connected. Can you enlighten us, Raghu?
Dr. Ramesh Dagubati is in the group. He's there. He's currently available here.
Okay, okay. So Dr. Ramesh, can you listen to us?
Sir, just tell him to unmute and start the video. He's there.
Okay, yeah, but we can't see him here. Dr. Bijoy Bang, please join us. Dr. Bang.
Yeah, I'm here. Hello.
Okay, okay, please join us. Yeah. Nice to see you, sir.
Nice.
So I think Ramesh is having some problem in getting connected.
We think we can call Dr. Professor Feng.
Yeah. So I think let Ramesh come with us. He's a great friend of ours. And I would, lost no time, but I would invite our great friend and legend on bifurcation. He was also president of European Bifurcation Club, Dr. Miroslav Ferenc, no other than Dr. Ferenc. So Dr. Ferenc, you will be talking first. He has two lectures. He has first lecture on mechanism of side branch compromise and how to avoid it. So Dr. Ferenc, please welcome to CSI NIC. Thank you very, very much for joining us, sir. Thank you very much.
Yeah, dear Dr. Kahali, dear friends, thank you again for the invitation. I'm very happy and glad to stay with you in contact during this really, for everybody, it's a terrible pandemic situation. Yeah. So we have now, as you heard, a second wave in Germany, and we expect again a lockdown. Difficult times. So,
but you are doing much better in Germany in comparison to other European countries, you know. Dr. Siban is also there. So in Italy also it was very much affected.
Yeah.
Thank you.
Yeah. But now we are doing much better than Germany.
So can you see the presentation?
Yes, we see. Yes, we see. Go.
Yeah, thank you again for the invitation. As you know, we are here located in very southwest part of Germany. And together with University Freiburg, we are now one of the biggest centers in Germany. So we have altogether 15 cath labs, 11 cath labs are in Bad Krozingen. So we are doing around 3,300 PCIs in Bad Krozingen. Together, we do around 5,000 PCIs. And especially we as a center in Bad Krozingen, we are very specialized in complex PCI. So we do a lot of left mains, a lot of bifurcations, and we are definitely one of the leading centers in CTO business worldwide. We do around 600 CTO cases also. So this is a high volume center for complex PCI. And you see many hospitals in yellow points. The people from around Germany sent us patients to perform complex PCI. So for many years, we were in very difficult position because regarding the bifurcation lesions, we believed if we go to the bifurcation lesions, if we start the procedure, so we just keep the plug into the different position. So we open one vessel but close other one. And for many years now we have learned how to manage this problem. Now we know the plaques are not located mostly at the carina region. They are opposite, and in around 70% of cases due to IVUS and OCT investigations, we know carina is free of severe calcifications. However, I would like to mention our patients are going now from year to year. They are older and older, and that means the anatomy of bifurcation, coronary bifurcation lesions, what I observe is changing a bit. We have now more and more also calcified plaques here at the carina region, and this is a topic for us to how to manage this, because now we have even more dissections, and if we have huge dissection, then we have to cover with stents. So left main bifurcations are around 5% in our business. And before we start to think, should we protect the side branch, yes or no? What is the main criteria for that? Is the diameter more than 2 millimeters, so 2.5. It's definitely a side branch where I would, we recommend from the, European Bifurcation Club, we recommend to protect the side branch with floppy wire. I think this is one fundamental point. And as Imad Shaiban mentioned, and I think this is a really increasing topic, we should always try to keep in mind not every side branch is really relevant. So I fully agree with this approach, and we should try to focus to larger side branches with diameter around 2.5 and more. And sometimes the side branches are a bit from diameter very thin, but they are long, so they also supply a larger part of myocardium. And there was enough data now showing that only around 20% of non-left main bifurcation lesions are really relevant. And one of the options to find the relevance is also FFR measurement. So if we don't protect the side branch, there is a higher risk, and regarding the literature, between 1 to 50%, it could happen that the flow in the side branch is going to be worse and worse. That's why side branch protection make a lot of sense. And side branch protection give you also additional information. If there is occlusion and there is no flow, if you see the wire as a marker wire, then you can cross much easier. And this is the point which I mentioned before. Carina shift is mostly a problem because the plaques are opposite. And in majority of cases, we don't need to perform predilatation of the side branch. This is only sporadically needed in around 5 to 10%. And this is a criteria, subtotal stenosis of the side branch, severe calcification, and a longer side branch lesion. And this is exactly what Imad mentioned. This is we see now criteria which are going to according to the definition score, that is sign or signal, okay, we have here difficult anatomy, and difficult anatomy should be treated with a more complex approach. Simple, treat simple, complex, treat complex. And one very important point is, and I would like to mention this to younger interventional cardiologists, There are many different devices now on the market, tools like dual lumen microcatheter, or we have Supercross. This is angulated microcatheter. They are very helpful to manage not only chronic total occlusions, but also complex bifurcation lesions or difficult coronary anatomy. And this is she has shown how you can manage some retrograde entrance to the side branch because of plaque, very complex plaque distribution. So you go here practically with a wire back, and then you are it's possible to go then practically inside. So double lumen microcatheter is here very useful, and you can see if you have such anatomy, you could also believe, okay, I take some polymer wire and I could cross this, but it is practically not possible to go with a single wire, standard wire, because you have to go practically on the way back to the bifurcation. Then there's usually lesion and again very difficult angle. So you could, if you don't take care for such anatomy, you could even you could lose big branches like this. You make maybe more stiff wire, you make more movement with the wire, and then you dissect, and then you can lose here, like in this example, a huge wire. So this is again shown that a standard wire usually is doing prolapsing, and so you need here this Swen neck technical approach. And this is, you could, if you don't have dual lumen microcatheter, and that's why I will just show this for some Indian doctors. Maybe they don't have this dual microcatheter in the cath lab, so you could make it. You could take a polymer wire, make two curves here, 180 degree, then standard here, go backwards into fine cross or some microcatheter, and then you will be able to manage something like this. This is just showing you with standard is no way. So you can go with retrograde. You have your microcatheter and you pull out wire, and the tip of the wire is coming, like here shown, into the side branch. And then after 45 minutes later, you could manage this difficult anatomy very nicely without sending the patient to surgery. I think important topic is also to choose the right stent, and we know now there are different anatomical options, how easy to cross from the stent to the side branch, and definitely one of the easiest stents for crossing to the side branch is Resolute. So if you use Resolute Integrity for left main, usually we take Onyx, and this is the easiest way to cross. They have also very good data which we have published. This is from my perspective also important point to have in the cath lab such microcatheters with an angulated tip between 45 and you can go even to 120 degree. So this is very necessary if you are working in the complex cath lab with option to treat complex patients. Side branch predilatation, you can do this, but again, there is a Spanish study shown there is still a risk to achieve, to perform dissection, to get dissection. This risk is around 10 to 20% around. However, if you see, this is randomized study from Spain, from Dr. Penn, from our ABC board. there is no significant difference clinically after 2 years. And our colleagues from Korea, they see even standard predilatation of the side branch is even worsening the results. So this is definitely not always needed. So this is what we see in many cases, carina shifting, if we have Medina 110 option. And once again, very important point is to make a right visualization, to make a assessment, the right assessment of the side branch diameter is also very important, and that's I think what Ramesh will present us, how important here imaging is in front of strategy planning. So, in summary, we have usually problems with calcified bifurcation lesions, and that's why if we have anatomy which is complex, as according to the definition scores from Dr. Chen and Dr. Imad Shaiban, I think this is the way to decide, okay, complex anatomy, go with a complex approach. Thank you so much.
Thank you very much, Dr. Ferenc. As usual, fantastic speech, and we wait to listen to your speech. And again, we'll invite you for your second speech after Ramesh gives his speech. So I would invite our good friend, Dr. Ramesh Daggubati from New York, USA, to deliver his lecture on how to assess the side branch, IVUS, OCT, or FFR. So Dr. Ramesh Daggubati, please. And later on, sir, I will come back to you. Dr. Imad Sivan, please be with us. And thank you very much again, all of you, for being with us. So we'll be discussing at the end of the session.
Dr. Kahal, it's a great pleasure to be with all our good friends from India, as well as Miroslav and Imad. Great to see you. Really enjoy your lectures all the time. And so unfortunately, we are not able to see face-to-face this time, but hopefully in the very near future. So my topic today is IVUS, OCT, or FFR for side branch assessment. And as I have no disclosures, and as you have seen, both by Dr. Shaiban and Dr. Miroslav's lectures, that bifurcation lesions are not the same. Here is a left main bifurcation, which is 100. Here is more like a 111. And so they're not the same, and you have to be very vigilant on how to see what side branch should be protected. I completely agree with the statements based on definition. Now we still have a very good data to support angiographically that if the lesion in the left main side branch is more than 70% stenosis, more than 10 millimeters in length, that is a good lesion for a two-stent strategy. But in non-left main, the lesion severity has to be more than 90% and has to be, again, long lesion. That actually, again, is good for a two-stent strategy. Well, if not, by definition, it becomes a simple lesion, and it is going to be best treated with a provisional stent strategy. So my focus today will be on if we go provisional stent strategy, how to assess the side branch further. And so the uniqueness of bifurcation or side branch lesions are the various sizes, various amount of supplying myocardium, and side branch osteal lesion is very unique because if you just take it significant and by more than 50% stenosis is considered as a restenosis or a lesion significance, you might actually do unnecessary stenting and causing more problems. The plaque is actually very eccentric, and it is not very good to assess by angiography alone at times. There is negative remodeling, and there's after provisional stent strategy, there are different mechanisms of osteal narrowing after main branch stenting, which are carina shift, plaque shift, the struts, or thrombus. So all these come into a play, and we need to be careful how to assess them. because occlusion in the side branch can contribute to periprocedural MI, and these periprocedural MIs are associated with the unfavorable late clinical outcomes. And previous drug-eluting or metallic stent studies suggest that the incidence of side branch occlusion is presumably attributable to the strut thickness. So the larger, such as Cypher, having, or even Absorb 150 microns, they are all associated with the occlusion of the side branch. The incidence of side branch occlusion, as we know from Absorb, has also been unexplored, and now actually it is on the shelf. So if you look at the recommendations, there are no true recommendations of IVUS, FFR, or OCT in bifurcation for side branch lesion assessment. We know we need to use FFR for any patient with a stable ischemic heart disease or in multi-vessel disease, and IVUS or OCT is all class 2 recommendations for mechanisms of stent failure. But right now, there's no recommendations at all. So Koo from Korea, from Seoul, has done great work when he was at Stanford as well, and they're back now in Korea. He's still continuing to do this assessment of side branch after main vessel stenting with an FFR. So there's no dissection with TIMI3 and there is TIMI3 flow in the side branch. Those lesions were looked at by angiography. They appear more than 75% stenosis in 68% of the patients. But if you do FFR, which is a value of 0.75 or less, it is only 31% of them are significant. And the same patients, when they went post-kissing balloon inflation, actually even angiography stenosis came down from 68 to 32% in the side branch ostium. And post-kissing IFFR has come down from 31 to 8%. So it is still very good study to show that kissing balloon inflation has caused no harm and in these people, and FFR and angiographic stenosis significantly came down. And on follow-up, you can see that FFR remained less than 8%, but for our eyes, the stenosis is now more than 75% in 48% of the patients. So what it means is that sometimes actually we might unnecessarily do stenting in follow-up patients. So these are the patients that probably we need to further analyze. Any significant aortic, significant jailed side branch ostial stenosis by angiography, only 20% of them are significant by FFR. So in jailed side branches, FFR is of value. So this has been studied in several, from Korea, from couple of them from Korea, from Europe, and also in FFR Nordic bifurcation study. All of them have evaluated that, and they said that FFR is actually value in about 20% of the patients in side branch stenosis. Here is a 63-year-old man with unstable angina, and you can see that the lesion is 100, and after provisional stenting, it appears that the ostial side branch is stenosed, and you can see that by IVUS, actually, it looks like it has a good lumen in the side branch, and FFR was done, and it was 0.88, so nothing has to be done for this patient. So here is another patient, again with a bifurcation lesion, and after provisional stenting, the side branch appears to be slightly pinched at the ostium, and again, FFR actually here is done, and it is 0.70. So this patient needed a final kissing balloon. Do we have a study to say FFR versus angio-guided? Yes, there is. DK Crush 6 by Xiaoliang Chen and Greg Stone has shown that whether we can compare outcomes based on FFR versus angio-guided in people who undergo provisional stenting, and if need be, a modified TAP technique can be done in true bifurcation lesions. So all Medina 111 or 011 bifurcation lesions with side branch more than 2.5 were included in this study. 160 in FFR, 160 in angio, and jail wire main vessel stenting is done. If the side branch of FFR is less than 0.8, then actually they go kissing balloon inflation. If it is still less than 0.8 after that, they go side branch stenting and final kissing balloon inflation. If it is more than 0.8, there's nothing else to be done, 1 year clinical follow-up and 13-month angio follow-up. And in the same angio group as well, that's the same thing. If there is no dissection, no reduced flow, and the side branch osteostenosis is not more than 70, they are just followed up for 1 year. The endpoints for cardiac death, MI, and TVR, a combined MACE endpoint, and they were also analyzed subsequently, all the other secondary endpoints. So in this study, 1 year clinical outcomes actually showed that 18% was the outcome in angio versus 18% in FFR group, saying that the major adverse cardiac events is exactly the same with a p-value of 1.0. So there is no added benefit of FFR in this study. So the same thing has been shown in bifurcation lesions from Europe as well. If there is a provisional side branch stenting, you do first a POT. And after POT, if there is more than 75% residual stenosis, dissection or decreased flow or ischemia, having chest pain, you go ahead with the modified TAP or T-stent technique. If it is less than 75% and there's all the parameters are good, and you can leave it alone if territory not big or FFR negative. And if the FFR is positive, go with the T-stenting strategy. This is what has actually been recommendation, but most of us actually do now based on POT and final kissing balloon inflation. If the angiography looks good, if the stenosis is less than 90% in the non-left main lesions, we'll leave it alone. How about IVUS? This is the ADAPT DES study, which actually showed that IVUS is beneficial in all comers with the significant lesions to reduce the 2-year MACE definite or probable stent thrombosis, cardiac death, or MI. But the benefit is also seen in bifurcation lesions, but the number of bifurcations seen in the ADAPT DES is only 4.1%. But in Korean SCOBIS registry, IVUS guidance versus angiography guidance, there is significant reduction in the MACE endpoints with the IVUS guidance. So the same thing has been seen by Dr. Singh in USA, where the death or myocardial infarction are much lower, 8% in IVUS guidance versus 21% in no IVUS with a p-value of 0.002. And the same thing was seen by Xiaoliang Chen from China, that actually that stent thrombosis is much lower in people who are undergo IVUS-guided bifurcation stenting versus no IVUS in the same group. But when we want to see angiographic side branch jailing and you want to look at it angiographically, this is the one thing. It is a strut artifact, and you do a pullback from the IVUS from circumflex. The minimal lumen area is really very good. So angiography can fool us, and whereas here, IVUS will tell us exactly why that is not such a significant lesion. And this is a carina shift. You can see that actually there is a narrowing of some plaque, but not so much. It's elliptical shape in the circumflex ostium, so you're okay with it. And whereas if there's a true plaque shift, there is, you can see some of the plaque protruding into the circumflex ostium. So different ways of assessing. When you want to assess side branch by IVUS, should you also look at only when you withdraw the IVUS catheter from LAD? Is that enough? Here is an off-axis view of the ostial diagonal, and it might make us think that the ostium of the diagonal is not significantly narrowed. And this is not actually good. What is the recommendation is actually do an IVUS or OCT for that matter from the side branch pullback. So here you can see that this diagonal appears significant, but when you look at the from the diagonal alone, the diagonal is actually a very good ostium. But IVUS itself is being tested now in DK-CRUSH 8, which I think we have to wait for the results in a multi-center randomized controlled trial, whether there's any value of IVUS in the bifurcation stenting. The same authors have shown that ultimate study showed that all comers and non-bifurcation lesions, that there is significant reduction in MACE endpoints at 3 years with in the ultimate study. How about what should be the lumen area in the circumflex ostium? Pre-Excel, we used to think 5, 6, 7, 8. That was originally came from Korea, by Kang. Now, actually, Dr. Gregstone will say that actually go for 12, 11, 10, 9. So the larger you get expansion, the better it is in Excel. That has been shown. So to reduce the stent restenosis at the ostium of the circumflex. So here are some areas that we can consider what is the significant, but at least what is the minimal lumen area is considered as actually less than 4 versus more than 4. In the circumflex ostium, the restenosis rates have come down from 50 to 5.9. So this is again probably Asian population. So maybe there are lumen areas of 4 as okay, but in the US and Europe, we probably want to achieve as large as possible and maybe go with the 8 millimeters in the circumflex ostium. How about in the side branch assessment by OCT? This is actually a very good way to assess that after provisional stenting with OCT. And you can see that actually that sometimes you can don't have to stent across the side branch very clearly, that you can by OCT you can see it. In view of time, I'll go quickly. And here actually the most important point about OCT is that you want to cross distal wire crossing in however you can achieve it in provisional stent strategy, but in DK crush you want to do proximal stent crossing. This can be easily assessed very well with the OCT here, as you can see the wire actually coming into the distal cell crossing. And you can see whether OCT is able to see how can you cross and how many successfulness is there. In first attempt, 66.7% were able to cross by OCT-based wire crossing into the distal cell. So that is a very good study that actually showed that. And the immediate results of bifurcation stenting assessed with OCT have shown that, but it is a small study, obviously, that there is malopposition that can be identified, and side branch assessment is very good. In about 17%, they were able to assess without OCT versus 7.5% with OCT guidance. The side branch lesion is assessed very clearly. So in conclusion, side branch assessment starts with angiography. FFR data is not very clear, but less than 0.75 is considered significant. But Ku will say that even less than 0.75, what should we do? If the patient is asymptomatic, leave it alone and manage medically. If the patient is symptomatic, then actually go ahead and probably do a final kissing balloon and a pot again. Imaging has to be done from the side branch to be more accurate of the ostial minimal lumen area. And imaging-guided complex PCI showed more benefit than less complex PCI groups, but we have to wait for DK Crush 8 to look at the value of image and bifurcation PCI. OCT obviously uses more contrast, but gives beautiful pictures. And I think distal cell crossing, if you're not using stent boost, can be used with the OCT as well. Thank you very much.
Thank you, Dr. Ramesh, for your excellent speech, super speech. So, Dr. Ramesh, I would go to the discussion later on, and I would invite again Professor Ferenc to deliver his second lecture, how definition of complexity shapes the outcome of left main bifurcation PCI, mainly enlightened by the definition trial, as you have mentioned. Dr. Ferenc, please.
Welcome back. So you see my slides?
Yes, sir. We can see it, sir. Yeah.
Okay, perfect. Again, I think very important topic is to mention that if you go to the high volume cath lab, you have to treat much more often bifurcation lesions, including Clefman. So according to the studies ARTS2 and Syntax, if you have to treat multivessel, if you have to multivessel PCI in complex patients. So you have to treat at least one bifurcation in up to 70%. So I repeat this again and again. For younger interventional cardiologists, it's really very important to know how to manage complex bifurcation lesions. So they need to know how to perform at least 3 different technical approaches: TAP, culotte, and Dickey Crush. Then you can manage every bifurcation very nicely. So, and we have still unresolved issues with our side branches, especially because the result for side branch is sometimes really unpredictable. You believe you could go with even with one stent with provisional, and then you have a lot of troubles. The outcomes in severe calcified lesions are really very, very bad. We published a few years back the data from calcified lesions versus non-calcified lesions. The difference is 3 times higher MACE if you have to manage calcified bifurcation lesions. So there's still a big problem. This is a simple example. You could imagine, okay, there is an ostial LAD problem, some distal left main problem, circ still noch nicely open, not so large branch. You could just imagine, okay, you go with one stent approach, kissing for the circ, and as you can see, if you stand, you can have a really spiral dissection to the side branch. And then you need a lot of experience. Professor Scheiban mentioned this very clear today in his speech, and I fully agree with this statement. It's really very important to have operators' experience. So everybody needs a special level of experience and to manage such spiral dissection with TAP stenting here in this case. And regarding the left main PCI or revascularization, we have now from newest European guidelines a very clear approach. If we have low syntax score, you can go with PCI and CABG. If you have intermediate syntax score, then primary you should go with CABG, but you can go with PCI. And if you have a very high syntax score and left main stenosis, there is practically contraindication. And that's why heart team decision or discussion, I think, a crucial point to make the right decision and to have better support in case if something happened. So the calcified lesions, that's a problem here. You see calcified lesion, you can rotablate, you can then perform PCI with impeller protection to try to achieve really good angiographic result. And again, in stent stenosis, as known in distal left main, the main problem is ostial circ. But we have still not really good solution for that. And I think now to go with stents with better radial forces like Onyx or Synergy Megatron, this is probably the solution for ostial circ. And we have now also to discuss the data which we have from the syntax study and from the Axel and Nobel study. So after syntax study, there was the end of the left main stenosis is a taboo topic. Now we have solid evidence from Axel and Nobel trial, and meta-analysis allow more differentiation what to do for our patients. And if you just see here from meta-analysis from few studies, so you see regarding death, MI, and stroke, there is no significant difference if you put all data together and follow up for 5 years. So in majority of cases, the left main stenosis means distal left main stenosis, and that's around 70 to 80% of cases. And you have to discuss PCI surgery. And according to our own analysis, with more than 1,000 patients with high syntax score, we found only 10% of our patients were accepted from the surgery department. I think this is really a crucial point. We have many patients, they are polymorbid, they are sick, they are old, they have many different disease constellation, and they are not really suitable patients for open chest surgery. So that's why many cases we have to treat such patients by PCI. And it's clear the information how is the plaque distribution is very clear. The plaques are going in majority of cases from left main to LAD. That's is explanation for the fact that in majority of cases we plan to stand from left main to LAD. LAD is usually larger vessel, and according to the plaque distribution, it's the best way. And we should know the vessel diameter is in more than 75% of cases, more than around 4.75 usually, so sometimes even larger. And that's why I'm very happy we have now stents with option to go up to 6 millimeters Onyx or Synergy Megatron, for example. And so this is, I think, a good option to approach left main stenosis. And according to our data from our high volume center, we usually try to treat bifurcation by simple approach, but now, according to the more and more occurring complex anatomy, we need for distal left main in around 40% double stenting. So that's the way, and that's it's so important to know how to perform double stenting, how to perform especially Dickey Culotte, because the Dickey Crush has the best evidence for distal left main. Here it just shown how many different steps. If you go every step, step by step, so you could be successful. And we follow up our patients, around 1,000 patients for 10 years. And just to show you how is the data, we compared provisional Cypron stenting with kissing for Circ usually, or LAD, but in majority of cases we stented from the left main to LAD, versus bailouts, Cypron stenting, or by operator's decision. It was TAP and Culotte. And this is just shown. There is no significant difference for all-cause death MI, no significant difference, but we will find difference for TLR. So still double stenting has makes more problems, and MACE again by TLR significant. If we go to landmark analysis and follow up patients after 1 year, so after 1 year we do restart the analysis, you see MACE, the curves are practically identical, and it means the first year after left-main PCI, and we have all comers patients, and a majority of them are patients refused from surgery department. This is all everyday routine. You see, we have some sign that even complete revascularization due to double stenting may be even beneficial regarding prognosis of the patients. And I think what is very stable, we followed up patients for many years. You see the stent thrombosis, definite probable, is not big issue. There we saw few cases, but usually in first 48 hours after left-main PCI. So how to plan? I would definitely approach, if possible, duofemoral, because you can use 7 French axis or 8 French. Of course, good support guiding is very important. Wire above branch, prodilate always. I would always recommend to prodilate both branches. Rotablation sometimes very useful and necessary. If possible, if you have really very simple anatomy, not calcified lesion, you can try with single, then final kiss and final pod. And if anatomy complex, due to definition criteria, go with Dickey Crush, because Dickey Crush has the best data. Culotte or Dickey Culotte today is very popular, or is going to be popular, or TEP is a very good alternative. And of course, post-dilatation is definitely very important. You could use Onyx or Synergy Megatron. This is my personal recommendation. We are waiting now for the data from ABC main study. It is single versus double stenting for distal left-main stenosis. You saw this slide from Professor Scheiban, criteria to go with simple or complex approach. You see, if you go primarily with 2 stent, you have a better clinical data during long-term follow-up. So finally, we have now very clear evidence. If you have complex bifurcation, so go please by complex approach. I think the data is very clear. If you have non-complex through bifurcations, there is equivocal evidence, possible minor benefit of systematic 2-stent strategy, and with contemporary stents and stenting techniques. If you have non-true bifurcation, there is evidence for benefit of provisional. So you could really go with 1 stent. And if you have a very simple bifurcation, so there is a side branch treatment only as bailout needed. Thank you so much. Because of time, we stop now.
Okay. Thank you, Professor Ferenc, for your excellent speech again. It's always fantastic, you know. Now I have to be excused by Professor Rahman from Bangladesh. We'll call you next, sir. We have to be excused because Ajay Kirtaniya is with us. He's a very good friend of ours. Just recently we are together in TCT. And welcome, Dr. Ajay Kirtaniya. We have all been waiting for you. He has an overlapping meeting. But anyhow, he has done it well to come with us. So thank you very, very much, Dr. Ajay. And I will invite you to talk on treatment strategies for coronary artery calcification. So Dr. Ajay Kirtaniya, please.
Well, thanks so much. It's a real pleasure to be here, and thank you for adjusting the schedule to be able to allow me to speak. It's just hard because it's nice to see our friends again, but seeing them via Zoom is very different than seeing them in person. So I just wait for the time, I think all of us do, when we can actually see each other in person, hopefully soon in the future. So I'm going to talk a little bit about treatment of coronary calcification, and I'll set up the talk by talking a little bit about the incidence and what it means, and then similarly, how do we treat it. These are my disclosures. There's nothing personal germane to the talk. So this is just one slide that I like to show because I think it's something that we see more and more nowadays. This is a patient who has a stenosis, had a stent placed, and the stent is horrifically underexpanded and comes back with restenosis. And despite attempts to try to expand the stent, it doesn't actually work. Now, why does this happen? I think it happens because our technologies and techniques have gotten so much better. We have stents that are really thin. We have guide extensions, and oftentimes somebody will do a quick radial case, put a stent in, be done. They're done. And yet, with a more complex patient population, we see that this can be a real problem for many patients. And this is because of underappreciation of coronary artery calcification. And that's why I pose this question: is this case more broadly generalizable? Does this happen frequently? And the answer, I think, is yes, because at referral centers like ours, we see this more and more often, stents being placed and another stent being placed, and ultimately severe restenosis that's very difficult to treat. So what about detection and frequency of coronary artery calcification? It's remarkable. If we look at DES approval studies, these are studies that were supposed to exclude patients that had severe coronary artery calcification. What one finds is that in up to a third of cases almost, there is severe coronary artery calcification if you look at the angiographic core lab results. In other words, we're underappreciating how frequently this happens. And if you think about it, with more and more emphasis on lower radiation systems, a lot of stored fluoroscopy, unless your guard is up to think about calcium, you may miss it frequently. And that's one of the reasons why adjunctive imaging is so important. Now, if you take more complex patients, and these are the types of folks we're seeing more and more in the cath lab, this is from the Syntax trial, you see heavy calcification in up to 50% of cases. So this is not something that's going away. In fact, it's more and more prevalent, and we need to know how to deal with it. The implications of coronary artery calcification are real. And I think most people recognize during a case, it makes your life more difficult. There's difficulty delivering stents. There's difficulty with stent expansion and malapposition, and also asymmetry of stents. People know that these cases are longer and there are more perforations, dissections associated with it. But I don't think people actually recognize, especially trainees, that increased rates of stent thrombosis and restenosis are seen with severely calcified lesions. In fact, it's one of the most highly restenotic lesion subsets that we see. We also know that our stents, though we like to think that the 3.5 stent's going to go up to 3.5, the more the arc of calcium is, the less likely that's actually going to happen, because the vessel constrains the stent from being able to expand. This is just one study I like to show, looking at longer-term follow-up of patients with severe calcification. Severe calcification was associated with an increase in stent thrombosis and also an increase in target vessel failure of over 15% at 2 years. So that's pretty real for patients that are going to be coming to the cath lab and that you're going to see. So I think then comes the question, how do we treat this? If we have to recognize it, and the way to recognize it is to be attuned to it clinically, to see it angiographically, and to confirm it via imaging, then how do we treat it after that? And there are many options. The options range from regular balloons to specialty balloons to atherectomy devices and to newer devices like lithotripsy. So we'll talk a little bit about that. But first, I think it's important to recognize that irrespective of what device you use, what we're trying to do, and the imaging has really taught us this, is to create a fracture in the calcium that's within the vessel. Remember, if the calcium is very deep wall, you might not need to even do anything about it because the stent may expand. But if it's closer to the lumen and it's going to constrain the balloon and stents, the only way to expand a stent is to crack the wall. And that's what this study and others have shown using imaging of OCT, that you can get a bigger minimal stent area if you have a calcium fracture. So can we predict when we would get a fracture? Can we predict when our stent would actually expand? And this is data from our group looking at OCT-based characteristics. There are also IVUS-based characteristics to determine if you're actually going to be able to expand the stent and in turn going to get a fracture. And generally speaking, it relates to the angle of the calcium, it relates to the thickness of the calcium, and the length of the calcium. And by deriving a score, if you have a score of 4, for instance, longer calcium, more circumferential and thicker, you pretty much are going to need to use some other device like an atherectomy device or a lithotripsy balloon in order to achieve the fracture. Now, despite this theory of what I'm talking about, it looks like, if you look at the guidelines, that we really don't know what we're doing, because most of the recommendations for coronary artery calcification are level of evidence 2B and below. There's some 2A evidence for rotational atherectomy. And this is because there's a paucity of randomized studies. This has led people to come up with algorithms like this one in JACC, and I'm not going to go through it in detail, but basically, detailed algorithms looking not only at what the calcium looks like angiographically, how it might respond to balloons, and then also what happens with imaging to determine if we can then achieve a better outcome. So where's the data? Well, there's some data here, and I'll show you that in this part of the talk. This is a small study looking at a cutting balloon versus angioplasty alone, and essentially you can get a bigger stent area with a cutting balloon in this very small randomized trial. These are data from Disrupt-3, which was just presented at TCT. This is with a lithotripsy balloon. I'm not going to go into it in detail other than to say that it's a type of balloon that doesn't have to expand in terms of the balloon itself, but uses energy to then fracture the calcium behind. And essentially, in this study, this non-randomized study met its primary safety and efficacy endpoints with acceptable rates of adverse outcomes during the follow-up period, and this was at 30 days. Now, beyond balloon-based technologies, and I didn't talk about scoring balloons and all the other things that are out there, OPN balloons, for instance, let's talk a little bit about atherectomy. And for atherectomy, we know Rotablator has been around for a very long time. The newest iteration of this is RotaPro, which they've moved the foot pedal up to the handle. I love the joke that my friend Paul Tierstein tells about this. He says, the only thing that's bad about the new RotaPro is I can't figure out how to put my foot on the table. Because he's very used to using the old system. But nonetheless, they've made advancements to it, and there's even a newer version, a 2.0 version, that has actually made it a little bit more ergonomic as well. Now, what's important to recognize about atherectomy is that you need experience and you need to know how to do it in order to do it safely. I show this slide because at least in the US practice, and this is not dissimilar, by the way, to some Indian practice as well, you have a lot of interventional cardiologists out there, and nearly half of operators do less than 50 PCIs a year. And so if you're doing less than 1 PCI a week, one could argue if you're going to be really facile to be able to deal and know how to do Rotablator, especially dealing with the complications that can occur. And this is one of the reasons that we look at the percentage of atherectomy that goes on in the US, and it's really, really low. My friend Neeraj Behar published this article. And in this article, we also found that up to a third of hospitals in the US did not perform any atherectomy at all. This is a problem because if we think severe calcification may need to use atherectomy, then there's a big treatment gap here. And so this is something that I think needs to be worked on, not only with familiarity and training, but also perhaps thinking about referrals. Now, what does atherectomy actually do? This is probably one of the best studies I've seen that's an observational study, not a randomized trial, that illustrates exactly what it does. And these are patients that had either planned rota, you went up front and did it, versus provisional in case you needed to and the balloon didn't work. And I've highlighted at the bottom what happened. If you went by that latter strategy where you tried with the balloons and it didn't work, well, those procedures were longer, there was more flow, there was more contrast, and certainly more pain on the part of the operator. So if you see severe calcium and you're thinking about it, that's where this term rota regret comes from. You likely want to use it or at least image to see if you need to use it in those specific cases. There are some other randomized trial data. The Rotaxis trial, some people know, was a negative trial, but did show that there was more bailout in patients with severe calcification. And similarly, in the Prepare Calc study, Rotablator versus a angiosculpt-based strategy, there was more crossover to Rotablator in the patients with the angiosculpt-based strategy. That having been said, 80% of the time, the angiosculpt-based strategy seemed to work, although we don't really know what the MSA of those stents was compared to the Rotablator arm. Now, there are other devices as well. Orbital atherectomy is a device we have here in the United States. This is a device that is a single burr, and it functions through a 6 French system. You can actually put it through a guide extension as well, and everything is contained without a foot pedal. And in the Orbit 2 trial, the registry, actually, the trial met its primary endpoint for safety and efficacy, and this is what led to device approval. There are rollouts of this device throughout the world now. We're hoping that Europe will get it relatively soon, and the question is when it will come to other locales as well. We are, though, with this specific device, doing a large randomized trial called the Eclipse trial, which is 2,000 patients with severe calcification randomized to an upfront OAS-based strategy, orbital strategy versus conventional angioplasty, to determine if atherectomy can actually reduce the rate of 1-year target vessel failure, and in conjunction can demonstrate a bigger MSA by doing atherectomy up front. Of course, we'll look at safety and all those other endpoints. And the reason we felt it was important to do a randomized trial like this is because that's really the only way to advance this evidence and to deal with this gap in treatment, where you have a lot of patients with calcium who are not getting treated with potentially therapeutic and efficacious therapies because of unfamiliarity and otherwise. So that's kind of been a whirlwind of the data and types of devices. In conclusion, I will say that coronary artery calcification is becoming more and more prevalent in the modern day cath lab in what I would call the chip era. The reason for that is patients are getting older, they have more comorbidities, and we're seeing more downstream presentations. This is a term that Jeff Moses likes to use, where basically if we're doing upfront medical therapy for many patients, then what that basically means is that we're seeing them at later stages of presentation where they have more severe disease and more calcium. Calcified lesions are among the highest risk lesions we treat. Remember, they are associated with short-term pain and suffering as well as risk for the patient. So neither you nor the patient does well with these lesions. So we have to figure out better tools in order to treat them safely and effectively. Long-term outcomes also, it's not just getting the stent to where it is. It is worse to put a stent in that's underexpanded than to not have put in the stent at all. And that leads to longer-term adverse outcomes if you do put that stent in. I think imaging is a must. We didn't talk about this expressly or explicitly, but we feel that especially in calcified lesions, imaging is a must because it can help you diagnose the calcium, and you may change your treatment based upon this. And this is something that I demonstrated the TCT live case I did. Others demonstrate this as well. It really changes our strategy. It's not just to show that there's calcium, it changes what we do. This is after the initial lesion preparation as well, to document a fracture and be sure you're okay but to implant the stent. And finally, at the end, to optimize your stents. And then finally, the last thing I'll say is the field of adjunctive therapies for calcific lesions was literally calcific. It was ossified. It was lying dormant for a long time, but it's heating up now. There's more and more data. There are more technologies, more devices. And so it'll be an interesting area to follow, particularly in the years ahead. So with that, thank you so much. Happy to take any questions. And again, thanks so much for having me at the conference.
Thank you, Dr. Kirtane, for your excellent lecture. It's outstanding, fantastic. And thank you also for coming despite your busy schedule, overlapping schedule. I would ask the panelists and the chair if you have some comments or question to Dr. Ajay, because he has to leave us early. So we'll be going for the detailed discussion on calcified lesion on the next session. And if you have any short question or comments, Dr. Fereng, Dr. Ramesh, Dr. Imad, and Bijoy Bang is there, Dr. Devabrata Rai, you can have your questions. Thank you very much again, Ajay, from NIC, CSI, and all of us. Thank you very, very much.
Yes, Dr. Ajay, I just have one question. Dr. Ajay, no, do you image in all your cases? Because calcium is, the assessment will be better when you image. So do you do everything, for all the cases, do you do OCT IVUS?
Yeah, so at Columbia, we're now above 80% imaging for our PCI cases. I'll tell you the cases we're not imaging are ones that are very, very distal, or there's some other reason not to, but for almost every case we want to. The challenge about imaging, by the way, for many, and this is less of an issue because I know there's more OCT now in India, is that sometimes the imaging catheter is not going to cross the calcified lesion. And so especially with IVUS, we have all the HD IVUS systems, and we even with Philips have a smaller rotational catheter that allows you to cross. So I think that the problem that's happened in the past is that many people just know that the Philips Eagle Eye catheter is not going to cross, so then they say, okay, we can't image, and then that's the end of that. But there are other solutions to that are really, really effective now.
Ajay, Vijay Bang here. How are you?
Nice to see you.
Good, nice to see you. Just a question that, when you do a rota versus orbital, what is your take as against the wire bias in the two techniques?
The new orbital wire, which is the Viper Wire Flex, has a much more flexible wire. And so there tends to be less bias associated with it. Up until that wire came out, I think orbital had a lot more stiffness. It was even more so than the Rota XS wire. We tend to use the floppiest wire we can for the lesion because I think that the challenge that people have is you have to take, I personally view, when I train fellows, tell them they have to take a picture with the wire, the atherectomy wire down the vessel. Because if you take a picture and the wire is straightened out like this, that's when you know you're going to have a perf irrespective of the device. So right now, I think with the flexible wire, orbital can be favored in those cases, but you just have to be careful. And I like the fact that we have both because we use one in some cases and the other in other cases.
There is a question
about any observation about the difference in the restenosis or MACE rate, outcome rate between the two?
Right now, nothing comparative. And I also personally view that at some point we're going to need to have comparative data about shockwave 2, because the challenge with all these single arm studies is that you don't have any comparator group, and it's apples and oranges. So I think at some point, maybe you guys could do a study, for instance, in India, looking at these different technologies and figure out.
We don't have orbital as it. We don't.
No, I meant like shockwave versus rota, that kind of thing.
Ajay, I'm Dr. Khan. Yeah.
Hi, Dr. Ajay. I'm talking of calcific nodules. I mean, that's actually seen every time we talk of calcium in the coronary. Now, suppose you do everything that you know. I mean, you take a rotablator, you take a high-pressure balloon, and still the nodule persists, and then finally you have to stent. And the stent is going well over the nodule, and that means it is well opposed. And since the vessel is big, you get a good cross-sectional diameter at that particular area. You think long-term would be good? I mean, the stent is well opposed.
Yeah, great question, and nice to see you. So this issue of calcified nodule is one that's only come up more recently. I think probably because of OCT more than otherwise, and it's tough to say. I just got myself. I had this nice friendly argument with Akiko Mihara, who works in our lab. We had a left main with a calcified nodule, and it seemed to expand well with a balloon. I put a stent across it without doing atherectomy. I think Akiko got a little bit not angry at me, but she said, "Oh no, it's more prone to plaque prolapse or the nodule prolapsing later," which she has seen and which has been published. So you have to think about it. On the other hand, as the scenario you described, where you've done everything you could already, there's nothing further to do. And the other thing too is that it's very debatable as to whether something even like lithotripsy is going to have effectiveness on an eccentric nodule as opposed to circumferential calcium all the way around. So I think we just need to study it more and figure out if there's anything we can do at all.
Thank you very much, Dr. Ajay Kirtan. And no more question, please, because our guests from Europe, 3 guests are waiting for their lectures and the time is limited. So I again thank you very much. And if it is possible for you to stay for some more time, I should request you to chair our session for a little more if you can. Otherwise, we would request and we would thank you very, very much for accommodating us. Thank you very much, Ajay, really from NICCSI. So I would request our next speaker, Dr. Shaidur Rahman Khan from Bangladesh, to talk on predictors of outcome in non-left main bifurcation PCI. So back to bifurcation. Next, we'll be going to calcified lesions.
I think I'm invisible.
Yeah.
Okay. Thank you very much. I was actually indulged in calcium for a moment, and later on again we are back in bifurcation. But after the legendary assertions from the legends, then my mind is bifurcated. That what actually left for me to tell, and the topics, the predictors of outcome in non-left main bifurcation PCI. Actually, it's a huge one, and actually starting every component, starting from the coronary lesion bifurcation and studying all the stands or the techniques and everything, actually the predictors of outcome in non-left main bifurcation. I want to start with a case, not the best of my complicated case, but rather on the day-to-day simple cases, which sometimes becomes a little bit, that confusing. How to do it. It's a 62 years old hypertensive dyslipidemic male with class 3 angina with preserved ejection fraction. Actually, this angiogram is also the 6 months back. He has another angiogram with the same scenario. That means that his CTO in RCA and also, of course, also the CTO in LAD, though that CTO, the JCTO is very low and easy to handle. So this case, I have to take the Wilder XT, and then I have been able to cross the LAD, and we have a very just closer to the nearer to the ostium is the big diagonal branch, what you have seen there. So I've wearing the side branch, and then I have done the IVUS after pre-dilatation of the LAD lesion, and the IVUS to see the vessel dimension of the target vessel, and also to see the side branch, because angiographically it was showing a little bit 30 to 40% stenosis. But side branch appears in IVUS is not ugly at that extent. And then after pre-dilatation, the LAD was stented. But the thing is that here, you can appreciate here that I don't have any small balloon more than less than 8 millimeter in our docket. And that's why which was very necessary for this one, a port, that was not possible because of the sizing of the balloon. And after just stenting, the patient became bradycardic, and we have seen a little bit slow flow and in the side branch. And then what has happened, I have post-dilated by the NC balloon, and after that, I have done an FFR to the side branch. And after FFR looks pretty 0.95, so I have been relieved a bit. By this time, the patient has been stabilized, and I have done the post-stenting IVUS, and the IVUS looks pretty good with oil apostent, and also the no residual plaque shifting or in the side branch. So the final angiographic picture was pretty reasonable for me. So bifurcation stenting is still a dilemma, account for about 15 to 20%, and it's an individualized approach in almost all the cases. Treatment is individualized, and case-based thoughts are very much necessary because of the variation in anatomy, the plaque burden, the location of the plaques, and the angulation, the dynamic changes in anatomy during treatment, and plaque shift and sections, and for these reasons. And most importantly, which I always feel, though I can't understand that one, it is the basics of the pathology there, is the ESS, which always I want to keep in my mind to find out, to keep the lateral wall just as much as we can make it beautiful for bifurcation stenting or bifurcation treatment. And for bifurcation, obviously, it's this three components of the bifurcation. It's like three Caspers we have to deal with. In general, so if I come to the predictors of the outcome in non-left main bifurcation PCI, especially for both procedural and long-term outcomes, it depends on the side branch itself, the reference vessel diameter of the main branch and the side branch, the anatomy of the lesion and complexity, the bifurcation angle itself, the choice of the stenting techniques, the stent type and the platforms also. And other than these, the presence of the risk factors like diabetes mellitus for long-term outcomes. And from the definition criteria, also we can add here that in the side branch, if there is calcification, if there is multiple lesions, or if there is thrombus containing lesions there, then these are also a predictor for success and in procedure and also for long-term outcomes. Predicting the PCI outcomes, we have to remember and consider some points of bifurcation PCI as a whole, which some of the points has already been touched by our legendary speakers before. Like Medina classification, we have to remember all the time. It's though it is not showing everything, but at least we can, it gives bifurcation a sweet name. So that's why it's important sometimes. And if you can go to the strategies, the two strategies like provisional single stent strategy or the systematic or upfront two stent strategy, especially for the true and for the complex bifurcation lesions. But meta-analysis from before, it has been told that the provisional single stent strategy is better in huge meta-analysis like 5 RCTs and 7 observational studies. But at the same time, another meta-analysis and RCTs involving around 2,569 patients, and it has shown that two stent techniques are also good at least. And also the latest one has also shown that in definition 2 is that for complex CVL, two stent strategy is really better. So we need to know the third Casper to predict the outcome, actually the side branch, which has been already touched by everybody. The important side branch is a driving force, and a significant side branch, which already it has been told that more than 73 millimeter by CCTA, if we can measure this one, and more than 10% of the myocardium if it supplies, and also the more than 10 millimeter of the disease is extending there. And VResolve, there's a recent publications there which predicts the SB complications if independent risk factors are there, like plaque distribution, TIMI flow before stenting in the main vessel, pre-procedural diameter stenosis of the bifurcation core, and bifurcation angle itself. The diameter ratio between MV and SB is very important. Some different points are there, and diameter stenosis of side branch before main vessel stentings. And here, the active side branch protection is necessary or not, that we can predict by this trial. And of course, this meta-analysis, which everybody said, for a huge patient of around 6,000. And here, if the side branch lesion length is less than 10 millimeter, then it favors the one stent. But if it is more than 10 millimeter, it favors the two stent strategy. So in case of more than 10 millimeter length, the two stent strategy is better than the one stent strategy. And also, we have to remember the angle, and we have to study it properly and understand it properly, especially before, after angiography, and before wearing and after wearing the side branch to see the angle. And the cutoff value is more than 70 or less than 45 is very important to choose a technique. And for these techniques, you know, the DVC has the modified techniques. The standard techniques are like these, everybody knows these things, the DK crush and tap or culotte is mainly allowed. And then comes the inverted techniques, which actually sometimes are live, like sometimes for bailout stentings. Clinical outcomes, which also come after bifurcation PCI techniques. This review is telling that all these techniques like tap, crush, provisional DK crush, and culotte, the crush is also in the lead in the race. And if we see another case here, it's a bailout PCI for a primary PCI settings in a 50-year-old male with a huge extensive anterior MI with hemodynamic compromise. And we have here seen is, we are seeing that it is a 011 bifurcation lesion with totally occluded LAD just after the diagonal branch. And also the plaques, subplaques were there in the side branch. And open the artery was the main thing, as the patient had was experiencing VT and took the DC shock to revert himself. And then we have wired the LAD, and we have also wired the side branch. Then we have stented it, the LAD, predicting that the plaque shifts which were there, or the subplaques were there, can be just stabilized by the IC, GPI, or other things later. First, to stabilize the patient by opening the LAD. But after LAD, stenting, and after port, and by this time the jailed wire has been removed, which is also very important things to remember for everybody, that wire wrap was there. So I have to pull up the wire and to make that finish the case as early as possible. But after port, the patient experienced severe chest pain with fall of blood pressure, and we have seen that the diagonal branch itself is not actually behaving well. So we have to rewire, and we have to do a KBI, and then later on we have to do a bailout stenting with a tap, and then a KBI port, and the final picture, what you see here, is not good. So this, other than this, up to this case, few other issues we also have to remember, which already has been told by this thing. The side branch FFR after main vessel stenting is very, very much important, which I have shown in the first case also. Because sometimes the jailed straps or the or the carina shifting can just mimic like give you an oculostenotic reflex to go for the two-stand strategy. So FFR is very much important here. And other thing is that the POT, which is very much important, and it's a very important predictor for the long-term outcome. And at the same time, the POT, KEYS, POT. These three terminologies are very much important to remember while doing bifurcation for any techniques. Another angiogram, before finishing it, I'm giving you just an angiographic view of this patient with an honest TMI 2 weeks back, came here for an angiogram, and after angiogram, we have seen this this view where you can appreciate that this LCX is the culprit lesion here and proximally, and also the huge branch as is the dominant system. It has almost 90% stenosis in ostium with at least 001 bifurcation. So how we have to deal it, as I am going to do it tomorrow. So what can be the best technique for this side branch lesion technique? Which techniques will be best for you? So that one is the most important thing here. And that one, by this way, my take-home message is keep it simple and safe, understand and respect the original bifurcation anatomy, optimize the flow and function of a bifurcation, and limit the number of the stands, obviously, not in the complex bifurcation cases. And as I'm a radialist, radial approach is not a limitation for bifurcation. And of course, don't forget the POT and the KBI, and you can smile in the long run. Thank you very much for your patience hearing.
Dr. Rahman, excellent lecture. Fantastic. You have done so well, and congratulations. And I also appreciate our, bilateral ties with CSI NIC and Bangladesh. First time, I think, we are organizing a joint meeting. Thank you very much. And give our regards to all the cardiologists of Bangladesh community. And now we are joined by 1408 cardiologists and also paramedical staff, I think. And I extend our gratitude and regards to all of them for giving their valuable time. And just a few minutes discussion, because our European guests are waiting to deliver their lecture, and we are a little late, about 30 minutes late we are going. And so I would request Dr. Fering to summarize the session in short, and then I'll also ask Dr. Imad Shiban to take up the discussions, one or two if there, and also to Dr. Bijoy Bang to have one or two very short comments. So Dr. Fering, please.
Yeah, thank you. I would suggest what we have learned today from the bifurcation lesions. It's a very clear topic to tell you. We have learned that if we have a simple anatomy, we should primarily try with provisional approach. Simple can be treated usually with a simple way. But if we have primary, very complex bifurcation anatomy, we can go, and we have more and more clear evidence for that. Then we can go primary with double stenting for left main, especially with a decay crush. This is, I think, one very important message to you. What we have learned regarding the topic calcifications, I think also from my point of view, we are high volume center in Germany, and we performed last year more than 300 rotablation PCI. So I performed around 130 cases, and what we observe regarding the aging population, and you will have this this problem also, more and more all the patients with really complex calcific lesions. Lesion preparation is the most important topic, and you have to know how to perform at least rotablation. The IVL, the shockwave treatment is not so easy, because you need a 1-millimeter channel to come into the lesion. So in some cases, a combination of both rotablation and shockwave will be also option, because optimal stent treatment and stent implantation is crucial point. Thank you.
And one simple question, we learned from Ajay, who is working in US, that they use in 80% of cases imaging modality. But on that day, Dr. Goran was speaking, you were also there, we had a wonderful occasion, and he told that in Europe, the incidence of using imaging in bifurcation lesions is only 8 to 10%. The same situation also in our country, because there is no mortality data to tell that imaging reduces mortality or the morbid, though it improves the outcome of the procedure, but there is no hard data to prove. So what is your option? Because OCT is so costly here, also IVUS. So what is your option? Because I like Dr. Goran's statement that only in 8 to 10% cases you perform in bifurcation lesions. And also I would request you in EBC left main, what percentage of patients you use this imaging modality?
Yeah, this is a good question. We usually, in general, in Europe, there is the frequency for using imaging is definitely lower than compared to US and Japan. There is, I would suggest, regarding the centers, high volume centers are doing something between 10 to 25% imaging. Definitely not so in not so many cases like US or Japan. And what we do in our center, we do usually imaging if we have a question, if I don't understand something, or I'm not really happy with the result, then definitely, from my perspective, to do imaging is a must. But if you're really skilled, if you do 400 or 500 PCIs a year like me, I think you can compensate with your expertise, with your knowledge. It's so
That's
much
right.
good points. Okay, for youngsters it's okay, but for me it's I just take it with the RCT if I have really questions. If I'm not happy with strategy primary, or if I'm not happy with the result, to make 100% result.
Thank you very much. Dr. Debabrata Rai, any comments on this? You also do a lot of interventions, Dr. Rai? Short comments? Dr. Rai?
Yes, please unmute.
Oh.
Please unmute.
Just talking to the question. So I would request Dr. Imad Shivan to have some very short and precise comments, please. Dr. Shivan, to wrap up the session.
Well, actually, I really enjoyed this meeting. This section about the bifurcation, we have examined so many things, so many issues. My idea that what I also see during this section, that there is still lacking a definition or what is complex and what is simple. Because I think we should come to a global definition, that means universal definition about simple bifurcation, what is, how to define, and what is complex bifurcation. This is as a crucial issue, because I think accordingly you go for simple stenting, that means prevention stenting, and complex stenting. We're still mixing together simple and complex and speaking about kissing every time where it is recommended everywhere and so on. So I think that the essential point is to define what is simple and to keep it simple, what is complex, and to go for complex. This is.
Thank you very much. Yeah. Thanks a lot, sir. Yeah.
Yeah.
Yeah, you finish your step. Yeah.
The second point about intravascular imaging, I think, we do not have the resources that Japanese have, so they are using 100%. I think also in our cath lab, we are using not more than 10 to 15% of cases. globally. But if we look on distal lift main, we are doing complex interventions in distal lift main, we are using that up to 50-60% in cases. So it depends on type of intervention you are doing.
So thank you very much, sir. Thank you, Dr. Fehring. Thank you, Dr. Rima Shivan. Thank you, Dr. Rahman. Thanks, everybody. And I would request you, if you be with us in the chairs, if it is possible, because I know you are very busy and it's a Saturday evening. So anyhow, if you can stay with us, we'll be very, very grateful to you. So we are going to start our next session on calcified lesions, and it will be chaired by no other than Dr. Ashok Sheth, Kajal Ganguly, Dr. Sengoto Velu, our good friend, Dr. Ramesh, Dr. Srinivas Kumar, Dr. Prakash Hajra, and Dr. Mohammad Ghulam Azam from Bangladesh. And the expert panel consists of Dr. J. Nayak, Ronnie Matthew, Dr. Rajiv Bhagavat, C. Raghu, Prakash Mandal, Dilip Kumar, Jabir Ekutti, Dr. Shunib Banerjee, and Dr. P.V. Joy Gopal. So I hand it over to the chairpersons, and the first topic has already been given by Dr. Ajay Kirtani. So Dr. Christopher Never is a very good friend of ours, and he is a very respected person in our country, and he will be talking on how to negotiate balloon and stent in a torsade calcified lesion. So Dr. Never, please kindly introduce him. I refer it to the, our chairpersons. Thank you.
Thank you very much, Devan. That was very kind of you. The first talk, of course, the calcified lesions you've just heard are a nemesis for interventional cardiologists. And I'm glad this topic is at the end, because I'm sure a lot of those 1,500 interventional cardiologists who are watching the CSI NIC meeting would actually be on the, watching the screen. Whenever we see calcified vessels and have to intervene on them, the first thing we actually say is, oh my God, not me. Why me? They are practically the most difficult lesions to treat, especially as we go into more and more complex cases, elderly cases, those with renal failures, CHIP cases. That's what we're faced with. So handling them has become a science and an art much more in the last 5 years, with a variety of treatment options available, and then to utilize them judiciously to get the best outcomes. So it's great to have Dr. Christopher Naber talk to you about...
Ashok, a little intervention. Dr. Never is not available. He'll be joining later. Okay, so we'll be requesting Dr. Luca Testa.
And he's a great friend. And I think he's going to talk about cutting, scoring, and OPN balloons. Ultra-high pressure balloons is one of the interesting and very good options for these heavily calcified lesions. Luckily, in India, we have 3 major options available to us. We have rotational atherectomy, we have ultra-high pressure balloons, and more recently, we have IVL. So I think there's no better person to tell us about the use of these specialized balloons for plaque modification in calcified lesions. Over to you, Luca. Very good to see you.
Hello, everybody. So it's always a good pleasure to see you. Well, I would prefer in person, but it's it's not the right time everywhere, unfortunately. So Ashok, it's always a good pleasure to see you. I'll try to share my screen and see. Well, I hope that you. Okay. So let me optimize. And okay. Please confirm that you see what I see.
Yes,
in presentation.
We do. We see your
presentation mode. Not sure.
Yes, we do.
Okay, is it? Okay. So, well, you said that. I mean, this is probably the nemesis of all of us, because every time we see a lot of calcifications, we wonder whether we should do one technique, another technique. There's always kind of a merging of art from one side, but also science. Sometimes we don't have a lot of data, so we need to really try to find out what's the best getaway from that case. But anyway, let's try to define why are we here. Calcifications are not so rare. And if you just look at the left side of the slide, you see that in time, the presence and prevalence of type C lesions with a lot of calcifications have increased steeply. And this is something that, of course, we all observed. And it's also, we are not talking just about the fact that we see calcium. The problem with calcium is that it affects the outcome of what we do every day. This is just historical data, but it's just to show, introduce the subject. If you look at a calcified control, well, they behave much worse as compared to non-calcified treated segments, but also calcified treated segments. So calcified lesions are not just, anatomically different, they behave differently. But why is so crucial to prepare a calcified lesion? Because, of course, the non-uniform stent strut distribution and malposition may result in more intimal hyperplasia after stenting. The minimal stent area and stent underexpansion are major predictors of stent thrombosis. And stent thrombosis, only 22% of patients that experience that have an optimum PCI. So if you just actually look at the reverse of this data, almost 80% of patients with a stent thrombosis have suboptimal PCI. And IBUS guidance may result in more effective stent. We just said about the IBUS, but the problem is that not all calcifications are equals, because we can have superficial calcified plate, deep intimal calcification, scattered microcalcification, but also nodule. It makes a lot of difference whether the calcification is superficial or deep. Just an example, if it's so superficial, of course, we'll have an headache to cross and navigate without the devices. If it's not, because it's deep, well, we may actually cross easily. However, the expansion of the stent is going to be a problem. We have a lot of devices, as you said before. So we have atherectomy, can be rotational, orbitals, laser, direction, and so forth. But also atherotomies, like cutting and scoring, and some special balloons, like a chocolate and lithotripsy. Let's start from the basics. So we all know about the atherotomy and the cutting balloon and the scoring balloon. There are a lot of possible, let's say, examples. I want to just show a few things. Let's start from the simplest, the cutting balloon. The cutting balloon is usually a non-compliant balloon made by nylon material, predictable and consistent dilatation, because of course it's non-compliant. And there's also secure fixation flexible atherotomes. These atherotomes are actually made to actually cut the lesion. Diameters are, of course, different, and length and so forth. What is the point? The point is to create microsurgical incisions in the vessel wall in order to get these areas weakened and so more inclined to be dilated at lower pressures. So the aim of this is to change the compliance of the lesion. What are these atherotomes? These atherotomes are T-shaped notches designed to enhance the flexibility and fixation to pad. But the point is, as I said before, if we cut the lesion, we make it, let's say, easier to expand the balloon. The Wolverine is probably the last version of the balloons that we have nowadays, and is made by Boston Scientific. It's made by 3 or 4 atherotomes that expand radially and deliver longitudinal incision in the plaque. The cuts are actually longitudinal, and rather than causing an uncontrolled disruption like inflating a balloon, they ensure that the cracking or propagation happens in an orderly fashion. There are some data, of course, we don't have plenty of time to discuss, but it's just to mention there are a lot of small studies, unfortunately, in particular, nice cut and rescue cut, they show that the cutting balloon angioplasty effectively facilitates the intervention procedure and leads to a low rate of recurrent stenosis in osteal bifurcation, coronary lesion. We will talk about osteal lesions in a minute. The rescued as well, CBA did not reduce recurrent ISR and major reverse cardiac events. However, CBA was associated with procedural advantages, such as use of fewer balloons, less requirement of additional stenting, lower incidence of balloon slippage. What about the sculpt? Well, the angioplasty balloon catheter is exactly the same angioplasty catheter than any other. However, there are some scoring elements. The scoring elements are rectangular laser cut needle electropolished with helical configuration. And this is the mechanism behind. And they reduce the slippage, first of all. They have a very high dilatation force, and the rate of major dissection is really, really low because this cutting force, this scoring force, is absolutely under control. These are just an example to show with the OCT that in the right side of this slide, you will see that in the first example, the E, you see that the lesion post-angiosculpt demonstrate the scoring. This scoring is just the arrowheads. Left side, but also the right side. Again, some data coming from the literature. I mean, in this trial, it was a randomized control trial. 252 patients have been randomized to an intimal modification by means of scoring balloon or standard lesion preparation. And that's the result. Diameter of stenosis, of course, it was absolutely in favor of scoring balloon. The late lumen loss was almost equal. But in terms of recurrent binary stenosis, there was a clear advantage of scoring balloon, but also the minimal lumen diameter in segment was absolutely in favor of the scoring balloon. So in other words, it was easier to achieve a better expansion. The angiosculpt X is something different because it's a sculpt balloon, is a scoring balloon, but with drug delivery. So in other words, instead of just cutting the lesion, it is also able to deliver some drug in order to, of course, reduce the percentage of restenosis and to increase the effectiveness of this procedure. Just one trial, just some data. This PATENT-C trial was a prospective randomized controlled trial of treatment strategies for BMS restenosis. So we are talking about, or historical data. However, the advantage of angiosculpt X using the drug was absolutely in favor against the normal angiosculpt. So in order to summarize now, the angiosculpt itself without drug delivery is a useful adjunct to modern interventional practice. However, the angiosculpt X offers novel strategy for treatment of side branches and small vessel. And of course, there is a question mark over the ISR treatment side branches. Unfortunately, there is a lack of clinical data. As I said before, there are some special balloons we need to talk about. The Shockwave, of course, and the chocolate balloon. I'm not sure this is available everywhere, but let's start from this one because it's probably the new kid on the block. There are some constraining structure that controls the balloon expansion, prevents air shear stress. There are also some dilation pillows and plaque channeling grooves that allow focus force during dilation and allow for seepage of plaque. The chocolate bar registry showed low rates of dissection and bail outstanding peripheral interventions, now approved for use in coronary artery as well. So this is just the design, just click this. But the thing is, when using this new balloon, this new concept of balloon, there are very few limiting dissection during PCI. So in other words, it seems to be absolutely safe and absolutely effective. Of course, again, in this case, we need more data in order to implement this device in our current practice. There are some clinical indications suggested for it in situations where DS seems to be more problematic. And it's also a matter of attitude, of course. Indeed, talking about small vessel, bifurcations, DAPT contraindications, or in the last years, not now, best preparation before BVS. Unfortunately, BVS history is all known. Of course, I need to talk about intravascular lithotripsy for a little bit. You all know about the technology of the Shockwave, so I will go fast on this. But the point of the lithotripsy, the Shockwave, is to create these cracks in the plaque in order, again, to facilitate the stent expansion. So we are not talking about saving lives. We are talking about optimizing the results of our procedure. Or in other words, we are talking about improving the stent expansion and the stent apposition. The Shockwave is very user-friendly, to say, and I don't see that the intravascular lithotripsy is, let's say, against the rotablation. I think they are complementary. There are also some tips and tricks. I need to skip this for the sake of time, but I need to mention the rotational atherectomy. Rotational atherectomy is there since 30 years, maybe more or less 30 years. And of course, there are a lot of, let's say, different approaches to atherectomy. I have personally a very low threshold for atherectomy. So every time I see something I do believe that atherectomy may be of help, I always use it. Nevertheless, this is again a matter of experience, a matter of attitude. Nevertheless, we need to remember that when we use the rotablation, we are doing something that is really debulking the plaque. With any other balloon that we talked about today, we are not debulking anything. We are just improving the compliance. We are not actually reducing the volume of the plaque. So it's time to summarize. I mean, this is our portfolio. And in the left side of this slide, in this table, you may see that there are ablation techniques, rotational, orbital, and laser, and balloon-based techniques like cutting, scoring, super high pressure balloon, and lithoplasty. So we need to define these two groups according to the real mechanism. And the real ablation techniques are those uniquely actually aimed at reducing the volume of the plaque. Balloon-based techniques are only, let's say, aimed at improving the compliance of the plaque. So in other words, this is just a small list of the benefits of rotational atherectomy and lesion modification. So we can minimize the vessel trauma, enable lesion access, facilitate stent delivery, optimize uniform standard position, create a larger MLD, and avoid rotor regret. This is one possible flow chart. Of course, this is also depending on the attitude, depending on the experience. I will also say depending on budget constraints and local availability. However, the very first thing to understand if the balloon can cross. If it doesn't, of course, in that case, we need to use some more advanced techniques, using maybe a microcatheter. And in that case, we can switch to rotational atherectomy or orbital atherectomy. However, on the other side, if the pre-dilation is possible, in that case, it's strongly suggested to use OCT or IVUS imaging in order to understand some other anatomical features like the archum, the length, the thickness, and so forth. And in that case, we can decide if we need to use a non-compliant balloon, cutting, scoring, rotational, and so forth. Again, this is just a possible flowchart, and I'm pretty sure that every single expert operator has his own. Thanks for the attention. And again, thanks for this kind invitation. It's always a pleasure.
Dr. Ashok said we can't hear you. Great talk,
Ashok, I mean, you need to unmute.
Sorry, okay. What I was saying was
good. That's good.
That was a great talk, great overview. What I was saying was that we did miss out on talking to some extent regarding the ultra high pressure balloons, but we're going to address this in the discussion at the end, because the techniques and tools for treatment of calcified lesions is not one or the other. It's a continuum of a process where multiple modalities may be used to get a good result. So it's best that we talk at the end about all these, including the ultra-high pressure European balloons. So thank you, Luca. We should move on to the next one, which is calcified lesions with a special mention and specifically for IVL in calcified lesions, going to be presented by Keith Dawkins. And Dhiman, is Christoph Naber going to be talking later?
Yeah, we have been trying, just hold. We have been trying to contact Dr. Christopher Naber. I'll inform you within next 5 minutes. Okay,
Sure. So we have Keith,
So
Keith,
Professor
course,
Keith Dawkins will be speaking.
That's right, and he's a tremendous interventional cardiologist. Who has been the CMO of Boston Scientific and is now the CMO of Shockwave, but a very experienced interventional cardiologist and a great friend of India and a personal friend for years. Keith, great to see you. Over to you.
Thanks very much, Ashok, and thank you, India, for inviting me to give this talk, to bring you up to date on the recent data for intravascular lithotripsy. I'm the CMO of Shockwave, and therefore I'm obviously conflicted. You've heard today, and of course are well aware of the fact that you all now have a number of techniques to deal with calcification. Balloons of various types on the left, atherectomy on the right, lithotripsy that I'm going to talk about, and obviously laser atherectomy. Many of you have already used IVL in India, and you know the principle of how it works. An expanding and collapsing vapor bubble creates a short burst of sonic pressure waves, and these pressure waves have a transient, very high pressure of up to 50 atmospheres and cause a localized field effect that can crack calcium and leave normal tissue or soft tissue unaffected. You see a typical case here on the left. There's a heavily calcified OCT image, so almost circumferential calcification with a lumen area of 1.69 millimeters squared. And following intravascular lithotripsy in the center image, you can see fractures which are obvious at 12 o'clock, 6 o'clock, and at 4 o'clock. And already the lumen area is increased to 4.58 millimeters squared. And then following stent implantation, the stretching of these fractures, so the lumen area increases to 9.51 with a stent area of 8.01. Currently, there are 3 Shockwave IVL products available. The C2 product is for coronary use, and the number is indicative of the number of emitters. So the C2 has 2 emitters, 80 pulses, available 2.5 to 4, and one length currently at 12 millimeters, and it can be run over any 014 guide wire, and is 6 French compatible. The S4 and the M5 larger devices for BTK, iliac, CFA, and SFA use more pulses, a larger diameter, and a little larger, some of them, in terms of the sheath size. So there are 4 Shockwave-sponsored DISRUPT studies. The first on the left is DISRUPT CAD1. This was a single-arm feasibility study, 60 patients in Australia and the EU, published in Circulation last year. And this was followed by a study twice the size, the CMARC study, 120 patients, same protocol, published in Circ Intervention. And I'm going to talk to you today about DISRUPT CAD3, which is the pivotal trial, 384 patients in 47 countries, 47 sites in the US and the EU, already published. And just a mention of DISRUPT CAD4, which is the Japanese approval study, which is also completed 64 patients. So this is the CAD3 study design. Dean Kariakis in Cincinnati in the US and Jonathan Hill in London in the UK were the PIs, undertaken in the US, UK, Germany, and France. A prospective multi-center single-arm global IDE study for heavily calcified lesions. Reference vessel 2.5 to 4, more than 50% diameter stenosis by the core lab, lesion length up to 40 millimeters. Each site was allowed 1 roll-in patient, their first patient. So the roll-in patients, 47 patients from 47 sites, and then 384 patients in the intention to treat population. And I'm going to talk to you about the 30-day follow-up, but the patients will be followed for 2 years. The primary safety endpoint was freedom from MACE at 30 days, MACE being defined as cardiac death, myocardial infarction, or target vessel revascularization. And it's important to note that the definition of myocardial infarction was very sensitive. It was a CK MB level of 3 times the upper limit of normal. The primary effectiveness endpoint was procedural success with a residual stenosis of less than 50% without in-hospital MACE. And there are a number of important secondary endpoints. 4 of them are listed here: device crossing success, angiographic success, procedural success with a residual stenosis of less than 30% by the core lab without MACE, and a sensitivity analysis for different definitions of myocardial infarction. So here we are, 431 patients, 47 roll-ins, followed for 30 days, ITT population 384. There were 2 deaths and 1 patient lost to follow-up. So at 30 days, we had 381 patients. The baseline characteristics are shown here. It was an elderly population, mainly men, the majority of which had hypertension or hyperlipidemia, 40% had diabetes. And on the right, you can see that the majority of patients were very symptomatic in angina class 2 or 3 or 4. The majority of the patients were treated in the LAD, and a third of them in the right coronary artery, just a few left mains. And the reference vessel diameter was 3, MLD was 1.1, and the core lab stenosis was 65.1, lesion length 26. The calcified length was very long, 48 millimeters, according to the core lab, and 100% severe calcification. This is the most heavily calcified group of patients ever studied in a formal trial. So the total procedure time was just under an hour, and of course the operators were following a protocol, so it was quite prolonged. Just over 50% of the patients had pre-dilatation, just over 1 IVL catheter per patient, 69 pulses, and per protocol, the inflation pressure started at 4 atmospheres and went then to 6 atmospheres, but no more. The inflation pressure is just large enough to oppose the balloon to the wall of the artery. It's not actually dilating the lesion. A fifth of patients had post-IVL dilatation, 1.3 stents, 99.2% stent delivery, 99% post-stent dilatation. So here is the diameter stenosis at 3 time points according to the core lab, pre-procedure, post-IVL, and post-final stent, falling from 65.1 to 11.9%. And the cumulative frequency shift curves are shown on the right, moving to the right from pre-procedure, post-IVL, post-stent. So the final in-stent diameter stenosis was less than 30% according to the core lab in 99.5% of patients. Here's just a selection of the OCT data. There was a 100-patient OCT sub-study, also core lab adjudicated, and each patient had 3 OCT runs, pre-IVL, post-IVL, and post-stenting. And you can see that the MLD increases progressively, goes up 3-fold from 2.2 to 6.5 millimeters squared, and the area stenosis falls in parallel from 72 to 22. Look at the calcium angle here, 293 degrees of calcium angle, almost 1 millimeter of calcium thickness. And despite that, the stent expansion, according to the core lab, was 102%, with a minimum stent area of 6.5, and only 4.1% of stent struts were malopposed. This is a very safe procedure, and the angiographic complication rate is shown here. Immediately post-IVL in the middle column and the final post-stent on the right side. You can see that final post-stent, the total angiographic complications was 0.5%. No slow flow, no reflow. There was 1 abrupt closure post-stent, which wasn't present post-IVL, and 1 very small perforation post-stent, which wasn't present post-IVL, and that patient went home the following day without a complication. These are the MACE figures, and you can see that CKMB, 3 times the upper limit of normal, defined myocardial infarction. The majority of MACE events occurred in hospital, and very few in the blue bar occur between hospital discharge and 30 days. And the majority of the MACE events were non-Q wave myocardial infarction. So this study was compared to a predicate study, ORBIT-2, which was for orbital atherectomy, and that was defined by the FDA. And there was a performance goal from the ORBIT-2 study of orbital atherectomy of 84.4% for the primary safety endpoint. And you can see that for IVL, this was significantly exceeded. So the primary safety endpoint was met. Here's a similar chart for the primary effectiveness endpoint. The performance goal from ORBIT-2 was 83.4%, and you can see that this was exceeded by CAD3, IVL 92.4%. So the primary effectiveness endpoint was met. It's important to understand the definitions of periprocedural myocardial infarct. ORBIT-2 used this sensitive CKMB 3 times the upper limit of normal definition. And you can see the event rate there was 6.8%, which was very similar to the 4th universal definition. If you define myocardial infarct by the SKY definition, which is a more contemporary use, it's 2.6%. I should say that all these patients that had a biochemical myocardial infarct all went home the following day. Here are the figures on the right for TLF, all revasc and stent thrombosis. The 3 stent thromboses, 0.8%, none of them were definitely attributable to IVL according to the CEC, and they represented stents that were really put in inadequately. Here are the secondary endpoints for device crossing success, very high at 95.8%, and with angiographic success with a residual less than 50 or less than 30, still very high, 96 and 96. With a procedural success of 92.2. This really attests to how easy this procedure is to undertake. If you can undertake balloon angioplasty, you can undertake intravascular lithotripsy. And this shows the results of the roll-in patients in yellow, the 47 patients, the first patients undertaken in that center by that operator, and the pivotal trial patients in blue, the 384 patients. And you can see it doesn't matter whether you look at MACE, procedural success, or device crossing success. There's really no significant difference between the roll-in patients, the first patient, and the subsequent patients. CAD3 was presented the week before last at TCT Connect as a late-breaking trial, and on the same day it was published simultaneously in JACC and is available open access. And there was also an accompanying and very supportive editorial by Philippe Genereux in the same edition of JACC. You've already seen an algorithm for the treatment of calcium, and this is courtesy of Ashok Seth, and shows, and there are a number of these, but this is one that I think is favorable. Diagnostic angiography on the top, down the left-hand side is for patients who have mild calcification, and on the right-hand side for patients with moderate to severe calcification. And you define patients who are moderately or severe calcified according to a point system relating to the severity of the calcium. And you can see if the lesion is completely uncrossable, the patient is treated with rotablate or particularly in the US, orbital atherectomy. And then if the lesion is crossable, if they have a high point score on the severe end, they're treated with lithotripsy, and a low point score, they're treated with NC balloons. And if that's a suboptimal result, they're treated with lithotripsy. And you end up obviously with optimal stent expansion. We do see this as a complementary technique, complementary to rotablator, orbital atherectomy, specialty balloons, OPN balloons, and so on. And obviously, it's another weapon in your armamentarium for the treatment of calcium. It was very exciting for me, and it was probably the last live meeting that I attended in Delhi earlier this year at India Live, and there were a lot of cases treated with intravascular lithotripsy successfully, and a lot of excitement and enthusiasm from the Indian delegates. We're excited also to announce the SHOCK India registry, and this is designed to investigate outcomes with IVL, with the C2 catheter in calcified coronary arteries in Indian patients. It's a prospective multi-center single-arm registry. It's investigator-sponsored research, and my long-term friend and colleague Ashok Seth is a PI. 1,000 patients treated at 30 to 35 sites, and it's going to have extended inclusion criteria, but the 30-day Mason effectiveness endpoints are going to be similar to CAD3. We're working on a coordinating CRO, and Translumina Therapeutics is the sponsor. So in summary, the prevalence of cardiovascular calcification is increasing. You all know this, and you know that vessel calcification leads to adverse outcomes when treated with conventional PCI techniques. Shockwave IVL is a transformative platform technology which is now available in more than 49 countries worldwide. It's very simple, efficacious, safe, predictable device with reproducible outcomes applicable to all treated vascular beds. In the CAD series of studies, we now have 628 patients treated with IVL on the same protocol. IVL is an adjunct to traditional technology, including simple balloons, drug-coated balloons, and stents. I've shown you the CAD3 data. In the US, IVL is approved for peripheral vascular disease, and we're anticipating approval for the coronary bed in the first quarter of next year. It achieved CE mark, obviously in India and Europe and elsewhere in May 2017, and we're looking at other options for being treated with IVL, including treating of valvular heart disease and other vascular beds. Thank you very much for your attention.
Thank you very much, Keith. I mean, that was tremendous. Let me just say very clearly that IVL has been one of the recent but most important additions to our armamentarium for treating heavily calcified lesions, especially in large vessels for a variety of disease processes. And I just congratulate you for the success of the CAD3. There's a lot of enthusiasm about this technique because of the fact that it practically has no learning curve, and also the least amount of complications associated with any of the therapies, specialized therapies for calcified coronary arteries. And I think that is a huge step forwards for all of us. So we hope that the Shockwave India registry, and there's enthusiasm and a lot of complex cases are being done all across India with gratifying results. I think this is going to be another insight into and all-comers use of shockwave lithotripsy, use of shockwave lithotripsy in all comers, including some of the ostial bifurcations and left mains bifurcations which are being performed, some of the instant restenosis which are being performed, and some of the very heavily calcified bifurcations which are being attempted by shockwave at this time in this country. So India has been contributing tremendously to the experience of IVL, and we hope that that comes into the literature in the future. Thank you. I know that there's going to be a lot of questions on this.
No, we'll discuss later on.
Correct. We're going to discuss this later on.
Yeah, let us invite Dr. Ramesh Daggubati, great friend of ours, to deliver his lecture on rotational versus orbital atherectomy in calcific lesion preparation. Ramesh, please.
Ramesh, good to see you.
Yeah, great to see you.
Wonderful seeing you.
Yeah, thank you very much. And it's a pleasure being here, Dr. Kali. Thank you very much for this opportunity, and to all the respected chairpersons and the panelists. So I think this is obviously relevant currently, and in the future, it'll probably will be orbital versus shockwave or rotational versus shockwave, I hope. So I have no disclosures. So calcified lesions are not something new, and everybody thinks that this is something on the rise. But the first 5 cases that Grunsik did, the second patient had a severe calcification in the left coronary artery, about 70%. So if you do just angiography and versus IVUS, angiography actually underestimates the calcified lesions in the green, about 38%, versus actually if you do IVUS, 73% of them are calcified, and about 12% of them are severe calcifications. And you saw this from Luca earlier as well. The outcomes in the calcium are poor. Calcified lesions have a higher chance of death MI, and any revascularization as compared to not calcified, not so severely calcified lesions. And there are complications that occur if you don't recognize the calcification, such as incomplete stent apposition or inadequate stent expansion, and drug delivery may not be the best, and you can either cause dissections and unable to completely dilate the lesions after a stent implantation, which might result in restenosis. You also have seen these slides, so I won't cover these, and actually there's algorithms multiple as been shown by my previous speakers. And let's compare between rotor and orbital atherectomy. Rotor is a unidirectional ablative technique, whereas orbital on the right, you actually can see it's an elliptical, and that's why it's an orbital atherectomy device that can achieve much larger minimal luminarias after the ablation technique. How about the catheters? You have different rotor burrs, and you have to keep upsizing the sheath based on the rotor from 6 French to 8 French burr. 8 French sheets to accommodate 2.20 millimeter burrs. But if you do take orbital, you can easily do it from transradial. That is probably one of the reasons why it is much more accepted in the United States, is that you don't have to change the sheets at all. So let's look at the differences in rotational versus orbital atherectomy. As you see, most of them now have, earlier I think Dr. Bang was asking about floppy wires and wire bias. And even in orbital atherectomy, there's a flex wire now, Viper Flex. So there's no rotor, there's no wire bias in between the two. So you can see that the differential cutting with the rotational and differential sanding with the orbital. And as I spoke to you about, the sizes of the burr is different, and you need different sheet sizes. Most importantly, looking at particle size is actually 5 to 10 microns with rotational and 2 microns with orbital. And even though we say, it should not cause any complications, there is still a coronary perforation that can happen up to 2.5% in rotational and 1.8% with this prior Viper wire advanced guide type of guide wire, still 1.8% perforation that could happen. So in this slide you have seen earlier, so I'll skip this slide as well from the differences between the two. We'll be talking in a little bit. So how about transvenous pacemakers placed and activated? And this is a study by Dr. Evan Schlafmetz, and you're looking at the right coronary artery lesions. When you see with rotational atherectomy, temporary transvenous pacemaker was placed in 11.5% and activated, versus orbital only 3.9%, which is very clinically significant. So most importantly for us, when to use which device between these two. I'm not talking about, as the algorithm has been shown by Keith, that you can depend on if the cannot get any balloons in, balloon not crossable, then you choose these atherectomy devices. So the vessel size, the larger the vessel, orbital atherectomy is more effective while keeping the same burr size. Orbital atherectomy allows for maintaining the need for only 6 French sheath. The smaller the vessel, rotational atherectomy is safer with small vessels while being as effective. To achieve the size with orbital atherectomy in large vessels, we have to increase the speed, but of the atherectomy speed. And so we have 80,000 RPM or 120,000 RPM. If you do 120,000 RPM, there's also a chance of higher perforation. So we usually go to only 80 and C. Unless it is in left main, we go to 120. In rotational atherectomy can engage small vessels better, actually. So vessel tortuosity, the more tortuous due to its floppy nature, initially rotational atherectomy was preferred, but now with the Viper Flex, we all don't have any preference between the two. In terms of the wire itself is great between the two. So rotational atherectomy tracks tortuosity better, although you always have to handle with care, and less tortuous, and rotational atherectomy and orbital atherectomy are equally effective. So I think in my personal use, I don't actually now pay attention to the tortuosity because both of them can cause harm, and both of them have now flex wires. So I don't think really it makes a huge difference between the tortuosity. How about concentric calcium or osteal lesions? Very tight concentric calcium. More concentric and tight, the rotational atherectomy cuts the front and thus engages lesions better than orbital atherectomy, is a thought, at least we think. But it can also stall and be stuck if a pecking style is not employed. So there is a risk with this, with the rotational atherectomy. But if you actually put the orbital atherectomy right in the lesion and can start it, you can cut both backwards and forwards, so that I think the risk of getting stuck with orbital atherectomy is much less. Osteal lesions, the rotational atherectomy remains the ideal choice due to its concentric rotation. Orbital atherectomy may damage the aorto-osteal junction, but it can be used, and I have used it as well. But what we do is we go past the lesion, and then we cut backwards into the from the vessel into the lesion. So that is an advantage that you can use with orbital atherectomy. Here's a 70-year-old patient post-bypass surgery, patent grafts, except the right coronary artery was not bypassed. And here's severe proximal lesion, as you can see, and heavily calcified. And this is a nice case for rotational atherectomy. As you can see, very slow motion and nicely done. And then we were able to actually go ahead and balloon it again with a non-compliant balloon. You can use cutting balloon, I think. And at the end of the stenting, you can see that there's a great result in the ostium here. And so very well done osteal. So here's the pictures, actually, a significant lesion, calcified and eccentric lesion that was done. Here's another patient with a diffuse calcified LAD and a diagonal disease, and this patient had a concentric calcification, but we were able to treat it with the orbital atherectomy here. As you can see, a slow motion, actually 1 millimeter per second almost advancement, and if you need to do it for a longer period of time, you could. In between, we administer nitro and verapamil to make sure there's no slow flow. As you can see, there's some slow flow in the diagonal here, and further ballooning of the diagonal and preparing the lesions, both diagonal and LAD, we thought we could go with the provisional stent strategy and stented the LAD and both the mid and the proximal lesions. And at the end, we saw that the diagonal appears to be a little bit pinched, and we could have left it alone, but we felt that in our fellows, some of them felt it was better to modify tap technique and final kissing balloon inflation later. It actually looks much better, as you can see here, pre and post stenting. A beautiful result with orbital atherectomy and the well-expanded stents. Those are the pictures. Here's a patient with in-stent restenosis that in a non-compliant balloon 3.0, a non-compliant balloon could not actually dilate the lesion. It was still, you can see a big waist over there. And so this was done with, again, orbital atherectomy. So as I said, some people prefer rotational, but can orbital atherectomy be done within the stent? It can be done. You might have to go higher speed. You don't like the sound. The sound is really horrible in the cath lab at the time when the orbital is going through the stent. But afterwards, we were able to expand it quite well and with a non-compliant balloon. And the patient did not need any further stenting after that. And actually, it was very good. You can see the result here. That's so just with the post dilation of that stent. So here's an 80% instant rate. That's the pictures that I wanted to show you with after preparing that. So there's one observational study that or registry from Northwell Health, and they looked at patients 273 with orbital atherectomy versus 273 in rotational atherectomy, propensity matched patients, and the fluoroscopy time was slightly less. The contrast volume is somewhat similar, and significant dissections and perforation, tamponade, vascular complications are no different between the two. As well as in-hospital mortality was slightly higher with the rotational atherectomy, 2.2%. With the orbital, it was 0. And probably, this is the only data that we have to say that the MI rates are also slightly lower, probably because of the small particle size that is sanded, and slow flow is less with orbital atherectomy, at least. So that's what we think. Atherectomy action differences, bidirectional atherectomy without question, a huge advantage of orbital atherectomy. You can go forward and backwards, whereas rotational doesn't do that. And high speed is maybe more deleterious to the reflow phenomena and also cause perforation. So you have to be careful with going to higher speeds with the orbital. And prior stents are trying to avoid orbital as much as possible, but I showed you a case that it could be done still. I think rotational atherectomy is still the ideal option as it will maintain a central location and obliterate stents if needed. Need to maintain a good technique or burr entrapment may occur and upsize the burr to actually avoid that. So in conclusion, rotational or orbital are both very effective methods to optimize PCI in calcified lesions. There are some vessel-specific findings which may decide the device choice. Emerging data suggests a possible association of orbital atherectomy with less myocardial infarctions. Unlikely to ever see a head-to-head randomized study, I think, unless it is just an investigator-initiated research. Okay, thank you very much.
Thank you, Ramesh. Dhiman, can we have our other chairpersons and expert panel comments?
Sure. Dr. Luca Testa is there and others are there. So we'll go to the discussion, Ashok. After Ajit has been waiting for long, he has endured everything. We talked in the morning because to accommodate Dr. Christopher Never and Ajay Kirtani in their time, he has to sacrifice his place. And I am really very much grateful to our great friend, Dr. Ajit Menon. So may I invite Dr. Ajit Menon to deliver your lecture on optimal imaging strategy to guide calcified lesion PCI. So Dr. Ajit Menon, please. Ajit.
Good evening, everyone. Hope you can see my slides. Thank you very much, Dr. Ashok Sheth, Dr. Dhiman. So you don't have to apologize. It's a pleasure for me, and it is a wonderful learning for us. All of us who are still in the process of learning from all of you. So thank you very much for this opportunity. And my topic is on optimal imaging techniques to handle PCIs in calcific lesions. So If you look at the prevalence of coronary calcification, even Andreas Dunziger described the difficulty of treating coronary stenosis in one of his initial papers. And we all know, and this has been seen presented in the earlier slides also, that despite being an exclusion criteria in most of the studies, a pooled analysis of over 13 drug-eluting stent studies reported an occurrence of almost 29% of patients. The prevalence of calcific lesion is dependent on various studies that it has been studied at, and varies from 30% to almost 55%, depending on what study you're looking at. If you look at the pathophysiology of calcified lesions, it elucidates that vascular calcification is the hallmark of atherosclerosis, and the location, density, and confluence of calcification may change portions of the arterial conduit and make it into a non-compliant structure. Having said that, we also know that calcium seeds the cap of thin cap fibrous atheromas and make these lesions prone to rupture because of changes in the tensile forces. And there are multiple factors which are involved in the process of ongoing calcification, and these are elucidated. If you look at calcification, we look at two parts of it. One is intimal, and then the second one is medial calcification. And they are caused by different mechanisms. Macrophages, inflammation, and apoptosis may play a crucial role in intimal calcification. Dense vascular calcification, usually seen in stabilized plaques. Microcalcification, more in high-risk plaques, and these are the plaques which are probably prone to acute clinical events. So why is coronary calcium such a big issue? We do know that there are various prognosticators and risk factors for calcification, and certain parameters such as renal dysfunction, hypercalcemia, hyperphosphatemia, they have a higher prevalence of medial calcification. Calcium severity also corresponds with cardiac death, with myocardial infarction, target vessel revascularization, and evidence of major clinical events. And in one of the studies where calcified plaques were studied in acute coronary syndromes, calcified plaques contributed about 12.7%, of which most of them were superficial calcium sheets. And we all know that treatment of drug-eluting stents and BMS is a vast difference in calcified lesions, and that's seen in most of the studies. In one of the studies of the prevalence, correlates, and impacts of coronary calcification on adverse events following PCI with newer generation DES, which is a retrospective analysis, it showed that almost 18% of patients had either moderate to severe calcification, and this correlated with the incidence of adverse prognostic indicators in terms of death, TBR, and a combination of the two. So how do we approach calcified coronary disease? Of course, you know that better diagnosis, the right technique, and better outcomes have been discussed in all the previous talks, and you have various armamentarια for treatment modalities. However, in terms of imaging, there are various ways that you can image it, and we have various techniques of calcium detection, and each of them have their own pros and cons. Each of them have their own sensitivities and specificities. We know that angiography has a low sensitivity in detecting calcium. Intravascular ultrasound, on the other side, detects superficial and deep calcium. Semi-quantitative grading in terms of distribution, localization, length, and the arc. It has a pitfall in that deep calcium is usually hidden by acoustic shadows. It can't detect microcalcifications. Intracoronary OCT, on the other side, has a very high resolution, can be used to measure calcium thickness, much better quantitative grading of calcium distribution, localization, area, and volume, and it detects microcalcification, the downside being that it uses a significant amount of contrast media. In one of the studies of about 440 patients, which is presented, of OCT, IVUS and OCT guided stent implantation, disagreement between angiography and other modalities was seen in about 4 to 5 patients, but that's basically because of thinner layers of calcium that do not appear to affect the stent expansion. There was no difference in the detection rates between OCT and intravascular ultrasound. This is shown by Ramesh in the previous study, in his previous presentation, that there was a study of patterns of calcification in coronary artery disease, where angiography detected calcium in about 38% of stable lesions, whereas IVUS detected calcium in about 73% of lesions. If you look at this chart on the right-hand side, you see that coronary angio detected 25% of single arc quadrant calcium, 50% of two quadrant calcium, and increasing numbers as the quadrant increases. In terms of the length of the calcium that aids in detection, coronary angio detected 42% of less than 5 millimeters and 61 to 63% when the length was more than 6 to 10 and 11 millimeters. Compare that with the angiographic calcification of mild, moderate, severe, and the extent of pickup as far as IVUS is concerned, where there was definitely a much better elucidation of the data. These are photographs of calcification by IVUS, ranging from a superficial calcium to circumferential calcium over here, a deep calcium on this side. So you have various modalities that can detect, various ways you can detect calcium on an intravascular ultrasound. This was a study of echo attenuated plaques and plaques with spotty calcification using an intravascular ultrasound, where IVUS detected deep spotty calcium is usually associated with unstable plaque characteristics that predict a future rupture. And it's probably related to the presence of a necrotic core, also indicating that these are unstable plaques. Having said that, the ORBIT-2 study was a study of about 400 plus patients with de novo calcified lesions subjected to orbital atherectomy prior to stent deployment. There was a post hoc sub-analysis of procedural outcomes and 3-year MACE which were evaluated. And this study showed that the number of stents definitely reduced in the IVUS group as compared to the non-IVUS group. And the post-orbital atherectomy MLDs were much higher in the IVUS group as compared to the non-IVUS, the non-IVUS group. Well, there are some IVUS predictors of stent expansion which have been reported, and there was a novel IVUS calcium score which can be used to predict adequate stent expansion, and these are based upon 4 different parameters of length of calcium more than 270 degrees per 5 millimeters, presence or absence of a calcified nodule, the diameter of the vessel, and the reverberation arc per 90 degrees. So each of these is given 1 point, and depending upon the point scoring system, if you have a calcium score of more than 2 based on ultrasound, and use of an adjunctive device should definitely be considered for better expansion of the stent. There was a study which is a comparison of the incidence of slow flow after rotational atherectomy with IVUS crossable versus IVUS uncrossable classified lesions. So out of the entire study, they took about 280 odd patients, divided them into 2 groups. And what was seen is that in the pre-procedural IVUS catheters could not cross the lesion, operators should prepare for the occurrence of slow flow after rotational atherectomy. And so the IVUS analysis can be used as a risk stratification for severe calcified lesions in rotational, when you're doing a rotational atherectomy. 2 modes of detection, one based on sound, one based on light transmission. And the presence of calcium can be seen on both the modalities. Whereas the IVUS takes it as an acoustic shadow with reverberations on the back, and you have measurement of the thickness on this, and the arc of calcium which can be detected on the basis of intravascular ultrasound. As far as OCT is concerned, it definitely has a much better delineation of the boundary. You can measure the thickness much better, and the arc of calcium is very well delineated. These are certain pictures of corresponding images of superficial calcium, deep calcium, spotted calcium, and of course, this is one image where probably an IVUS scores over an OCT in this. But this is an image which looks like a red thrombus, but it is actually a hyperechoic hyperechogenic mass on the ultrasound, which basically shows that it's a calcified nodule. So OCT can definitely measure the calcium thickness, and with OCT the light can penetrate calcium, helping in evaluating its thickness. Comparing angiography, intravascular ultrasound, and OCT in terms of the measurement of calcium modalities, of course, I think OCT definitely has an edge over the other modalities and over IVUS in these 2 areas. That's calcium thickness and longitudinal calcium length. And these are histopathology images of a calcified nodule which is seen on an OCT. So once the calcium is assessed, of course, these have been discussed in the previous in the previous talks. How does OCT help in deciding what form of treatment can be used for these patients? You have you can use OCT to strategize the management in terms of the morphology, length, and the diameter of the vessel. Morphology is what drives the strategy, and depending upon whether you have a moderate calcium burden or a high calcium burden, or you have a superficial calcium or a calcium nodule, you can the treatment modalities range from using high pressure balloons, scoring balloons, rotational atherectomy, orbital atherectomy, which of course we do not have, and the use of laser. Pre-PCI imaging can aid in choosing the right strategy, and this is a study of 261 patients with calcified lesions studied with using the calcium angle and the length and using balloon dilatation, where it is seen that balloon expansion can crack calcium effectively for a calcium arc of less than 225 degrees and a thickness of up to 0.24 millimeters. And the Opian balloon trial, which is a clinical trial of very high pressure dilatation for resistant coronary artery diseases, show that calcified lesions yielded to high pressure, to a very extremely high pressure inflation. There's a new optical coherence tomography-based calcium scoring system to predict stent under expansion, and this is based upon 3 factors, and that's the maximum calcium angle, maximum calcium thickness, and the calcium length. And based on these, you have 2 points for the calcium angle, 1 point for the calcium thickness, and 1 point for calcium length. And if the calcium score is 4 or above, you have is 4, then you have a high risk of stent under expansion, and you need to plan your lesion preparation strategy in order to facilitate plaque modification. Use either intravascular lithotripsy, orbital atherectomy, rotational atherectomy, or use of the high pressure Opian balloons. This is basically the validation of the scoring system, where of course where when you have a lower calcium score, your expansion is pretty high, is pretty good. As the score increases, you can see that the expansion achieved is also much lower if you do not use the appropriate modes of lesion preparation. This is a small flow diagram for OCT guided PCI of severe calcific stenosis, depending on whether the calcium is deep, superficial, or nodular. And you have the use of NC scoring. If you have deep calcium, NC scoring cutting balloons, stent, final OCT, superficial calcium, depending upon the CVI score of 1 to 3. Use of balloons, if it is high, use of, that's greater than 180 degree arc, more than 5 millimeters long, and more than 4.5 millimeters thick. Depending on whether it's balloon crossable, uncrossable, you have these 2 modalities of treatment. And if you document a calcium fracture on OCT, go ahead and stent these lesions. And of course, nodular calcium, rotational atherectomy or orbital atherectomy would probably be the treatment of choice. There's little data on IVL in these subsets. And if you have an OCT or a balloon uncrossable lesion, of course, rotational atherectomy or orbital atherectomy would be the plaque modification treatment of choice. If I were to just summarize this, suspected calcified lesions should be assessed by an intravascular ultrasound or OCT prior to stent implantation. Lesion preparation can be guided by the calcium classification and calcium score provided by these 2 modalities of investigation. Imaging following lesion preparation allows recognition of calcium fracture and to determine if additional lesion modification is necessary. And imaging should be performed post-stent implantation to document adequate stent expansion. Thank you very much once again, Dr. Kali and Dr. Ashok Sheth. Thank you very much for giving me this opportunity. Thank you very much, sir.
Thank you, Ajit, for your excellent speech. Superb speech, fantastic. It's a really incredible, and I thank you also for being present with us for a long time. Thank you very, very much for your excellence. Now I open the session for discussion, and Dr. Ashok being there, I would invite Dr. Ashok to lead the question. Ramesh is there, Dr. Subhash Banerjee is there, I think, Dr. Luca Testa, and Dr. Dawkins has also come. So, all of them are there. So I would invite Dr. Ashok Sheth to have some discussion on calcified lesion, which is an Achilles heel for all of us, the interventional cardiology community.
Oh, I think the talks have been tremendous. And I think I'm going to, get in my colleague chairpersons and panelists, firstly to ask their questions, and then we'd be able to comment. But this has to be a profound practical discussion, which I would. And you said that we actually had, I think we have our colleagues. Is Hazra there?
Yes.
So go on, Hazra.
Yeah, I mean,
your thoughts.
Fantastic talk. What about the Bresheau motion? Which one is the best? You had the BVS era, to what brings the Bresheau motion. It's not there anymore. But out of these three, orbital, rota, and shockwave, which one is the best to bring the Bresheau motion back in the native coronary artery?
And I can address that, Hazra, because these are adjunctive tools for calcification. The final answer is a metallic stent, a drug-eluting stent. Vasomotion of the vessel does not relate to the adjunctive tool. It allows you to give you the maximum MSA for good long-term outcomes. But the stent, metallic stent, will always cage the vessel. And the longer segments you actually treat, the longer metallic stents that you would put. So what it does is improve the long-term outcomes, both the short-term and the intermediate-term outcomes of the stents in terms of MACE or stent thrombosis, but not necessarily the vasomotion.
I think, Dr. Seth, I just wanted to bring in another important concept which recently Antonio Colombo is proposing. Basically, nowadays we deal with large calcified diffuse disease vessels. So instead of covering the entire thing with a long metallic stents, what is proposing is basically the tightest portion where you have critical narrowing, you stent it, and rest of the vessel was assessing with FFR, and the values were coming less, he left it, because some of these calcific lesions are immediately, though we look like less expansion, things like that, but immediate problems are somehow less common compared to acute coronary syndromes and thrombus like lesions. So what he proposes is basically assess the distal vessel by FFR. If the FFR values as a cutoff, what he was proposing was 0.8 or 0.9, whatever we decide on, and then follow these medicines, and you use a drug-eluting balloon just to patch up in the distal vessels rather than putting diffuse all the long, making them metallic tubes. What are your thoughts on that?
I have a huge respect for Antonio. He thinks a few years ahead than most of us. So this concept is tremendous, except that it still has to be proven. And it's Antonio himself who will present that data in a year or two to say that that's a robust policy. We know at the moment that that's a hypothesis, but he's always created hypotheses which have reflected our practices in the subsequent years. Let's see what he comes up with. So I think that but we've talked about the spot stenting even years earlier without the days of drug-eluting balloons. Now we have the advantage of FFR giving us an acute result which translates into outcome as a result optimization. And we also have drug-eluting balloon which decreases restenosis. But the concept of spot stenting started much earlier, even in the days of bare metal stents, when we knew that if we stented long segments, the restenosis rates were higher. But I'd rather like to get everybody back to the calcified lesions and to the practical aspects of it, because OPN was not discussed. I think there are nuances to IVL, which needs to be discussed. And I think, therefore, let's actually get back to the fact, and I'm going to ask Luca around this, and you all have experiences of ultra-high pressure balloon. So on one hand, Luca, we have IVL, which is tremendous tool for all of us. It's hardly got any learning curve. You saw the CAD3, there were no perforations. On the other hand, you have OPN, which is a lower cost, 1/5 the cost of IVL, balloon, which delivers ultra-high pressure. Where do you see the role of OPN in your armamentarium of dealing with calcified lesions?
Well, let me say that, of course, this is not the right place to discuss about the budget constraints, but I totally agree with you. I mean, the OPN is something easy, at least as easy as the IVL, because the IVL is really for it's for kids. I mean, it's just another balloon. However, I can tell you that at least in Europe, specifically in Italy, the cost of lithotripsy is a sky high. So in other words, we are all forced to use any other option, including rotablation, instead of using lithotripsy. So I have to say that the OPN, in my mind, it's something slightly more dangerous in terms of dissections and risk of perforation as compared to lithotripsy. Because honestly, I mean, using lithotripsy since 1 year, I didn't have a single complication. Not even one, but it's just my experience. It's not science. What I'm saying is the specific spot for OPN, in my mind at least, is those very short nodule of calcium where the use of rotablation is not a good idea because maybe the vessel is large. So at least I see my personal flow chart that if the vessel is large, there's no way to use rotablation because you need to use 9 French sheaths, 8 French sheaths, so it's going to be a problem. But if the vessel is relatively diffusely diseased and small, rotablation is still the answer. However, if you have an OPN or if lithotripsy is not that expensive for you, I see there is a big match, a big challenge. But in my mind, at least, and considering the budget, the OPN is first choice. If it doesn't work, lithotripsy.
Right. So Keith, what I was coming to you about is eccentric lesions. We all have eccentric lesions, and I'm being very practical in this discussion because it needs to benefit nearly 1,400 listeners or maybe 1,000 listeners who are here. Now, IVL is a very user-friendly tool. Very little learning curve. You saw, Keith, you just discussed that. On the other hand, is it there for everyone? Is it which would work in all types of heavily calcified lesions? Are there some lesions where it doesn't work? What are the nuances around getting the best results out of IVL, say, in a 4 millimeter vessel which has a heavily eccentric calcified lesion? Eccentric calcified lesion.
Of course, CAD3, Ashok, as you know, excluded nodules. There were a few nodules, but it excluded nodules and eccentric lesions. There is a small literature, not very much, not that robust, showing efficacy in eccentric lesions. I think we will have to wait for 2 studies. We've got a patient-level meta-analysis of CAD 1, 2, 3, and 4, which is 628 patients, which will have more eccentric lesions in it. And then we are bringing together the OCT studies from CAD 1, 2, 3, and 4, which is 250 patients, core lab adjudicated, same protocol, 3 scans on each patient. And in that study, which will be the largest OCT study published, there will be quite a few eccentric lesions and nodules. So we have a little information. We have bench data to show that we understand that it would work in eccentric lesions and nodules, but we do need more clinical data, and we don't have that right now. We'll have it probably in the first quarter of next year.
So as a practice point, would you say 2 aspects which I believe in my experience which help with eccentric lesion is, of course, greater number of cycles at that particular point is one that I believe in. Secondly, in the eccentric lesion, if you've got the right guide wire bias, then rotablate it so that you get the balloon closer to the calcification and perhaps get a better break of the calcification with the IVL.
Yes, I mean, I think, Ashok, as you know, I mean, there are a lot of tools, and we've discussed today quite a few of them, and none of them are exclusive.
Correct.
So what we're all trying to do with our algorithms and our experience and everything else is work out what the best combination of tools are for a specific patient. And obviously you do a lot of imaging, and OCT does really allow you to choose the tool scientifically, or the tools. And for example, with IVL, there have been rotor shock patients where they've been written up where you have rotablator plus shockwave. And I should just mention quickly the whole question of cost and reimbursement. this is a fairly new technology, and we're chasing down reimbursement in the various countries. And right now, of course, like in Germany, where there's a big rota use, it's not reimbursed. But we're going through the process, and it is a process in each country of getting reimbursed. So, we understand that. But I think the ease of use and the predictability does count for a lot.
Absolutely, it does. It does. Srinivas, yourself, please go ahead. Any other burning?
The other place where this OPN balloon is very useful, I feel, is instant restenosis, where a lot of us are worried to use atherectomy, rotational atherectomy, because of worries of stent starts getting into entanglement. And many other times we got bailed out by the usage of OPN balloon. But only one word of caution with this OPN balloon, as Sir was mentioning about perforation, is taking the optimal size of the balloon. You don't oversize. Probably you can quarter undersize the balloon and go to very high pressures. That's a good way to avoid risk of perforations and getting optimal results. I thought I would just highlight this point.
You're so right. And I'm just going to say it for the benefit of the audience who worry about OPN. I use a lot of OPN. And in fact, I use a lot of combination technologies, because I have a whole lot of cases where it's going to be an rotablator followed by IVL and finally followed by an ultra high pressure balloon to get the best results in heavily calcified long diffuse disease segments. Now, one of the things about OPN is unnecessary concern regarding perforations, because I can tell you that a 3.5 balloon, non-compliant balloon at 27 atmospheres is probably larger and worse than a 3.5 OPN at 40 atmospheres, because even the NC balloon grows more than OPN does. So it's so good and safer to actually go just half size down on the OPN and go to ultra high pressures. That's never going to give you perforations. What does give you perforations is size rather than pressure.
Ashok, what is your experience? Sorry, Prakash, you continue.
Yeah. What about the mechanical force of rota versus orbital, Ramesh, versus IVL and OPN balloon to the stent, implanted stent, like stent disruptions or stent ablations? What about the force, mechanical force generated, one versus another? Which one is the best? Which one is the highest? Which one is the least? Force generated inside coronary arteries.
Yeah, very good question. I think there's no doubt both with orbital or rotational, you're going to cause damage to the priorly placed stent. There's no doubt about it. I think so. Those two probably have the highest. I mean, obviously there is neoatherosclerosis, calcified neoatherosclerosis within the stent, but still, to get a best result, I think you will be causing some damage to the stent struts. The lowest one obviously would be the OPN and IVL. IVL actually hits the calcium behind the stent, and so it helps the stent to be expanded further. And obviously, I think probably the lowest one would be IVL in my opinion, because you are not going such a high pressure even with such a non-compliant balloon. So IVL goes at you can go up to 4 atmospheres and deliver the IVL.
Thank you.
I have a question on the OCT sub-study of this disturbed CAT3, where not necessarily you must have the fractures. It could be even the micro fractures, which could really give the benefit in stent deployment. In fact, there was something which was contributed by Dr. Hill yesterday. So I think, Dr. Ajit, you were showing that, when you do a post this thing, and you always need not see a fracture in the calcium. Micro fractures can also sometimes lead on to the stent expansion quite well.
Yeah, I think that's an important point. In CAD3, 67% in the OCT 100 patient sub-study showed demonstrable fractures. And then when you looked at the maximum stent area and all the various metrics, they were the same as to whether you identified fracture with OCT or not. And we know from micro CT studies by Renu Vermani on peripheral arteries that you can see microfractures in all directions. Some of them don't break the intima, some of them are out of plane, and therefore they're not all identified by OCT. But what you do see, of course, is that the balloon at low pressure becomes fully expanded when you crack the calcium. So it is pretty obvious without imaging, actually, when everything has become favorable for stent implantation. And just a note on the use of IVL in in-stent restenosis. Of course, there's a lot of interest and excitement, in some cases being written up, of IVL in in-stent restenosis. It is off-label, and there is a little bit of concern about if it's a very early stent, how the IVL is going to modify the polymer and the drug elution. And you can see on the bench with scanning EM, you can see some pitting of the alloy with IVL, but it can be very effective. And in the Shock India trial, you're permitted to put those patients in. So it will be very interesting to see the results of those in India.
Ashok, what is your experience regarding rotatripsy? Because in very tight lesions, you cannot pass the IVL balloon.
Okay.
So in those patients,
I'm going to address that, and I'd then ask Keith to follow that up with his comments. But before that, I just want you all and the audience to know, and Ramesh yourself, that the first in human study of orbital atherectomy happened in India. 14 years ago. I was one of the investigators, and that first paper, if you know, has been Keyur Parikh was the best enroller. We did 15 cases, Keyur Parikh and Milind Chagh, myself, and that was the first ever proof of concept of orbital atherectomy. So we've contributed immensely to what you are doing, and we haven't got it yet. Yeah. So getting back to that, we must understand that a significant portion of calcified lesions are uncrossable lesions. There's at least 2 angioplasties I do every week, which have failed elsewhere in a calcified lesion only for the sake that balloon did not cross. And therefore, rotational atherectomy does form an important part of treatment of calcified lesions. But there's another aspect to it. You asked me the question, what do you think of rotatripsy? And I don't just believe that rotatripsy gives me the ability to pass an IVL through. I believe that it actually gives me advantages in 2 or 3 different manners to get the best results of IVL. Firstly, for eccentric lesions or calcified nodules, if you have the right guide wire bias, atherectomy, rotational atherectomy, is the best way to deal with that. The second aspect is that if you create a channel, then you're not going to get in a collapsed and constrained IVL balloon into the site. You will actually, when you open the balloon will have some space to open. And that, I think, is very important for the emitters not to damage the balloon, but for the emitters to start working to create those waveforms to break the calcification rather than work on the balloon material, which happens in a collapsed state if you start emitting in a highly constrained balloon. And I was recently speaking to not just Keith, but some of the engineers at Shockwave, who gave me more insights into how this balloon works and how this can actually be more effective. And thirdly, I do believe that combination therapy gives you perhaps the maximum MSAs. Now, we have to prove that. There's no proof of concept yet. But rotatripsy is perhaps an important way to go in highly calcified, high-grade stenosis, long lesions, as well as eccentric lesions and nodular calcification. Rotatripsy is the way to go, not one or the other.
Ashok, if I can make a comment, actually, following the same concept, let me start just saying that I agree with you. But going to very practical things, I would say that sometimes the lithotripsy can be, replaced by the cutting. So the rotacut sometimes can be as good as the rotatripsy. So of course, in order to, let's say, provide a very practical message to our audience, I would say, look, depending on what we have, availability, budget, position, situation, imaging, there are several combinations. And of course, I will not say who's best, honestly. But I totally agree with you that there's no competition, there is combination. And combination can be with Rota and Tripsy, Rota and CAT, Rota and OPA, or Rota, I mean, several options, several iterations of these combinations. And it depends on practice and experience. I mean, in your hands, everything can work beautifully. But of course, in our, let's say, junior colleagues, fellows, residents, of course, it depends on what they are learning to do, depends on the learning curve and so forth. So let's stay practical. Let's stay, I mean, to the concept of understanding what is the real fabric of that lesion, because this is crucial.
Lucas, Dr. Hajra here, Dr. said.
I'm just going to comment before going. Yeah. Hajra, I'd love you to comment, and then I'd love you others to comment, including Keith. But Luca, there's one thing which has always puzzled me. In heavily calcified lesions, believe you me, the ones we actually, Luca, you know, the ones you and I say bad, heavily stuff, I tell you, be it scoring balloons, I think that's for mild and moderate calcification. I think we're overselling scoring balloons for heavily calcified vessels. And the same goes for cutting balloons. Following rotational atherectomy, you have some advantages of getting large MSAs. That has been shown in small study. But if you just try and put a cutting balloon in stuff that you haven't broken with a non-compliant balloon, you just don't break it. You just actually, neither can you get it through, nor can you break it. So I think we're practically overselling these cutting and scoring balloons, which are meant for mild to moderate calcification. And what we're talking about is severe heavy calcification, in which we have limited number of tools and options.
Yeah, right. And if I can, I would say that particularly in terms of trackability, these two devices, cutting and scoring, are honestly not as good as any available DES or balloon. So if we're talking about proximal lesion, very proximal lesion, ostial lesions, well, we can discuss. But if you are talking about the second diagonal, distal lesions, they will never get there.
Right.
Never.
Lucas and Dr. said, my last question, what about the physiological gain between rota, orbital, and IVL? Hypothetical and intuitive question here.
Well, if I can comment on this, well, yes. I mean, you need to, let's say, distinguish the philosophy behind. I mean, debulking means, well, reduction in the volume of the plaque. Cracking the plaque means getting a better compliance. So in terms of physiology, I suppose, of course, I got no proof of that, but I suppose that if you reduce the volume of calcium, the plaque burden, somehow you are actually getting back to, I would not say normality, because of course this is not the case. I would say to a more elastic arterial wall, to a more, let's say, more diseased arterial wall. What's the meaning in terms of MACE? I don't know. But definitely, if you are talking about debulking, well, let's go for rota or orbital atherectomy. If you're just looking at the compliance, well, of course, you need balloon-based devices. That's it.
So Ajit, Keith, your comments on some of the perspectives that have been put, and there's just Jabir as well. I think Jabir has been sitting. Sorry, please come in. Yeah. I mean, this is
also Dr. Rajiv Bhagavat. He has been
Rajiv Bhagavat is there. Yeah. No, please. Yeah. They're the ones to comment and ask and put the things into perspective. I hope I don't mind these discussions, because these are like sitting in a drawing room and talking to each other.
Yeah. Exactly.
You got to tell when we stop, okay?
Yeah, okay. You continue for some more time.
So Jabir,
I want to ask Dr. Ramesh a question. So you were also commenting on that. We don't have an orbital atherectomy, though you started with orbital atherectomy. Unfortunately, we don't have the orbital atherectomy with us. But when we see a diffuse heavy calcified lesion, always there will be multiple nodules. If we don't get a wire bias, how do we manage these things?
Yeah. I mean, I think as Ajay was mentioning earlier in his talk, always take a picture with the wire in place and look at the wire bias. And you might have to do multiple long calcified nodules. You have to probably go and ablate at each and every spot that you can get to. there will be some risk for ruptures, but for perforations. But that said, in a large trial so far or in large registries and small trials, so far the risk of perforation is less than 2% with orbital, which is not that bad. So I'm not so sure that in such calcified eccentric nodules that IVL will be able to achieve all the results that we want to, and still rota and orbital will have a role. So the most important thing I think actually Luca was talking about is all these are ablative technologies, and how by combinations the cost of the procedure is going to be really extreme, huge. And I think we need to be cost effective in the delivery of our care as well. So I don't know what is the best way, maybe, and starting with an OPN might be the best way, and going for other technologies. I also am just posing the question to all the other panelists as well. And cost is, I know for for India, it's a big deal.
Yeah.
And is there a way by which we can decide on certain factors by which, if these factors are present, of course, I'll go ahead with OPN. And if these factors are not there, or if these are the factors, I'll not opt for an OPN, I'll straight away go for an IVL. Because here, once you rupture an OPN balloon or the OPN doesn't work, you have to spend the money on OPN, then you have to go for another modality like IVL. So always, India, we have these financial constraints. So, or somebody was telling like financial toxicity. So if your one gadget fails, you are in trouble now. So
I think the financial constraints exist practically all across the world. And that's definitely there. The important thing to understand is that we have a number of technologies available to us, but the final answer is that we're dealing with very difficult patients. You give them a suboptimal result, they do very badly. And you yourself know how many patients come back to you who've underexpanded stents, who actually are in a huge problem, and you are in a huge problem as to how to treat them. Correct? And that's happening all across. Personally, I think that these algorithms are overdoing. I mean, they're taking you through imaging everybody, deciding. I mean, by the end of that algorithm, I get confused as to what to do, actually. It doesn't guide me as to what to do. I'm pretty confused as to what to do. I start thinking that I know how to get a good result. By the end of that algorithm, I'm not sure how to get a good result. Okay? But there's some science in those algorithms which you need to pick and then apply in your practice and say, I'm going to get a good result because I know that these factors tell me what to do. And then I have the ability to use X and Y. The guy can't afford it. He's not got reimbursement. By the way, Luca said the right thing. Rotablator followed by ultra high pressure balloon, which is half size less at 40 atmospheres. I don't think we've shown that it's anywhere inferior to doing a shockwave lithotripsy.
Yeah. No.
We haven't actually shown that half size higher balloon at 40 atmospheres is probably safer than optimal size non-compliant balloon at 26 atmospheres, because that can perforate your vessel, but a half size large. So I think there's a load of missing links which we have to learn to apply in our own practice.
Yeah. But thank you for your valued comments, Ashok. Yes, Srinivas.
Yeah, one broad guideline for everybody, for the youngsters to use and learn maybe is, as we understand, as Dr. Seth said, we all know that for very heavy calciums and we want to have the best results, SW shockwave, we will use it. In between, somewhere we use OPN, and the more milder ones, you just get away with using NC balloons.
Correct.
Absolutely.
Yeah, in India, we can have some comparative data where OPN versus SWL, even in relatively heavier calciums, because 50-60% of those cases we can get away by doing OPN, which is less costly than SWL.
Yeah. Dr. Ashok. So kindly short comments from Dr. Shuni Banerjee, Dr. Rajiv Bhagavat, and Dr. Kajal Ganguly. All are waiting for long. Yeah.
Correct. I would, just before we go to them, I would just say that shockwave India would give us the best aspects of understanding the extreme calcified lesions that we actually need to deal with shockwave, because CAD3, etc., could actually have lesions which we could have dealt with, even ultra high pressure balloons or even non-compliant balloons. So I'm not sure whether that data is truly representative of saying that's the way to go for shockwave. So again, we're coming back to practicality versus what? It proved that it was safe. It proved that it had very few complications. Where is its application is probably heavily calcified lesions, where heavily calcified concentric lesions in large vessels. So now,
Ashok, Dr. Ghulam Azam is waiting. He's from Bangladesh.
Yeah, Ghulam Azam. I think I want each of them to have comments, their questions, and I'm therefore now going to keep quiet unless they address it.
No, you continue. It's nice to listen to you, Ashok, my great friend, So, Dr. Ghulam Azam, are you there? Dr. Azam?
Can you hear me? Is also waiting.
Can you hear me? Yeah, we can hear you. Thank you for joining us. Yeah, he is the president of the Bangladesh Intervention Council. Nice to meet you.
Thank you. Nice to meet you all.
You get a lot of highly calcified lesions. Your food is very good for producing highly calcified lesions. So we'd like to listen from you. How do you manage the issue?
Right. Yeah. I must say first, you nicely organized such a wonderful meeting, and this meeting give us a lot of learnings. But one thing I'm telling you, in calcified lesion, actually every modalities have every unique indication to use. We sometimes see confused which one is more better than other, but we have to customize and we have to decide which one is appropriate for our in every cases. But in especially, can I ask in Ramesh Yogavati, when he nicely said orbital atherectomy and rotational atherectomy, actually when we go for eccentric calcium, in that particular situation, which modality you prefer?
So I actually prefer orbital in those patients. I think definitely for eccentric calcification, because of the orbital nature, it would definitely get that calcified nodule or lesion. That's my preference. And I don't know whether Luca or anybody else has any comments on that.
Well, I would like to have as much as experience you have, but in Italy, the orbital atherectomy is not available. It's not available in Europe, I guess. So none of us has enough experience to say, but I understand your position because, well, with a rotablation, I mean, it's likely that if you really have a nodule, where using rotablation will not ablate anything. So that's likely. But with with those elliptic movements of orbital, of course, you may anticipate that you will really debug something. But again, I don't have experience, but I understand your approach.
Right, yes.
But same to me in our country, in orbital atherectomy and IVL also not still available. I know Dr. Ashok Sheth very well. We are trying to introduce in our country very soon. Hopefully, we'll get it permission from our target.
Yeah, a few months, few weeks, you'll have it.
Thank you very much.
Thank you, Dr. Azam. So, Dr. Rajiv Bhagavat, are you there, Dr. Bhagavat? Dr. Rajiv Bhagavat, I think he has left. He was waiting for long. Dr. Kajal Ganguly, Professor Kajal Ganguly, you have also left. So, Dr. Shunip Banerjee, are you there? Dr. Shunip, you do a lot of rota. Dr. Shunip, all has left. So, Ashok, Ashok, if you permit, because the organizers and the team of who are the behind the scene, the technical team, they have been request me to wrap up the session, and I think that it is one of the best sessions today. And I am especially thankful to our international guest, Dr. Luca Testa, Dr. Keith Dawkins. Thank you very much, Luca, and we'd like to have you, if possible, tomorrow. Please give your valuable comments to both of you and Dr. Azam as well, because we'll be together. As Ashok told, we are in the drawing room, and we have been listening to Ashok's very, very practical, long experience, comments, and it was a learning lesson for all of us. And it was a beautiful session. So I thanks everybody, including the technical team and more than 1,400. Yeah, Kajol, you have appeared, it seems.
Yes.
Yeah.
I'm very much there.
Yeah, okay. So, any short comments?
Thank you.
1 minute comments. We want some comments from our professor.
Thank you, the speakers, for a beautiful deliberation, and the delegates for beautiful interactions. We have learned a lot.
Thank you very much, Kajol. And I would also request my good friend Ashok, join us tomorrow and give us your valuable comments, great experience, great expertise. And, Srinivas, our ex-NIC chairman, Dr. Ghulam Azam especially, you have joined from Bangladesh, and Dr. Hajra. So all of you, please join tomorrow and give your valuable comments. And it's actually a drawing room session, as Ashok has told. Ashok, thank you very, very much. So please allow me, Dr. Devabrata Rai, are you there? Dr. Rai? I think he is very tired, and he was instrumental in getting this great meeting, And I'm thankful to all of you, to all the delegates, and to the technical team and the industry as well for their massive support. So we'll be joining tomorrow at 3:25. Ashok, I'll be expecting you. Dr. Luca Testa, Dr. Keith Dawkins, Dr. Azam, Dr. Ramesh Dagubati, he has given three lectures. Thank you very much. And one extempore one, because, he was speaking on legend, so legend speaks. So Ramesh, I will be expecting you throughout the session tomorrow. And thank you very much, because you are a very busy cardiologist, I know, but you have given entire time from 3:30 to 10:45, I think you have given the time. So I thank you, everybody. My sincere gratitude, my regards. Please accept it and let me allow to wrap up the session. Thank you, everybody, and good night. Very good night. Tomorrow we'll be meeting at 3:25.
Thank you.
Good night. Thank you. Thank you, everybody.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Always a pleasure. My pleasure seeing you.
Thanks, Ashok.
Thank you. Thank you.
Okay. Thanks. Chalo. Leave for. Thank you. দারুণ মিটিং হয়েছে, ফাটাফাটি হয়েছে। আমাদের পিস নেভার আসেনি, কিচ্ছু আসে যায়নি তাই না? কিচ্ছু আসে।
Sir, this is Raghu. Can I close?
Yeah, Raghu, you can close. Yeah. Sorry, we are little.
No problem. I hope it was okay today. I hope your connection